coming from and what's my background will be helpful. Please hear and settle. So, how have been the last 2 days? You survived? It's not easy, isn't it? So, I'm a clinician, so um, don't keep too much of heavy stats with me. I'll take you through. I'm more of a methodologist, I'm not a statistician. I'm a full-time clinician who is very keen in RCT. So, RCT is my forte, randomized controlled trials. And I've been with Cochrane for last 17, 18 years. So essentially, the Kap sir, who's our mentor, has trained us. And way back in 2006-7, I got this Cochrane bug that we call this. From then on, trained us, and then we moved on. So I worked with the editorial board of Cochrane for the last 10 years. So I worked with the editorial board in the gynecology and fertility, which will cease to exist in a couple of years because Cochrane has moved on to something different in terms of the way it's going to function. So we are the last of those. And yeah, things have changed. So it's a little more different than what I'm used to, but whatever we have learned probably still is quite useful. We're going to keep it very hands-on. So what I'm planning to do now is next couple of hours. So we'll go slow, and I'm going to take you through risk of bias one, which is uh, the main, I think, the basic platform on which the rest of things come in. That is risk of bias two, and then a bit of non-randomized studies, of course. That's where we will stop. And then I think we have a lecture of introduction on NMA, which is between 11:15 to 12. And after between 12 to 1, we will use a practical session. Um, if I find that it's getting difficult, we can do a practical session before, maybe around 10 o'clock or something, but we'll keep that as things flow, we'll change the flow. And it would be good if it's interactive, because otherwise it gets a little boring. So, how many of you are dealing with randomized trials? We've had some experience with randomized trials because that is very crucial to understanding this. Pratap sir is here. Some of the slides are his slides, so let's acknowledge that. So we will move on to Mr. Bias. And feel free to ask any point of time if you feel that not clear or so. You all know we are in an early stage, and it's good to ask here. We have enough time, we can go slow. There is no commercial conflict of interest. Of course. So the topic that we'll be looking at in the next couple of hours is why we actually need to perform risk of bias. So the way that workshop has been planned is that I think we've got an introduction moving. The first day, the second day. I think by the time you are here now at this stage, you have done through the protocol. You got familiar with the software, got till there. Now we've kind of looked at, let's say you've moved on and got your studies. Okay, we are stopping at that. That is, you've done your protocol, and then you've run through the search, and you've got your studies. You are included study, let's say 5 or 10 of them. That stage we are right now on day 3. Today and tomorrow, what essentially is being done is we are assessing these studies in terms of quality. And then tomorrow we are probably using those studies to do the meta analysis. So that's how these 2 days will pan out. Finally, of course, you will move on to grade on the day 5 and eventually complete the review. That's the flow of the workshop. So today is all about checking the quality. So why do we need to do this? Something that is worth looking at. Then we will basically focus on how do we do this. So the steps of risk of bias is very important. As I mentioned in the initial stages, this is mainly workshop is focusing on randomized control trials. We're not looking at the other studies like cohort studies and case control or diagnostic tests. I especially would probably stick on to RCTs because that's my area of interest and expertise. It's very good to have people who have done work in that particular field and are able to speak because we can be more hands-on. I don't want to be theoretical here. That's why I would, but we will give you a flavor of non-randomized trial listeners. That's how we're going to go forward. So keeping it interactive, I think these many of these the presentations we had probably refined during COVID. So if I just ask you on this, that let's say you have a you had this fast processing of COVID vaccines during the pandemic, and there are randomized trials that were performed. As a clinician or person who was involved in taking care of patients, what do you think can be an impact if in a trial the investigators or the people who are allotting the patient to a COVID vaccine versus control, how do you think can impact downstream in the healthcare? Like, how do you know whether the follow up is going to be different or the way you are going to treat that patient is different or the patient's behavior will change? Do you think it's going to have an impact if it's an open label trial? You understand the word open label essentially is no blinding, and that is typically it could be a problem. So, what do you think this random do you think could be an impact? If somebody, let's say, take a COVID drug itself, forget the vaccine, there's a drug, and it's not a placebo controlled trial. It's the arm where people know who's getting COVID drug and who's not getting a COVID drug. But yeah, so that's like you could probably give it to the sicker patient. So there could be a bias in the way you are, randomizing the patient. So if you are worried about that patient who walks in, and you feel that that person can be randomized into a control arm and may not benefit, sometimes we might just push the patient off and not, even though the patient is eligible by screening, we would still ensure that the patient does not get into the trial. That is because you're worried that the patient might get into the control arm. Yeah, that's sometimes like a pre-selection. But even let's say if the patient is in, do you think the behavior will be different for the clinician and the patient? You think the suppose that you are aware that that sick patient has got into the control arm. What do you think can happen downstream? You'll be more worried about this patient. Probably you'll call for more surveillance, ask more vigorously for the symptoms and signs and all. So there'll be something additional beyond the intervention. And the patient also, if she or he is aware that she or he hasn't got the COVID drug, that patient is going to be really cautious in his or her behavior generally and use the mask and so on and so forth. So there can be some changes. These are all examples of bias. If you ask me, this typically, if you name the word, is performance bias. Okay, but this is just an example of how trials can introduce bias, and then it might not reflect the real world. That's what we are looking at. So this is an example where you are now worried about this. But if the trial was a placebo controlled trial and you could not identify who got the COVID drug and who didn't get the COVID drug, no matter what your behavioral change as a clinician or a patient, it will not affect because it will be equal on both sides. Fairly simple to grasp as a clinician or a healthcare person that the behavior is going to be same because you can't identify. So that's how trials have to be planned in a way that we can't eliminate bias. We can only mitigate it. We can only reduce it. Okay, no trial is going to be perfect. There will be issues. There will be biases creeping in. We can only reduce the bias at each stage, and that requires a lot of planning. So what are we trying to do is we are trying to see after the end of the trial whether the evidence that we are coming to, whether it is what is the real question in our mind. It's like whether this drug A is working on it. Okay, there are two interpretations here. One is The drug A could be significantly better. That's what we are using the term, but it might not be significant in terms of clinical, outcomes. So try to understand this. It's like if you have a antihypertension drug and which just reduces the blood pressure by 2 millimeters on an average, mean, and is still significant. It's as an end user or a healthcare provider, it might not be a very clinically significant finding, but statistically it could be. Okay? But overall, that's what you're trying to do. You are finishing the trial and you're trying to figure out if drug A is working or not. So the whole problem here is how trustworthy are those findings? At the end of the trial, uh, what we call it internal validity. How trustworthy is this trial? That's what risk of bias in some ways is going to attempt. And we can introduce bias at all stages. The first one is design stage. So when I gave an example of open label trial, where do you think the problem started? Is it design stage or execution stage or reporting stage? Design stage. So people haven't thought this through, or they have constraints in terms of logistics or funding and so on. The placebo control trials typically are quite expensive. It's not easy to get an identical placebo. And sometimes it's just not practical, or if you look at surgical trials, you can't come up with a placebo, or a sham procedure. That's always going to be difficult. So it could be a bias could be introduced right at the initial stages. To go at execution, the way it is being done, there could be issues at that point of time. And finally, there could be biases introduced at reporting, the way we report the results. So there could be certain results highlighted more than the others. And finally, the investigators might focus on certain secondary outcomes instead of the main outcome. So let's say if the COVID drug was to look at survival, and all they found was survival wasn't really improving, but the ICU admission was slightly lower. And the investigators finally report that this is a fantastic drug reducing the ICU admission, but the survival hasn't really improved. That's what you and me are interested in. So there are a lot of ways of reporting, but there is a standard way. Usually you will report based on what? What is the final conclusion is based on what? When you're looking at a randomized trial. Primary outcome. Primary outcome always gets linked to the sample size. So essentially, these are all linked. Our aim is to answer that question, and you're looking at primary outcome. So each specialty will have their own outcome of interest. There could be so many surrogate outcomes. Like I come from a specialty treating infertility. So for us, we do IVF quite a number of times, and we are interested in is live births. Okay, now there are many ways of judging the outcome of an intervention. So in an IVF, it could be just a pregnancy sign, that is pregnancy positive. It could be a pregnancy clinical, that is at 8 weeks you see an ultrasound and you see that okay, pregnancy is there. And then there could be a live birth, which is the final outcome. What is my patient interested in? Live birth. Just trying to say pregnancy rate is not good enough, because there'll be at least 25% miscarriage rates and so on and so forth. So across the world, this is all it is. It is about which outcome are we picking up, and it should be as much as possible picked up based on what our patient and I am interested. Not around. So what happens many times in trials, we kind of use surrogate outcomes just to justify the sample size. Okay, because we know that if you use the primary outcome, the difference is very small and the sample size is becoming bigger. So then people who know the system, how to work it out, will start looking at a surrogate outcome and try to uh, get a sample size which is convenient, and you can get the study moving. You can convince the funders this way or that way, move on. So remember that the way we report also has an impact. So external validity is of course different than internal validity. So basically validity is all about whether this trial is trustworthy in terms of the final report. That's what we are. External validity is about whether the trial findings are applicable to us. So let's say you have a drug or a trial done in a different population. Okay, it could be the Caucasian, UK, US, or in our population. How applicable the findings of that study are. So one of the issues that at least I know, at least in our specialties, most of the data that we are looking at is from the Western world, and it may or may not be actually applicable to us. So that should be a worry, and this is something that is taken in consideration when even we are looking at the final review findings. Sir is going to discuss grade tomorrow, so day after. So how much of the finding, one trial typically cannot be applied to the whole world's population. Now, if a trial is done in UK or a US, and you want to take that evidence and say this drug is not what it is, because it's a very small subset and changing practice. Remember, what are we trying to do? Always remember that we are trying to finish the systematic review and feed it into the guidelines and apply this to our population here. So be very careful of where the evidence is getting generated from. So there are issues about external validity, but internal validity, as I said, is what our focus is. How valid, how trustworthy are the results of this particular trial? That's what you will be doing in your systematic review. So I'm putting in the context again. Got your protocol, you got your included studies in. Now you are sitting and assessing them with how trustworthy each of these trials is. Now, let's say 10 trials are there and only 2 are trustworthy and rest all have issues. When you do a final pooling, where do you stand? Is a question that we should probably think of. Okay, I'll take you through this at some point. Okay, so some of the terms I'll just simplify it the way I have understood. We are looking for bias, which is systematic error. And essentially, what it does in the simple word is, let's say that you introduce some kind of bias and it will just shift the point estimate towards one side. Okay, so it is, let's say it is the effect is around 5%, 5% benefit. It will just shift it towards 20% or 15% and so on. Goes towards one direction. That is systematic error. Okay, so that's what we are looking at. I'm going to ask you your. Now, this is typically how a forest plot will look at. Now, this is a hypothetical situation. And the question I want to ask here is, you have 2 trials and you have one favoring the intervention and one is favoring the control. This is not exactly representative, but which one is a bigger trial here? First or second? First is this one. Okay, I think it's a bad design. I got it wrong. So essentially, I was trying to show is I think the box is looking bigger. Well, essentially, the sample size of the second one is much larger. It's a very narrow confidence interval. The second one is a larger sample. I think I got it mixed up, but the point was not that. The point was, let's assume the first trial is a small trial, okay, and the second trial is a very large trial. Now you tell me which is favoring the intervention. First one, yeah, because this is on this side, this ratio of 1.3, and the large trial is not favoring the intervention. Okay, it's favoring the control. So now when we pool the results, the pool result is 1.3. Tell me now, how do I interpret this? Should I tell the end user is patient or it's the clinician, whoever, that risk ratio 1.3 with good confidence interval going other side of unity, 30% increase in whatever the outcome is, favorable outcome. Do I tell them go use the intervention? But that's what you're telling. Like, this is what tomorrow you'll be doing is this only. You are going to combine these things and come up with this. Is there a problem with this? Is what I'm asking. There is a problem because We are now confused. One trial is telling, and this is typically going to happen. Most of our trial and interventions, one favors one side, the other one sits on the fence, and one more goes the other side. And all you are doing in mechanics is you are pooling it and coming out with a magic number, which is a final pooled estimate, we call it. So, is that estimate trustworthy? We are worried about it in this sense. I would be worried as well. So, why? Because we have a poor quality trial and a high quality trial. How did we make that judgment of high and low risk of bias? No, poor quality. How did we do that? So we did risk of bias. How do we assign that this is a not a good quality trial and this is a high quality trial? That exercise is what we are going to choose. Okay, then we can decide. Now that we identify, let's say 10 trials are there, only 2 or 3 are good, and the other ones have all issues, then we can have other mechanisms in place to account for this problem. But if we don't identify, then we are not doing the right way because we are just pooling them together and presenting. So, some poor quality studies are typically known to, drag down the whole evidence. So there needs to be a mechanism to address this issue. But for that, the first thing is identify the problem. And that's what risk of bias we are doing. Okay, we can, there are ways to go about it. I'll discuss that. Once you identified how you can, come up to a solution in terms of helping our end user. Who's the end user? So typically now, if you see in Cochrane and all, there is a PLS, page plain language summary. Okay, and this is typically done, and it is now becoming more and more a mandatory part of many journals as well. That because what are our patients doing? Get more information before they come to us. They Google and make life difficult for us because Google has everything there, confuse them further. So this plain language summary is probably an attempt to give them a clear idea about where things are in the language. And when you make, it's quite a difficult task to convert medical jargon into a simple plain language. So I had one on endometrial lining, endometrium, that's a uterine endometrium. So I had to convert the lining of the uterus, things like that, so boom, yeah. So it was quite a task, but that's what it is. But the effort is empower our end user, and typically it's not us, it's our patients. Okay, so remember always that that's what the idea is. So bias can occur, as I said, in all these 3 stages. Typically, the first one is design, and that's where most of the effort should be there. At least I can tell you, I've been guilty of spending very less time on design because the way we were trained, we had to cobble up with the trial quickly, the PG thesis or whatever. I had to come in, and people have 1 or 2 sessions in the department, and we say, okay, this is a worth going in trial. But believe me, it takes a lot of effort to tweak a trial and design it and look at all the aspects, because once you take care of all these design issues, the way it will pan out, how the patient is going to come, whether patient has to be called again and again for the trial requirements, then there's a problem. No, you get what I'm saying. So if you have patients or participants of the trial who need to make that extra visit for the trial, what do you think is going to happen? Compliance will go down, attrition will go up. Okay, so typically we will keep a magic number of 10% attrition or a 20% for a longer trial, but invariably it will cross 10%, 15%, it could be 20%. We did a feasibility study on a lifestyle intervention, and our attrition was 50%. Okay, which was not surprising, considering that lifestyle intervention is not, that's been the issue. But we wanted to check the whole feasibility study or a pilot study was done to check out what was the attrition, because then what can you do when you do the trial, when you plan the bigger trial with this kind of attrition? Just telling you how much thinking has to go in to ensure that you don't get in problem at the execution stage. So essentially, I would just probably, for interest of time, I'll keep giving what we did. So what we did is we ran a parallel qualitative study. Okay, and all those who were falling out of radar or refusing to participate or were partially compliant or non-compliant, we took an interview-based study as well, and we figured out that most of these people were, they thought that they were basically not overweight or having weight issues, and they were perfectly fine. So they didn't even recognize that they had an issue. The trial was basically on polycystic ovarian syndrome, and we are trying to introduce weight reduction as an intervention, and that becomes the first line in all the guidelines, but it's never been proven that it's helping. Okay, so but there was so much of resistance for this that we really wanted to know. So armed with this information, you can tweak your protocol and try to, one of the things was patient could not travel again and again. So what we did is we tweaked the whole protocol in a way that they were, whenever they're required to come for their normal medical treatment, we combined the trial requirements. So they didn't have to make any extra visits. Okay, that way we were trying to ensure that the attrition rates are not as much. In fact, it's an ICMR funded trial, and currently the attrition is around 10 to 15%. It's a 5 years trial. So that's how we actually try to ensure that the planning stage issues are settled and we don't land up at execution stage, having a very high attrition and so on. So you can see this, that every stage you need to look at this. How do you measure the outcomes? How do you analyze? So do you think measuring outcome is an important issue if you are doing a multi-centric trial? It could be, the way we measure. So for this trial, we are measuring weight and the height and stuff. So we've got the same instruments to measure from the same company. All the blood tests are being done by a central lab and things like that. So that there is uniformity in the way we measure. Okay, because there could be issues there. And of course, the way I said, interpreting results and reporting results, because all these stages we are going to assess any trial. So typically the steps now, this is more about hands-on. So it has to be done by two independent reviewers. So two authors have to do it. So typically what we do is, once we have studies, we have the data extraction form. We will have all the data, and then we will have the risk of bias table below that. Okay, and two of us will be doing it simultaneously. Okay, and of course you can use now Providence and stuff just to keep track, but I'm just going on the manual mode, just using Word format. And then we do it in a predetermined criteria. As I said, it can be done along with the data extraction. So this is something that we need to understand. The most important and critical one is selection bias, and this is where the problem starts. And then, of course, you have, as I just gave an example of performance bias, uh, where people, if they're not blinded, it can lead to a lot of differential care. Then I mentioned an example of attrition bias. People are dropping out in a skewed manner, more in the intervention group than the control group. Then there is the way we measure. If it's a trial which is involving pain and things, how we are measuring, there could be detection bias because of that, the way it is reported. So these are all stages that now we'll go step by step and assess each of these domains, and definitely with some examples we can think of and take it from there. Eventually, when we do this kind of green, red, yellow graph comes in. It looks very fancy. It's all done by the software. We don't have to really worry about it. Okay, all we need to do is just populate the risk of bias. Everything else is done by software. It generates the figure and everything. So that is not something that we need to worry about. We will probably take you through this filling up of the Redman desktop version as a practical. And of course, in the afternoon, this will be done as an ROB2 as well on the web. But of course, that we need to figure out how we'll do it on web. So I'm going to use 3, 4 examples, at least three different specialities. This is my specialty of reproductive medicine. So many times we have patients who are. This was a trial we did where patients have been advised. Couples have come and the male partner has an issue with low sperm count, and typically they end up with IVF. We call it ICSI, but that happens 6 months down the lane because we have a long waiting list. So many of the couples wanted to have some medication or other. Most of these antioxidants are empirical. There are no clear evidence to support that. Okay, but it's so commonly used because there's a general tendency from everybody to help. So let me just give off antioxidant because it's believed that it's harmless. So we wanted to check an antioxidant therapy while waiting. So we had an arm where we gave antioxidant and no antioxidant in the other arm. And as I said, typically our outcome is LIBA. So it's a very simple thing to decide. Then, of course, I could use a COVID example, susceptible population, let's say COVID vaccine or a drug. Then you have a placebo, and you can look at the rate of COVID infection. This was, again, I think, the alternate medicine, endometriosis women. This is just to look at the pain as an outcome. So we had, to assess one of the trials which was looking at yoga. So hormonal suppression is the standard of care. So it will be difficult not to have the standard of care. So the idea was the PICO here would be hormonal suppression on both sides, that's intervention and control, because it would be quickly um, problematic not to give the lady any drug. So the standard of care definitely is OC continuous. And people wanted to see if addition of yoga would probably make pain free better or the quality of life score and so on and so forth. So keep these kind of trials as an example while we go through each of these domains. So I'm going to start with selection bias. Uh, Now what we need to do is, I'm going to give you an example as well. So essentially each domain we are assessing, and where do you get the detail of these uh, you know, domains. So let's say selection bias is basically randomization and allocation concealment. Where do you think I'll get that information from? Study design. Anything else? Where do you think, suppose you're taking an article out, method section. That's where they will actually mention how they have ranked. What do you think typically is written there? What do you think is typically written in many of our studies? They just write they were randomly divided into 2 arms. Okay, that's all you have to work with. Okay, even in conference abstracts, okay, you have word limits and so on. But in good articles, the good many of the so-called studies of randomized, all that you can see in the method section is that population was divided into intervention and control randomly. Now you have to make a judgment call. It's a very problematic approach. So I'll take you through that. But before that, I just want to probably give an overview of what we are trying to do. Selection bias is typically you're looking at, whether there is a difference in the baseline characteristics, the way, because randomization, especially a proper a sample size is okay. It's not too small. Normally try to balance off the confounders. Okay, so typically if you are looking at, let's say, I use the endometriosis example. Endometriosis can be quite debilitating. Okay, and some of endometriosis has grades. Like there's one which is mild to moderate. There's one severe endometriosis, and some of the ladies have real problem in terms of quality of life because of coexisting conditions. There is something called adenomyosis and so on. Now, if you are doing a randomized trial and you have a situation where some of the women with very severe endometriosis are falling on one side, that is intervention, whereas in the control, most of them are mild to moderate. Do you think it's okay? It is not, because you have given a disadvantageous position to the interventional group. Okay, so the idea is, if the randomization has been done properly and you have enough numbers there, it should balance off. That means that the severe endometriosis group should be evenly as much as possible on the both sides. Otherwise, we are giving an unfair advantage to one group. Okay, so people who have severe endometriosis, they might not improve as much, and if they are on a higher numbers in one arm, that is intervention, let's say, you might say that the pain score hasn't improved much, and control and so intervention basically not working. That's what we end up saying. So that's a problem. And this should not happen if your systematic selection bias isn't there. That is, you have done your randomization process correctly. Yeah. So, so a lot of times, at least in initial phases of my career, I used to ignore the table number 1. What is that? Yeah. I was guilty of that, and now I focus only on the table number 1. Because that's where you will, and most of the investigators, even the integrity issues are grouped into table number 1. That's where people identify there's a problem in this whole part. So please look at that. So selection bias is 2 aspects. One is randomization, another one is allocation concealment. Performance bias, I have given you a glimpse of what it is. Essentially, what blinding and everything else is that, other than giving that extra intervention, nothing else should be different in the 2 arms. That means we should not be offering some extra testing or extra visits or be more directly connected with the patient. That's what performance bias is. Only the change between the 2 arms is that addition of intervention. Now, if you think about, let's say, as I said, the COVID example I gave, if you are worried about it and it's an open label trial, you are likely to do extra because you will be in your mind slightly more, I would say, worried and concerned for the patient who have fallen into the control arm, and you might make that extra phone call just to see if patient is doing fine. And that is a bias. Yeah, that's what performance bias is looking at. So whenever you're assessing performance bias, think about this. What is that extra that investigator or the people involved in trial might end up doing? That's what is the question that should be in our mind. Attrition bias. So I'll of course come to this. Let's say you have a cancer trial, and drug A is the intervention, and drug B is your standard of care. Drug A is working really well. It's really good in terms of survival, but it's very toxic. So out of 100 patients randomized, 50% drop out. They just can't tolerate the drug. It's a common situation. Whereas the standard of care is not as effective, and you got a full compliance. 80 people survived the whole trial period, but the survival was lower. So how do you actually assess this interpret? How do you interpret this? Because remember that if patients are falling off post randomization, they are to be accounted in the analysis or not. What is that analysis known as? Intention to treat. So even if patients haven't completed that intervention, they will be in the denominator, and the numerator will be definitely less, because 50 of them who dropped out, we are assuming that it's not effective. That's the assumption that is done in intention. So what do you think as a trialist? How will you interpret this? Our protocol obviously might show better results, but what do we conclude our results on? Our main results mainly are concluded on based on which analysis? Typically, it's intention to treat. By default, ITT is the way forward, that is closer to the real world. Per protocol is more about effectiveness, but when you introduce an intervention, it's more closer to real world, because that's how it will pan out once you start using it in a practice. If 50% are going to drop out in the trial, they are very well going to drop out in practice as well. Okay. So how do you interpret this results of this trial? The drug really worked well for those who continued, but then if you, how do you conclude? There's a problem. That's what I'm trying to say. 50% attrition in one arm and maybe 10% in another arm makes it attrition bias in some sense. So what could have been done better? How could we land up avoiding this situation? So typically trials run through pilot, the phase 1, 2, 3. So this can be the phase 3. So before that, in phase 2, the drug tolerability, whatever the data is coming out, need to be very clear that there is a lot of toxicity and we need to find ways to address it. If you ask me, the way forward is do a pilot or a feasibility study to see whether we can reduce this kind of problem by giving additional support to the patient for the symptoms that they have and ensure that they comply, because obviously if you tell somebody that if you are able to make through this drug you are going to survive longer, it is not very difficult to motivate them. Yeah. So but the point is we can't land up with this 50% attrition in one arm and 10%. The whole trial goes into problems. So that's attrition bias. Detection bias is again the example of yoga and endometriosis. What do you think we should do? What will you think if somebody is like, I practice a certain thing and let's say I practice yoga and I feel it's working for me. Yeah. Reducing my stress. You can see the stress levels are hitting rooftop nowadays. So essentially, I feel that doing yoga is reducing the stress. Do you think if I am the assessor of the trial and the trial is open label, how do you think I'll be assessing the ladies on yoga? The pain score, no? Do you think there's an element of bias there? Could be. That's detection bias. Okay, typically subjective symptoms need to be, see, that problem is not there for my specialty, generally IDFL, because we have yes or no. It's a pretty straightforward live birth. You can't really have any subjectiveness. It's clear cut. Similarly, like survival or no survival is yes or no. But the problem starts when you have, if let's say you do a surgery and it's a drug given to reduce blood loss. So I use an example from my field, my myectomy. And you think you can you can reduce detection bias in this case. It's a drug which is given intravenous around the surgery time. And the surgeon, patient is under anesthesia and there is no drug being given or an IV given on the other side. Do you think we can we can eliminate the detection bias? Surgeon will know that this drug is being given. There'll be a performance bias because he will or he she will become different in terms of surgery. So if he knows that this lady hasn't been given that hemostatic drug, he or he is going to be very meticulous in the all the hemostasis maneuvers. But do you think we can reduce the detection bias? RTMS. Yeah. Yeah. Here, the way you would do the surgery would change if not placebo. Similar, yeah. Let's say it was not possible. Can I reduce the detection bias? The person who is assessing the blood loss can be blinded. So it's not the surgeon who is assessing. You can always tell a third person not to, he or she will not be aware of the drug given, and all that person has to do is assess. So that's a good example. It's just that I don't know if that procedure, the way you assess the outcome, the person can be blinded. But the example I have given, the person can be blinded. So at least detection bias can be mitigated. Yeah. Okay. We can, start thinking crooked and start thinking that person who's assessing also may figure out and all that. But we don't want to go that far. In normal circumstances, this is possible to mitigate detection bias. Reporting bias, certain outcomes are highlighted and certain outcomes are not. How do you think we can figure that out? Yeah. So what can typically happen is many of the outcomes, actually it's pretty straightforward. If put it in the clinical trial, you have to tell primary outcome is this, and these are your secondary outcomes. End of the trial, when the results are published in a manuscript, sometimes you find the whole focus is on something else, whereas the trial was planned for something else, which is problematic. Yeah, because many authors believe that only significant results carry a lot of weight in terms of world of publication. It's not so. Um, if the trial is done properly, it's a negative trial, it's fine. And editors, if they are good editors, they will give cognizance. But typically, the positive studies tend to get published more. I agree, but that's not the way science should be. We should give credence to the right way of doing things. Yeah. So reporting bias, of course, as rightly pointed out, you can get a lot of clues from clinical trial registry and the way it has been focused. Yeah, so I will probably giving that kind of an overview. Now I'll quickly go through each of these domains and take up the time. Yeah. So this is on random generation sequence. So I have mentioned this already. I'm just now going to focus on what kind of methods are allowed to make a judgment. This is again adequate, not adequate. So typically, when I was doing trials, early stage, we were going by those words called computer generated random numbers, sealed envelopes, and so on. Are you familiar with that still? Yeah. So we go to the biostats, they generate the numbers, and then we put it in those sealed envelopes. 1 to 50, A, B, whatever the combination, and it's put in nice sealed envelope and done with it. Now, what are we doing today? If you have all the resources, and we are supposed to be the IT world, center of the world, what is the better option? Web-based randomization, right? So what do you think is the problem with this date of visit in the OPD? Yeah. Also, you might get little biased if you feel you are worried. You run the OPD throughout, or let's say Monday, Wednesday, and Friday, and the other group runs it on Tuesdays and all. The patient is sick and all, and you feel this person is going to land up in trouble. You can always shift the change the date. Or second is if it's a hospital number, even ones go into one arm, the odd ones go in another arm. These are all quasi-randomized trials or pseudo randomized, we call it. They're not truly randomized, and it has to be avoided. Why? Because what is the problem with using even and odd numbers? If the hospital number ID is serving as your randomization, the even and odd, what would it be? What is the problem? Let's say I'm an investigator and I know even are falling in intervention, odds are falling in control, and a patient comes with an odd number. Where do you think the patient is going to be? If I'm worried about that patient, yeah, so I will be worried. I will just, probably not screen that patient only. No, there can be a lot of ways to avoid if I'm concerned about, because I will have my concerns as a judgment. See, typically, many times also remember in our scenario, the head of the department decides this is a trial which has to be run by the department. All the consultants don't really are into it. Their heart is not into it. They don't believe that this is okay because they are worried about certain things. But you as a consultant have to go by what the department or HOD says. There can be problems in that. You have a biases. and we will be worried about putting a patient in a particular arm, you realize that this odd hospital number is going to land this patient into a problem. There's always a chance to shuffle around, and that's a problem with these kind of methods. So interestingly, like one of the Cochrane's, we wrote to an author. So you get smarter when you start doing these reviews and you become like an investigator, almost like a police investigator. So earlier we used to say, have you randomized using computer randomized or whatever? Then we said, how did you randomize? Those kind of open-ended questions. This person very uh, nicely responded. We randomized based on hospital visits. Automatically, that trial was out of Cochrane because we can't go by pseudo-randomized trials. So these things matter, but just what I'm trying to tell is there are different ways of randomization, and certain ways are acceptable and certain ways are not. Okay. So typically, non-randomized trials overestimate the effect. The other simple way of putting it is if it's showing 5% benefit, it starts showing 50% or 20% benefit, and that's not where the truth lies. We will never know the truth. We can only get closer to the truth. That's the way it looks like. So now I'm giving you a screenshot of some of the Revman examples just to make it clear. And you can see here. What do you think? How should I interpret this? Children where this is quote unquote taken from a study. Children were randomly allocated to 3 regimens. What should I assess it? Was it randomized or not randomized? Actually, it's yes, it's low risk, unclear, or high risk. I don't have clear indication to suggest that they have done the wrong way. So I'm not clear. I'm not got enough clarification. So I'm putting it under unclear risk. Yeah. Where do you think these answers are given? So it's pretty clear. But you can see here that they have mentioned computer generated or a web based randomization used. So I have parked it under low risk. This is how it will come in the RevMap. These things are already by default there. We will have these drop downs. You can see here. Okay, whatever. This is where the drop downs will be. But we need to do this in the data extraction form. That is, we pluck out from the method section what they have written, and we can quote unquote. Okay. Sometimes I get worried on this because now, like the recent Cochrane, people said too much of similarity score should not be generated and so on. So I started, of course, you can use quote unquote or try to just rephrase it the way it is, because this part is problematic because we can't quote unquote too much here. So I use my own words to say that. This is more important, and many times this is an ignored area, allocation concealment. People are okay till they say, okay, we randomize it. But people are not very clear many times of how they have executed this randomization. Yeah. So typically, this is where I, as an investigator, should not know who's going to get what in the next, whoever participant is coming. That's what, keep that in mind. I have the stack of all the codes, 1 to 50, they are serially arranged. Okay, clear. So you have let's say you have randomization for 100 participants. Your statistician has generated A, B, B, C, whatever the A, B combination in different forms. The first participant comes, I take the first envelope, randomize, open that envelope and randomize. Okay, whatever it is, A or B. Understand? But I will not know what is there in the second envelope. That is participant 2. I will not know. That is allocation concealment. Yeah. Remember that this is not there when we are using, I mentioned hospital visits and even not, because some person comes with an even number. I know this person is going to get allocated to the intervention. Whereas in a real allocation concealment, you open that envelope, it's B, you have to allot to B. Okay, and you are going to open it serially. The first participant, first, fifth one, fifth, you can't, course, you can start thinking crooked here also and put the fifth one back and open the sixth, the seventh till that person gets A, and that's what you want. But that's again, as I said, benefit of doubt is given to us as medical practitioners that we will be true to what we are doing. And in fact, we are made up to sign so many statements and ethics and so on, just for this reason that we believe that we will be doing this with the right intentions. So basically, it's preventing the order of recruitment. Is this any of these things uh, possible in a web-based randomization? So in web-based randomization, what happens? It's very clear. You come, the investigator will feed in the unique ID number of that participant. So I have a trial with thing. So I'll say 0002 PMC. So we have 5 arms, so 5 sides. So we put 001 C PMC, and then I just punch in the button, and it will say intervention. Next participant comes, it's controller. And all this data is recorded. You can't change it. Okay, so currently, if you ask me, if you have good funding, this web randomization is what we should. In fact, my CMC's data management cell, which is responsible for the web randomization of our trial, generates the whole one sequence of how many site people, how many were randomized and which arm and all, everything is clear. So nobody can really fiddle around with that. So the current gold standard is web-based randomization, so that I am not in any position to control or change the order. So these are, as I said, state of what is acceptable as sequentially numbered identical drug. The first one, what I mentioned, web-based randomization. What is not acceptable is sequence and known to the staff. Person knows A, B, C, D, how it is coming, and you would know that this person is going to get the next one. That's not acceptable. So look for these kind of details in when you're looking at the methodology. And remember, this is one detail that is most of the time missing in the methodology. People just say we randomly allocated, or they say we use web-based, or they say centrally generated sequence. That is not adequate. That is just to generate the sequence that you're taking. How did you allot that participant to each of those arms is what the problem is. And it has to be very clear. This part needs to be clearly mentioned. And if it's done the right way, people will write it. But if it's not done the right way, those either out of ignorance they have missed it, or they haven't done it the right. That's all. So currently the way the world is moving in terms of research and integrity and issues, if you don't mention it, it is assumed that you have not done it. Earlier, when we were, in our nascent stage, benefit of doubt was given. If you don't do it, probably you will ask for a clarification. But now the assumption most of the times is that these guys haven't done it. Okay, and it's very difficult to pull back. So I would add a note here on now. At least I have noticed a lot of trials now are not only getting retracted, some of the trials 10, 20 years down the lane, also people are going and investigating and asking for clarification from authors. And authors, of course, you don't have the data now. So what is coming as a disclaimer down below is expression of concern, EOC. That means that the editors and other people have investigated, and these trials, there are some issues which the authors haven't been able to respond to in satisfactory manner. And the problem is they can't retract it because there's a valid reason 20 years down the lane, nobody will have the data. But then they are writing that people who are going to read these articles, please note there is an expression of concern. This is a new thing that has happened in the last 1 year that I know. And also, all that is because these kind of details are missing. So, okay, it is acceptable 2010. Before that, things were not so rigorous. But ask me if you do a trial now, and if you don't have these details, it's simply not on. Okay, the editors will just look at it. If you notice now, there's a lot of desktop rejection. The trials just don't move forward. Editors are noting all this. Moment they see there's something even doubtful, they will not let it go forward because it's a lot of headache. Because if this trial slips through, later on it will come back to the editorial in the journal, and retraction on the editor's dashboard is not a good sign. So I, as an editor, would not take a chance at all. I rather play it safe. So just a word here. There is a difference between allocation, concealment, and blinding. Blinding is about after randomization. If once the intervention has been allotted, we don't confuse this with allocation concealment. Allocation concealment is not the randomization. We need to decide. We don't have any control who's getting what. Once the intervention or control has been given, after that is the concept of blinding, not before random. Just remember this demarcation, not to confuse allocation concealment with blinding. As I said, allocation concealment is a list. We can't take it off, but blinding is something that, as we discussed, is not possible for all the interventions, especially surgical or procedure related. There are ways to get about this, but it's not possible. So this is again an example, not very difficult. You can see no details were provided, but central randomization was done. And you can see that, electronic pill dispensers and so on and so forth. They had the whole infrastructure in place. So there is no reason for us to doubt this. It's a low risk. Whereas here, uh, each main investigator had an open list of randomization. The whole list was with that investigator. And whoever came, they knew who's going to get what. So participant number 5 came, they knew whether that person is going to fall in intervention or. So remember, if they just worded that we generated a computer generated sequence and allotted the participants, and they don't tell you this part, how will you judge that? You got my point. In the methodology, they just say they generated the sequence, but they didn't go on giving an example, actual details of how they randomized. That is, how did they, prevent this allocation concealment? They gave them, they didn't give the detail of allocation concealment. Then there's a problem. Okay, so try to read this. So we had a problem with this. So we write to the authors, and the authors respond, yes, the investigators could know beforehand. They committed that they knew what was the next allotment. With that, as somebody said, the person has committed that they did this, so now there is no unclear risk, which is a high risk. Yeah. Yes, sir. Yeah. That's the whole idea, sir. So first, so basically the thing is, you can only plan the trial. So getting into trial is fine. Patient will not know which arm they are following. Even the investigators won't have any control. But yeah, they have to agree to that. Yeah, that is the. So the answer is that. Yeah. Yeah. So that is typically the problem at recruitment, sir. So basically, the problem I would say to add. No, once they are in trial, it will go on either side. But they should agree to be randomized to either of the arms. Otherwise, if they don't, that's why it is written willing and informed consent. Now, the problem, as you rightly pointed out, is nowadays a lot of interventions are being introduced without due deliberation, and which is the phase 4, all those things, and they are on the internet. Now, this patient, if she goes and Google thing, she will not get into the trial. She will say, I don't want to be because I might fall in the placebo. And that's the problem of clinical researches. When many of the things are introduced and they're already on the net, participants not agree. So that is a thing that can't do much about. Point is that the thing is that extra is going to benefit or not, that is not a no. We need, that is the clinical, what I call it as clinical equipoise. I should be convinced that there is ambiguity. No, like you and me should be clear that adding that extra is not clearly going to benefit her. So that's why we are launching this. As long as clinical equipoise is there, we are clear that in my practice, at least I know now, most of the times I tell, I don't know whether this is working or not. And also trials, the trial participation in entirely. We don't know, sir. That there is an equipoise. That's a larger debate, I would call it. It's not something that we can, but what we can say is a lot of trials are being conducted the right way, and people do agree that that culture has to percolate. But you and me, as an investigator, definitely need to be convinced that there is a role. I would give you just one example on that. Entirely agree. Yeah, yeah, this is yes, this is pharma-driven trials do have that. Yeah, yes, sir. It's an industry-driven trial. Okay, sir, the thing is how to conduct and the feasibility. That's what I said. See, trials that we, at least I know, the smaller trials are not the right way. The right way is first, that's why, as I said, we have to go to feasibility studies. Then only we launch these big trials. How many of the patients will be agreeing? That's what I gave an example of. And the thing, what I would say is, if you as an investigator are convinced that there is equipoise, you tell the patient, we don't know. This is not, this trial may not benefit you at all, but it might not harm you also. That kind of a discussion. And as you said rightly, who's going to explain that this is what the trial staff is all about? We are trying to run trials of PG thesis on this. This is not all. I am busy, you are busy, busy seeing the OPD, and then we expect to randomize and give that. That's simply not on. If we are trying to do a trial, do it the right way. Get the ICMR to fund your trials or whoever it can be, and do it with trial staff. We can't do these kind of trials where I'm the investigator, I'm the HOD, I'm the clinician, I want to operate and then go and randomize. That is simply that's what the problem is. So that culture has to change, if you ask me, and that's where the thing is. But yes, most of the patients might refuse if they know that they are going to go. That's the problem, and that kind of creates a pre-selection bias. I want to add that.
Entire result of the trial will depend on whether it was done in the way that they said it was done. One thing to keep in mind, the question you're asking is about real life patients know something, they may not take part in the trial. They've tested this. They've done empirical research, and it's, in my opinion, if you look at the consort flow diagram, if you find that did not take part in the trial, there is nobody who refused because they refuse consent. I don't believe that. Because it is human nature. People, if they're given adequate information, some of them will not take part in it. It's not practical for them, or they're afraid. trial involves changing the existing treatment, the washout period, there are many people who say, I can't afford to fall ill again. They will not take part. All that is very well. But what we are looking at is this is a risk of bias. So we know from other empirical research, if you don't conceal allocation, chances that your results will overestimate the benefit from the intervention is pretty high. Sometimes it may underestimate, we don't know. So what we are saying is, if this method is done properly, then for this domain, there is very little chance of bias being introduced because of this part of the trial. So when he says high risk, it doesn't mean the result is flawed. Risk, and we have to evaluate beyond that. Second thing, even if you randomize, you get consent, if people or they consent and you do allocation concealment, it doesn't mean that patients don't believe they are not getting the actual treatment. Research shows that even if you blind, educated people also overestimate the chances that they actually got the treatment rather than placebo. And that will influence their subjective outcomes. So what people now do is people ask people before the trial, you are going to be randomized, but do you have a preference for each? And they will note the preference. And they'll ask them at the end, which arm did you think you got? They will match that preference. They'll correlate with their outcomes. All of this changes the results of trials. But anyway, one is talking about the risk of bias. And for that, you need to have some kind of structured method of evaluating the risk. All of this is true. Also true, because when you're assessing, one more thing, when you're assessing risk of bias, if you look at the trial, and if you look at consult, one of the questions consult used to ask is, you should test your blinding. You're saying it is blinded. So in one of our trials, I asked my student who was doing the thing, you guess what that patient got. Right. And that will expose the investigator's bias. So this first trial was either you get antidepressant drug, or you get counseling, or you get both, or you get nothing. So when the investigator found the patient is doing well, automatically they thought must be getting both. Actually, then what you do is you do a kappa, interrate between what investigator thought they were on and what they actually got. So there are you must look for all of that. Yeah. Yes. Yeah. 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 That's what. That's problematic trials with 20 and 25, or even the other way, block randomization also can, you will have a fair idea. At the end of the day, no, we don't want to become detectives or don't trust our people. Even if you do block randomization of two or four, you will know that at some point this person, the third or fourth person will get intervention because you've exhausted the other two. Block you have to balance every four or six. So there are those issues, but we live with that. We can't, really make it. Yeah. Good. It's generating some discussions. Thank you. Um, so we are just moving on to performance bias, and now I think with this discussion is quite clear that blinding is something that difficult in many circumstances, and I would probably give the example of an antioxidant. So it's quite commonly used. So the men are convinced that that antioxidant is going to do the job. So what can you imagine? You can imagine what's going to happen for the person who is not fallen into the intervention now, and he doesn't get any drug. What do you think this guy going to do? Very common in India. Over the counter. Over. Right. So this was one of the comments from our peer reviewers for this trial.
that how did it is called contamination. Basically, the control arm also will get contaminated. And you can argue the other way that even if you do a placebo and this guy really gets worried that he or if you give placebo, he'll still go and buy. So we don't know because that guy will be worried that he might be in the control arm and go and buy antioxidants. So there are no, but now you can't really start policing this guy out. So there are the limits of this. Like I was planning this dietary study, and people are like, "How do you monitor dietary adherence?" And there were various discussions going on. At some point, I said we'll have certain, FFQ and things like that. So one of the statisticians who was a purist, he said in our trial, we actually supplied the food, everyday food and all. Now, that is an extreme thing. In real world, I said we can't start planning these kind of trials where you're going to start, because I can't replicate that in real world. So there is a limit to what we can do. Um, that's something that, so open label trial. So if we say this is an example, as I said, it's an example for, let's say, a pain trial. If it's an open label, we have called categorized as high risk for the reason I have mentioned. And if it's a paid trial and you have a placebo control, they are decision low risk of performance. Yeah. So I'm going to again, we have looked at this again. Open label, high performance bias. But you can see here there's a slightly different situation. It was like, I think, for our trial where the outcome was light bar. So we said it's a high risk of bias for performance. Yes, the guys can go here and there, but outcome we can't really have subjectiveness in life. So for detection bias, even though it's an open label trial, we have put it as low risk. Okay, so please understand there are small distinctions here, even though blinding study might not take it. So attrition, again, we have given an example in the cancer trial. I have given you an idea. If we have too much of attrition in one arm compared to other, then there's a problem, and it can eventually, it could be very disheartening for the investigative team. You land up with a trial running over 4 5 years, and you have such a high attrition that you started with a clinical equipoise and you land up with what is the chance of something working when you start, even before a trial? Now, normally 50-50 is. I start a trial trying to say drug A or drug B, which is better, we don't know, it's 50-50. End of the trial is so badly, gone that you don't find any difference and every result is biased because of so many issues. Where are we standing after 5 years? The same. We really don't want to come down to that. Do a trial the right way, even if you don't find significant results, at least you can say there is no evidence or insufficient evidence to suggest that it's working. Now, there are ways to word your thing, but trying to run trials which are problematic, end of the day, doesn't make a wiser. That's a huge loss of resources. Your patients are subjected to unnecessary interventions, too much of money and time gone. So please be cognizant of these things. So we can't have such high attrition and jeopardize the whole outcome. So always remember that normally some amount of attrition is acceptable. How do you? Okay, now I move on to the next one, that is incomplete data. How do you figure out that that the data is all complete? These are, so if you find that some data is, let's say they have randomized an n number but followed up a less number. So are you worried about that? They have randomized 100 on each arm, and then they finally report outcomes of only 70 and 60. You worry about that? They need to account for all the missing participants. What happened to that? That number has to, I mean, 100, okay, 30 went, why they dropped out, what were the reasons? Everything has to be captured. We can't, suddenly feign ignorance for that. So if you have, people are, writing reasons. Okay, they missed because they moved out of the city and all. There are reasons which are acceptable, but if you have other reasons, there's a problem. So remember that many times if you have 100 randomized and all 100 followed up, is it a good trial? So you have 100 randomized, let's say for a drug in cancer, all 100 after 6 months to 1 year were there, all the outcomes are reported, which is the oh, it's in there, it's a bad drug. Yes. Because it's something it's not for manipulated trial. This is the thinking that now because of grown up. But earlier it was like me using data, everything is perfect. Perfect word doesn't exist. Okay, and if people are writing this, they are getting exposed because today nobody is going to trust that. And the moment they lose that trust factor, that trial will not go forward in communication world. That's something that we clear. So look at this attrition. So essentially, you see here, this is a TB drug, and you can see here that 52% attrition in the INH regimen arm, that's treatment arm, whereas the combination, the other one was 18%. So that's a very high attrition, and it can't be explained. So it's been categorized as high risk of. Yeah. So that's last couple of things. That's reporting bias. This is again, it's a good place to go and check is clinical trial registry. So, how long do you think the trial registry takes to generate the number in India? I think you people have outlined with that CPRI. For us, typically it takes 2 to 3 months. So, what do you think when you are registering? What do you think you should take cognizance of? I have done that. Many of my PGs register after ethics only you can give. No? So when you feed that clinical trial registry data, what is one thing we should be careful of to ensure that it's not retrospectively registered? Sorry? Yeah, projected date of enrollment. Yeah, that is, we commit that this trial will be on the 1st of November. We submit in July. Hopefully, you should get your answer before 1st of November. Now, if there is a delay and you project a very ambitious, you submit in July and you put 1st of August, and those guys reply on 25th of August, they'll put it as retrospectively registered and it will jeopardize your chances of publishing the trial forever. No, unless you find another way to do this. So be cognizant of these small issues. We've had issues where we had a 5 year running trial, 2013, but for some reason there was a 1 week delay and it came as retrospectively registered. And but then we argued it out with the editor that it's a 5 year trial and just there's been we gave a documentary evidence of enrollment on such and such date and the registration was 1 week later. And they accepted that. But that was 2013. Now we are in 2024. Life is tough. Right? So be aware of this. Yeah. So please go to the. No, I think that will be problematic. You won't be able to. You'll have to, I think, then re-register that remaining part. It will be difficult to salvage that situation. And the system is not responsive enough to address this issue at individual level. So I would be worried about that. Yeah. And one of the things that we need to be careful about is post hoc analysis. That means that once you found the results, you start looking for something significant, and also you've never committed in your protocol, but you start looking at some ways to find out. And this can typically happen in drug industry trials where they haven't found something useful, then they'll start looking around and doing post hoc. So the way to look forward is you have protocol is always available. So selective reporting, you need to look at all this. Most if it's now if you don't have a protocol and it's a little fairly old trial, but it has reported everything that you would expect it as a subject expert, then you can still give it a go. We are not being very strict here. So if something is done in 2010, 11, and I find every outcome that I am interested in is done, and they have very evenly presented everything, you give the benefit of that. Yeah. But if they don't present it the way or planned or expected ones, then you're worried on this, and it can be low. Now, so this is an example. It is prospectively registered. See the statements. All pre-stated outcomes were reported or provided by some of them. They don't report all, but if you ask the authors, they give you the reports or the outcomes. That's fine. Whereas in some cases, it's unclear. People are something as an expert you would expect it to be reported, and they have not reported for reasons, and they're not able to give a clear reason. You can park it under unclear risk, but that is something debatable. And this is something that is becoming more and more of an issue. This is the last one, which is other source of bias. I think this is Sir's slide where this was about, I think, a different thing. This is about, I think, more about publication bias. I would right now just tell you that this I'll come back later. I'll just complete the. Okay. The other risk of bias, this is, I'll just go back. This is problematic area now where a lot of people are investigating, and because they don't fit into the other six domains, a lot of people are looking at these kind of issues, and ROP2 starts taking cognizance of all this. Imbalances in baseline, and then um, premature stopping, possible fraud. There's so many things that are happening. Trials getting stopped much earlier than on the projected sample size. So all that is an area where we put it as under resource to bias. So that again can be because of the reasons that I've given. I not put in there. So many times trials are stopped when the people find results are significant and people want to just stop at that. If it's just a random chance that is significant, they'll say, okay, enough, stop. You don't have to go to 300. That's incorrect because it could happen that if they reach 300 and they find the results are not significant, the truth could be somewhere else. So those kind of, if they are not able to justify the stopping of trial, then there is a problem. So this is just an example probably of a publication bias that a lot of trials and data that is there in the with the regulators simply doesn't get published. So if you look at this particular, let's say an example of an intervention which is published in literature, 94% of the trials, there are like all the trials have to be registered with FDA, let's say 100 trials, and only 50 get published. Yeah. And then that 50, 94% of the trials say this drug is working. Whereas actually you go to FDA and check the data of all the remaining trials which never made it through, and you then figure out of how many trials really it showed working and how many didn't work. You'll see actually 50% were positive and 50% were negative trials. Those negative trials simply didn't make it in the public domain. And you and me as an end user are wondering that this drug is working. Almost every trial that is published is telling that. But in reality, many of the negative trials haven't got published. And that is one of the issues. So if as a reviewer, you are supposed to go and chase this data, which is many times with the drug companies, we don't get it. That's one. There are a lot of PhD students here. Yeah. It's very clear what is the difference between how it is related with outcome. Because that is the critical point here. So I think everybody is clear about the difference between the bias and confounder and how it is related with the outcome. Is it clear to everybody? If it is not, please clarify now itself. Because that is one of the very important things that I have found. Most of the students are actually not able to understand. I think nobody is saying means it is very clear to everybody. Can have a go. Basically, what is happening here in trial, the basic philosophy is you are having an intervention and you are thinking this intervention causing that outcome. Now, in randomization, you are actually distributing
between the two. Now there are certain variables which are accounting for certain which are not able. There may be some variable which is directly related to the outcome. There are some variables which are not related to the pathway of the outcome. The classic example is, sir, is that suppose tobacco and you are doing a trial on development of lung cancer, and you also collected the data that how many of them coffee, and then at the end you found that people who are drinking coffee is having a more incidence of the lung cancer compared to that those who. So is it that coffee is related with that? So that is think about that. So these are very important things when you do a regression analysis. These are factors which come into, like if you think that Cox proportional third model, you take this variable serially and account for that. How do you exclude those values? Is where your clinical judgment comes in. So I think that should be very clear in understanding and analyzing the trial.
I'll just tag in and then the RB2 and yeah. So this is how typically it will look. So whatever you have made those judgments, finally, let's say you have 10 trials, you will reach here. Once you feed the data of 10 trials, you generate this graph, and you can see individual studies as well that how the more red you see, you're happy or the worry. Okay. And what eventually it will do if you see too many of reds in the quality of evidence, bring down the quality of evidence. So be very worried about these things. If you see too many reds, you are okay with greens, sometimes a bit of yellow. Especially yellow should not appear in the selection bias domain. Finally, how, as I said, first initial stage itself, the whole idea of this exercise is to identify high quality trials. And once you segregate that, what to do with it, you have a lot of mechanisms. First is you kind of exclude trials of poor quality from the main analysis and then see how the results are. Then, of course, we can do sensitivity analysis. So, there is a paradigm shift in the way, at least I can tell in our specialty, what was happening earlier was the results. First, we used to present in the abstract and primary analysis all the trials, all the 10 trials, whether they are low risk or high risk. We used to tell everybody that this is your final pool analysis. Now, in the protocol stage itself, we write that primary analysis will include only high quality trials. Okay, and all the whole review is based on this primary analysis of good trials or low risk of bias. And part of sensitivity analysis, which is an exercise I'll explain, we just pull the results of all the trials and present somewhere in the result section. But the whole primary analysis will include only high quality trials. That is a good way because in abstract it will just show the results from high quality. It will not show full analysis of all the trials which have problems. Earlier it was the other way around. We used to show the pool analysis of all the trials, not good and good together, and then do a sensitivity analysis and see whether the results are not changing when you are restricting to good quality trials. Now it's the other way around. We suspect there's a problem, we just take them trial or we just keep the good trials in and keep them. These are like examples of in forest plot what you can do. These are, trials with concealed allocation, they have done the right way. And then you kind of compare these results, whether they are changing or not, the not so good quality and so on. So there are ways of doing this. But as I said, the first point is trying to segregate the good versus not so good. So you can see this is again an example of meta-analysis. You can see there, this is the trial. The first one has got a lot of reds there. So right now you can see here, this was a screenshot of a red man. You can see that the results are being pulled by these three trials. All I need to do, you can see here 0.93, 0.79. Sorry for the small font, but now I'm not happy to have this trial. What I'll do is I'll just take off that trial. The tick is gone. What is happening is now we have results from only reasonably okay, they are not higher. So because the full results are only from this. Now what I'll do is this result, this result in the same direction in points. If they're there, then having this problematic trial hasn't really changed the physics. That's what it is. That is called sensitivity analysis. Yeah. So we will show this in the practical, not to get too worried about this, but just that what is happening, what is the impact of the whole exercise that you have. So you will land up with the problems like this. This is a forest plot. You can see here that this diamond is favoring hysteroscopy. But actually, if you see here, there are two landmark trials published in Lancet, which are all green. What are they showing? They are sitting on unity. They are not showing any advantage. So the pool results, this is typically what I showed you the first and you land up with pool results are showing intervention is favored, but the best trials, the landmark trials, did not show benefit. How do you actually phrase the answer, final conclusion? So I'll just tell you how we did it. Problem for us was two of the authors of those landmark trials were also authors on this Cochrane review. There are a lot of disagreement in how we will write up the conclusion. Both said that we did such large trials and they did not show any benefit. And now we are authoring a Cochrane which is showing benefit based on results which are of problematic trials. And this is something that we needed to work around. So finally they said in women undergoing IVF, no quality evidence showed that it may benefit, but however, the pool results from the only two high quality trials did not show benefit. Simple, because Cochrane will not recommend any intervention. Okay, it can only give you the answer. It is left to the judgment of end user how you want to take this. I am just taking the last line, whereas many would just take the earlier line, that it shows to justify. But that's what the problems are, if you have a lot of trials which are problematic. So finally, this is what it will all lead to. Sir will be speaking on grade on Saturday. Where does risk of bias come? This is a grade output. Then see that grade actually gets fed by risk of bias. So if you have a lot of problematic studies, there are grades 4 levels: high quality, moderate, low, and very low. Moment you have a lot of trials coming in with problems, eventually this will get downgraded from you at the highest pedestal, that is high quality, to level you downgrade high to moderate, moderate to low, and review is when you know where it is heading. Okay, so many of us would realize that if you have a lot of problematic trials, even before you finish the conclusion, even if it's a significant result, it's a low quality evidence because we don't trust that evidence that much. There are trials which we give the reasons for this, and you can see here very serious risk of bias downgraded by 2 levels. This you'll understand when Sir takes grade because there were some problems in the selection domain itself. So this I will not touch now. I'll just close this and just move to the final 15 minutes on ROB2. So the take home message for this ROB1, which is the main basic platform for judging the trials, is experience with randomized trials is something that is very valuable. So that's why first question I asked here was how many of us are conversant with all the aspects of risk of bias trial, randomized trial, because if we are conversant with everything, the methodology, allocation, concealment, blinding, attrition, and all, it becomes easier for us as reviewer to judge the risk of bias. Many times I have noted, like I know a lot of reviews, Cochrane reviews are done by MBBS graduates in of the European countries. They are the first or the second author. They don't have a clue downside of what actually is happening downstream, and that can be a problem. So that's why as subject experts to be there and running this. There is some degree of subjectiveness. That is something that we can discuss during practicals. You can say that what I would feel unclear, you would feel low risk, and so on and so forth. That becomes less and less as you move towards ROB2. But right now, even then, there is some subjectiveness. And Remember that risk of bias is basically an exercise for quality of study. We're just saying that it's at risk. As Sir said, it's not a final judgment on the trial. It's not like this trial is flawed. We are just saying it has got a lot of issues, and we are not convinced that it has been addressed adequately. It could still be telling the truth or closer to the truth, but we are not comfortable with it. The problem, as I clearly highlighted here, is pooling of high quality and low quality studies. And that creates a lot of problems at the end. And as I clearly mentioned this again, currently the Cochrane, at least the group that I work in, is only interested in presenting the high quality trial results as the primary analysis. So dubious trials and fraudulent trials are being skinned out, problematic trials and poor quality trials, they are just falling in the sensitivity analysis. I'll probably stop for a couple of minutes. If there are questions, I'll take 10 minutes for just taking you through, argue with you the practical part and stop for question. Any questions at this point? We have 20 minutes. Yes. Yeah. But it depends upon what outcome we are looking at. Again, not an easy answer. Um, I don't know, you could probably have to think of and how to mitigate it. I won't say it's going to be a problematic trial. It's just that there will be certain risks, like say, infection. How do you actually blind that? At least I can't do the preference bias, but detection bias, I'm not sure it will work out a way to detect it. Yeah. How would you take that, sir? Can we reduce that bias? Yeah, somebody else has to. I think the way forward would be you would have a clear objective parameter when you trigger off the detection curve. That's the only. Yeah, and these are the things. Then you would send a slab or something. Yeah, yeah. That is one only thing. Where to trigger off that test is where the problem is. Also, if there is a subjectiveness in the way, okay, you are worried about that and you will send, or you might not send. That decision, the test obviously can be blinded. I think the problem would be her assessment when you take it. That's where, no, but that what can be done is it can be clearly laid down as objectively as possible when you are going to trigger off the testing for blood or pus. But even before that, you might, trigger off saying whatever. That it can be objectified, but there are limits to it. But having said that, even when there is some risk of this, you still need a trial. It will give you some evidence and then we can move on. But not having a trial itself is a problem. That's what I would say. There are limitations to what we can do. Yeah, that also. On. Exactly. Yeah, we know that. See, it's a little difficult to come up with a solution suddenly. As I said, the most difficult part is deliberation on planning stage. That we have to take it, and there are people who are very good at this. So now I can tell you that there are MSc clinical trial people who just plan and work on these difficult topics. I would still say that it may pan out to be the that, but there are, ways to, it's not like automatic choice that you're going to become high-risk. You will have to go through the algorithm. That's what the algorithm, the ROB to. You may have to make a judgment call. Is this, there is an element of bias coming in or not? And at some point you might take it, no. The surgeon is going to be really objective in the way he or she is going to say that. We want to give that a credit point to the guy. He is going to be honest and not be biased in his incidental in Zuma and the other one he will not. Yeah. There are ways. That's what I would say, sir. In risk of bias too, you can probably look at that.
What is the outcome you're assessing? Is it a objective outcome or a subjective outcome? An objective outcome, you have to see, I mean, subjective outcome, like, think it's infected or not. Suppose you think that. If you find out, if they write that this was done by an independent assessor who did not know this. If they said that, no bias. They didn't say that, then they have to make this independent assessor. So you have to think about it, say, X-ray result. What is an X-ray result? Is it an objective or subjective? Yeah, so the question is, who did the reporting? What that the person who did the reporting knew what intervention that person got. Those things you need to know. So if they say this was reports were read by independent people, panel, said they didn't know anything about it, they also have to agree. Then you know there's no problem. You have to think about how they did it. Point is that you need to have a whole infrastructure backing up and not just come into a trial. And that's what happens most of the time. Because I think that we can't do much more. That's a good point. Take quickly. Just quickly, I'm not going to the ROM to fully, just to introduce that how things are a little more complicated. So how we run the ROB2, it gets a little difficult, but then what are the fundamental changes that are there? So I have just 15 minutes, so I'll just take you through what is done. Why does it need? It is basically as anything else, just that people start improving on methodology, like we have improved in drugs and surgeons and all that paraphernalia that we have now. Similarly, in research methodology, they realized that ROB1 had flaws. And if you ask me, I have clearly mentioned here what the problem. The problem was that lot of judgment was unclear bias. We were not able to commit on low risk or high risk. When you have a lot of yellows in that graph, then it kind of brings down the quality of evidence. And in ROB2, you are going a little more in depth and trying to, we are just discussing, we are giving the benefit of doubt to the authors by going through a lot of signal questions, coming up with a more clearer commitment to low risk or a high risk rather than sitting on the fence of unclear. As an author, if I'm a reviewer, I'll just start putting everything in unclear and when I'm not very clear. But that's what has been, they have tried to reduce this. So the domains, the wordings are slightly different. This is the way it is. You don't have to, really go this verbatim. It's there. This is what I had discussed on those domains. This is what it is. Bias from randomization process, intended deviation. I'll just quickly go through what they are. But essentially, all these domains now are answered by 5 different questions. Yes, probably yes. So remember, this is where that subjectiveness is little left. Now we make a judgment call where it used to be probably no or no information. We used to now say probably yes or probably no. Earlier it used to be just no information and low risk of bias. Now we are saying no, even though they have not given this information, probably they have done this. Okay, or if I find there is something fraudulent, probably they have not done this. No, but that probably word, and that is what the main is. Yes and no information. There is a little more leeway for the author, reviewers to go that far. So don't worry about the text, it's all there. We will probably share with you the link. But you can see here
our job is made easy by having these signaling questions, and they have elaborated how it is affecting. I'm just reading out this one, where participants aware of the kind intervention during the trial. If participants are aware, it's most likely more likely to that their health is behavior. Obviously, this is what we discussed. Their behavior will change. Blinding participants most commonly using placebo or sham intervention may prevent such difference. If participant experiences side effects or toxicity they knew to be specific to the intervention, answer should be yes. Essentially, they want you to make a judgment, and you can see here all the reds are problematic, the greens are okay, and then there is no information. So you can see now that there is a long winding route, and you need to make that call. It gives you a little more leeway, and this is how it will finally start panning out. So you can see you just have to, you don't have to worry about this. This is 1.1, 1.2, 1.3. You just start writing yes, no, no information, probably yes, and it will tell you where your judgment will land. Okay, so don't worry. Just that there's few questions to be answered, and the way you answer, yes, probably, yes, no, whatever those five options are, it will tell you, the algorithm will tell you where you land. You don't have to, so you are not making that final judgment. You're making answering the signaling questions, and it is taking you there. So it's not too difficult to envisage. If you know risk of bias one, just taking a slightly longer winding route. So I'll just tell you what this first domain is. Risk of bias due to randomization process, which is essentially what we have discussed, randomization and allocation concealment together. Okay? So this is something that it stands for. The second one is deviation from intended intervention, which is nothing but performance bias. So we have discussed this on this already. What we discussed under attrition bias is bias due to missing data, and then there is detection bias, is bias in measurement of outcome. So the same domains have got a new subheading, you can call it. So essentially what you have learned in ROB1 is getting carried forward in ROB2. It's just that you have to make a slightly longer algorithm, come to a judgment. Final one is reporting bias. Again, bias due to selective reporting, which is nothing but the reporting bias, which we have already discussed. All this has been discussed. It's just that the way it's going to pan out is slightly different. Finally, you make a judgment on all those five. All of them are low risk, put low risk. And see, the words is unclear is gone. It's the word some concerns. Okay. So some concerns of at least one done, but nobody is at high risk. Now, clear. This is the overall judgment for that one outcome. That is the main difference. You are not making a judgment for that study fully. You are making the judgment for that one outcome of that study. I'll explain that because that's the main point. So steps get complicated. That's why I pull this back, because don't want to introduce ROB2 straight away. ROB2, actually, you need to do this for bias for one study for each of the outcomes. ROB1, what we did was, you had 7 or 8 outcomes. You just assess the study mainly on the main outcome and say this study is biased or not biased, high risk or low risk, keeping in mind the main outcome. Now, ROB2, what it does is for that one study, how many times you have to do risk of bias? For all the outcomes. How you understood why it is complicated? So if you imagine, earlier I used to do for 10 trials, 10 ROBs. Now for 10 trials, if there are 7 outcomes or 8 outcomes, 70 times you will do. That's why I said complicated, and it does. So now, in fact, we were writing a protocol and we got a reminder from the Cochrane team. Earlier we used to have 8, 10 outcomes. Now they have said you'll have only 7 outcomes, critical and important. I don't know, maybe this is the thinking that they don't want too many of them undergoing ROB2. That's what it is. And this is how the template looks. As I said, there will be domain 1. Each of them will have comments. You can see here. The text will share. You'll make this is the first domain. Was allocation sequence random? You can see yes, probably yes. So if it is random, they have done it. Called green, but probably no, no. we have a problem. So all this goes on, and you can see this is a macro capture Excel sheet. What we have done is, hopefully for one of our reviews, there are only two trials. So you can see these are the outcomes, and the same study you can see here for the, and different outcomes. And then we have made a judgment of each domain. Yeah. So this is what you'll capture. The thing about RB2 is it's only available on the Rubman web, not on this desktop version. And this is how it looks like. This is a screenshot of Rubman web, where you can see what I was trying to show in that paper Word format. You can see here the reason written here. The same thing, what we showed was Rubman his. You can see here low risk of bias because it's a centrally internet-based randomization. So this is a screenshot of Rubman web. And finally, what happens is this gets a little complicated because all this information, that is the judgment, you will create Excel sheet, and in your Revman that will not be shown. So Revman, the Cochrane will ask you to please store this in an online repository. So I was made to, there's some repository called Figshare where you can store this information of how you made that judgment of risk of bias to all that Excel sheet and all those sheets of whatever you generate, maybe some 20, 30 words documents and capture. Cochrane will not publish it. We'll have to park it in some online repository for people to see. So I found this, they only suggested go to Figshare. There are a lot of payment options, but there's one free which allows you to keep some data. And it's not only for this, you can do it for other things as well. And we just share the link to it. So take home for ROB2, generally, this will be dealt in practicals, so not to worry. But once you understand ROB1, it's easier. With an improvement, definitely. If you ask me as an end user, a lot of unclear biases start shifting towards um, yes or no. Remember, it's an outcome-based judgment. So the same study might be at a different risk for a particular outcome compared to another one. If the outcome is subjective, so, like in your case, if you're asking for pain, uh, then your risk of judgment could differ. But if you are asking for a laboratory-based yes or no answer, your judgment for details for the same study, two different outcomes, different risk assessment. That's what it is coming to. Earlier, it was problematic. You had to just go by your primary outcome and base the whole study on that. But now this will allow you to look at it slightly differently. Need to be familiar. So essentially, the bottom line is it reduces unclear bias, and finally, more studies are now under low risk, which is what we want. We don't want. See, one of the criticism of Cochrane and most of the reviews end up saying low quality or no unclear quality, and people lose interest. So what are we trying to do if reading a whole review and final output is low quality? This one probably will help us giving more conclusive answers because the quality of evidence could. This is all freely available on site. You can just go and go through. There's a big handbook. I'll share some documents with Dr. Saikar to be fit around with everybody so that they can also have. This is all freely available. I'll stop here. Sir, any comments that you have?
You can use RO, Revman, and do risk of bias, keeping in mind what ROB2 is asking from you. Example, it's got a domain and then sequence generation, right? You mark that. Second domain is concealment of allocation. What ROB2 is asking you to do is ask yourself, why are you randomizing? You're randomizing to balanced confounders. How will you know confounders are balanced? You will read table 1 of any paper. So I've had papers where they said randomize, no, central something which made me think there is some randomization. Allocation concealment was not mentioned. But I read table 1 and it is an extensive list of every possible confounder I thought was relevant. On that I said, Because there are no imbalances and confounders, I'm saying it is okay. There is very little risk of bias. No unknown confounder is going to make such a huge difference because it's a very positive result also. So you have to use your judgment. You can still use ROB, man, but utilize those kind of statements in making your judgment and make it clear. The other thing in change, what they are asking is, as Mohan mentioned, you're marking an entire study. You're saying, you're thinking of that study, in your mind, you're looking at various outcomes. In Redman, you can show it, you can break up performance bias for different outcomes. Outcome assessment for subjective outcomes, for objective outcomes, you can have separate domains. You can actually do virtually everything that ROB2 is doing by thinking of can you use ROB1. The only other difference is we are giving an overall risk of bias. Right? You can make the same judgment for the study by saying there are a lot of reds in this. But we are actually assessing it in terms of the outcome. Right? So if you know what the risk of bias and you've broken it down into various components, you need to do the bias for the outcome because you already broken down the subjective outcome and the objective outcome. And it's very practical view.
Navin, if you have any queries, otherwise you can take that in the practicals. I think that's key now, reaching throughout this curriculum.
So I thank Dr. Kamath for a very engaging, enriching, and enlightening session. So that was an overwhelming volley of questions for him. So there is a lot more to go for the day. So let's break for the tea and resume the sessions. Thank you.
benefits of radiation. And he has also been involved in publishing seminal meta-analysis, both conventional as well as network meta-analysis. So it is my privilege to welcome on behalf of the organizing committee to deliver the keynote lecture of network meta-analysis for the clinicians. Welcome, sir.
Thank you for nice words. It's really a pleasure actually to be here. So good morning, everyone. I must say that about 2 weeks back, I know on 30th of October, the evening I got a call from Psychiatrist that he's organizing this meeting. And he said, "Sir, can you come?" I said that, well, during this period I'm on vacation and I plan to go to Delhi. I'll spend a few days with my family there. So, but then he kept on insisting. I said, okay. So actually, I reached Delhi day before yesterday, and yesterday I was traveling from Delhi here. But although I was traveling, I was very keenly following all the proceedings which were going on. And fortunately, this is now live on the YouTube. So I had the privilege of going through some of the lectures, and it was really stimulating. And I feel privileged to be actually being a part of this workshop. It's a pity that I could not be here for 12th, would not be there for the entire session. But I think it gives me a great pleasure, and I'm sure I'm going to follow all the things that you are talking, and I've already shared it with my department, and I'm sure that they are having a look at those. So once I go back after the vacation, I'm sure that it will be an interesting discussion with all my staff. So, so let me start now. As I see here, the program you have been discussing on the various systematic reviews and the meta-analysis. So, in fact, we are trying to move towards the evidence-based medicine. And by this time, I'm sure that the element of this evidence-based medicine is also quite clear to you. And at the top two levels, we have the systematic review and the meta-analysis. So that's where we are trying to reach. And that's where I think the entire discussion in the morning, we had a extensive 2 hour talk on the risk of bias and show that it will follow its rates and all those things. So these are something which I think is very crucial. So what's David asked me to talk something on the network matrices. And since I am a clinician, I'm not a statistician. So whatever I could learn network analysis was because I was forced to learn when I was trying to look for some evidence for the treatment of some of my patients. And I thought that this could be of relevance to many of you who are also in the clinical path, perhaps for many of you who intend to carry out some of the analysis, many of you. So what I propose to go in 3 steps. The first, just briefly touch on the systematic review and the pairwise meta-analysis. And here, just try to look at so far so good, but then what are its limitations? And if there are limitations, then what's the next step? From there, we move to the second step, which would be the network meta-analysis, and try to understand that how can this network meta-analysis address some of the limitations of a pairwise meta-analysis, which we have talked about. And then, what are the key assumptions and the methods, which is certainly different from what you have been listening on the pairwise meta-analysis. And then finally, why we are trying to look for this evidence. We're trying to look for the evidence not just for some statistical calculation or publications, but we are trying to find out a solution for a patient. And being a clinician, I'm interested to know about the outcome of this meta-analysis so that I can apply on my patient. Therefore, final step is perhaps the most crucial, at least for us who are clinical people, is that the clinical applications based on the results of the meta-analysis and try to validate it clinically. I think that should be the final step which would prove whether what all the steps that we have carried out is ultimately giving us what we are desiring. So this is the three steps that I want to go step by step with you. So let's start. The first one, systematic review on the peer work analysis, and just try to understand limitations and then try to see where do we go next. And for this, I just thought that let's try to talk about a little case and how we really generate the evidence for evidence synthesis. And therefore, I thought of talking about the locally advanced cancer cervix, basically a stage 2B to 4A. That's how it's classified. It was cancer cervix. And this is, of course, relevance to our country. Not only to our country, I think all the low middle income group countries, because 87% of the locally advanced cancer cervix is supposed to be coming from there. So this is certainly a disease. And this is how a stage 2B to 4A is classified. I'm not going to go into details. But one thing certain, I would like to draw attention here that the treatment for these patients is not surgery. Standard accepted treatment worldwide is concurrent chemoradiotherapy, which means that I use chemotherapy and radiotherapy together. And this is, I know it's not a population that I'm speaking for the radiation oncologists, but maybe a mixed population. So maybe some of the technical terms that I would like using. So please feel free to stop me when you enter the patient in the. So the standard treatment of choice for these patients is basically uh, using chemotherapy and also radiotherapy. So if you look at a Cochrane collaboration, now named Cochrane, and look at all the evidence that Cochrane has placed before us the last few years for locally advanced cancer. And in fact, there are three meta-analyses. First one published in 2004, which was a neoadjuvant chemotherapy for locally advanced cancer cervix. And it said that the neoadjuvant chemotherapy or NACT or radiotherapy versus radiotherapy, odds ratio was 1.05, with a confidence interval of 0.93 to 1.19, and hence, so perhaps there is no role of neoadjuvant chemotherapy, and certainly it's not the standard. The second one was 6 years later, 2010. And surprisingly, it came up with some very unusual form of treatment. We know that for cancer, there are basically surgery, radiotherapy, chemotherapy, and of course, now after the COVID, immunotherapy. Then there is something very funny and very strange coming that is hyperthermia. So I'm sure that none of you have exposure to hyperthermia perhaps. So I will just touch on it very briefly because this is will be a very relevant for the talk. So for this moment, take it from me, hypothermia is something which is hyper, not hypo. So you are increase the temperature of the tumor tissues by a few degrees, and we will see what happens. So this was a meta-analysis published in 2010, which tried to look at hypothermia, what happens when you add radiotherapy versus radiotherapy alone, and with a hazard ratio of 0.67, it showed significant at 0.05. Then came last one, which is 2015. And this was comparison between chemoradiotherapy versus radiotherapy alone, with a hazard ratio of 0.81, highly significant. But if one goes through it, I'm quite surprised that how could Cochrane come up with this analysis? Because it is supposed to teach us, and as we heard, there is risk of bias and all those things. How could Cochrane come up with it? First, here is that patients that are studied, population which forms on A to A, It's a stage 1A to 4A, and it was a mixture. So we perhaps thought that's not really right. So, because I could not figure out that, well, that this policy work for stage 1 or stage 2 or stage 3 or stage 4. So what we decided that let's try to redo the whole thing. And 2017, we tried to redo this meta-analysis, which was a basically systematic review and meta-analysis between concurrent chemoradiotherapy versus radiotherapy alone in locally advanced cancer cervix, making sure that all the patients that we are taking fall only under stage 2B to 4A, and they were uniformly treated. What we found, there is difference. Local regional control was 0.08, significant. Oral survival was significant with the risk difference of 0.7. Q toxicities was higher, significantly higher when you use the chemotherapy along with radiotherapy. However, the late toxicities, there was no difference between whether you're using chemoradiotherapy or radiotherapy. So it was quite evident now that, well, chemoradiotherapy should be the standard of treatment, not radiotherapy alone. But then we also had this Cochrane review which said hypothermia to radiotherapy is better than radiotherapy. So then we thought that, okay, this study was published in 2008 or 2010, and in the last 12 years, there have been a lot of developments which have had in thermia. And so we thought that let us try to first read the conclusion of this authors. They said that there's a limited number of patients which are available for analysis. Rabbits drawing definite conclusions suggests that the addition of hypothermia improves the local tumor control and overall survival without affecting the treatment-related grade 3 or grade 4 later. It was looking promising. Then let's try to see what happened in the last 12 years now. When we looked at the literature, the hypothermia, when, as I said, that you are raising the local temperature by 39 to 45 degrees, so about just 40 temperature, and when it went, it is one of the most potent radiosensitizer, and therefore it complements radiotherapy. And for cervix, radiotherapy is the base and the mainstay of the treatment. Because you have a treatment modality which really enhances the effect, was found to also actually complement the damage which chemotherapy drugs are doing because it interferes with the repair of the DNA damage pathways. So if the DNA damage pathways are repaired, so DNA damage can want to repair. So therefore, they would expectedly like a cell kill. And it was shown that this could be there independently with some of the chemotherapy agents, relatively or even synergistically. Two of the most important chemotherapy agents which are used in cancer cervix, that is cisplatin and 5-FU, were sensitized by chemo. That was quite promising. Finally, very interestingly, hypothermia is found to be a tumor modulator, resembling like in situ tumor vaccine. So think of a single, any modality of treatment in cancer, any modality, which gives you equal advantage. Organ radiosensitizer, the mechanistic action with chemotherapy, immunomodulator, and on the top of it, no significant acute or data. That is where the hypothermia comes. So we thought that if this is what happens, then let us also try to see what exactly has been happening. So we found a lot of progress has been made for hypothermia. I'm not going to describe these details, but for my colleagues in radiotherapy, they are very well aware of these color wash diagrams, as we say. And so therefore, the planning with hypothermia and radiotherapy combination can be done. What is now available. So therefore, we carried out another set of meta-analysis published in 2016, in which we try to look at hypothermia radiotherapy with or without chemotherapy. And we try to look at systematic reviews and conventional and also independent. So this is a pairwise, which is hypothermia radiotherapy was radiotherapy alone. The local complete response increased by about 23%. The survival increased by 8.4, although it was not significant. The acute toxicities were not significant as expected. The new toxicities were also not significantly raised, and that seems to be matching with the logic of hypothermia. So what we came to the conclusion that hypothermia related certainly improves the therapeutic outcomes in cancer cervix stage 2B to 4A compared to radiotherapy alone without any added. So now we have one set in the results of chemoradiotherapy was already. The other updated sets of hypothermia radiotherapy was, and that's created. There was a dilemma now of these two sets of pairwise meta-analysis. One set said that chemoradiotherapy is better than radiotherapy. Other set said hypothermia and radiotherapy is better than radiotherapy. Both are sets are in locally advanced cancer cervix. So for a clinician, my problem is that which is the one treatment which I should choose? Should I choose chemotherapy with radiotherapy? Or should I choose hypothermia with radiotherapy? Treating the same disease. There are two sets of meta-analysis. That was a problem as a clinician, so I had to try to find the answer. And then I realized, as a service, we look at the entire history of treatment of cancer cervix. We find that it is not only these two modalities which has been used. As I said, for stage 2, P2 4A, radiotherapy has been the mainstay. But then, with chemotherapy, there are 8 different options. It could be either used as a neoadjuvant chemotherapy or with radiation. It could be used as an adjuvant chemotherapy, that is, the chemotherapy is followed after the radiotherapy is completed, or with concurrent chemoradiotherapy along with adjuvant, or then concurrent chemotherapy either with a drug system, most commonly, that too given either weekly or 3 weekly, or non-cisplatin products, or even multi-agents. There was one set with the chemotherapy. Other set was radiotherapy has been also used with hypoxic cells because cancer cervix with these are big tumors, which are hypoxic tumors. They don't really respond very good. People have used hypoxic cells. And I've also used immunotherapeutic agents and also hypothermia, of course, either as radiation or with chemotherapy. So ultimately, if you see 8 on that side, 4 on this side, and 1 in the center, that makes it today there are 13 different options. Mind you, all this have been tested in phase 3 randomized trials. So when you are testing 13 different options over so many years, you are giving a clinicians now problem very hard. Because any randomized trial would most likely show that one of the two arms is better. Okay? So therefore we had to think of something else. That's where. So the next step comes the network meta-analysis. Because as we have seen that there are certain limitations of pairwise meta. We're talking about pairs, there were only 2 different approaches. But most of the clinical conditions, there are not 2 different conditions. There are so many drugs. We talk about any subjects, anything, cardiac, psychiatric, any disease. There are so many drugs. Now, which drug to choose? There's not only, we're not talking about 2. For a clinician, I have to give only one drug to my patient. That is where I need to be very focused. So, how can we address these limitations of pairwise analysis? What should be the key assumptions of GO? That's second part. So it's just to bring you an update, this is what the conventional pairwise meta-analysis do. So there are 2 arms of studies, one A and one B, with various treatments having all here. And then we have these forest plots, and would have another treatment arm C. We could have a trial between A versus C. is another treatment. There could be another treatment which is comparing B versus C, but there is no trial which is here A versus B. But then, is it possible to estimate? So there is no trial. Can I really estimate it could be the outcome between A versus B? Like if A is faster than B, than C by say 5 minutes, and C is faster than B by another 10 minutes, the logic says A should be faster than B by plus 15 minutes. Yeah? So can we apply some sort of logic in directly estimates? There are two components now. One is a direct and A versus C and B versus C, where we have the direct evidence. And the other is that where we don't have a direct comparison, can we really make an indirect estimate based on the outcomes from A versus C and B versus C? So that is what is being done. Okay. So a network analysis would therefore have multiple treatment options. Like here, for some disease, talking about internal radiation, chemotherapy, interferon, observations for immunotherapy, multiple of them. And these are all a part of a network metastasis. And once you look at this, this is a network diagram. Some small things here. One, these are the nodes. Not coming here. So these are the nodes which you see on the blue round. And these nodes have different diameters because they represent different number of patients. Then we have another one which is basically, you see the thickness of these lines which are connecting. Some are thin, some are thick. And these are basically all the studies which are directly estimating between these two. And the thickness again would depend on the number of studies. And then the third one, which you see the dotted dashed lines, and this represents the indirect estimate, where you are trying to estimate with help of the direct studies. Okay? So there is a mixture of indirect estimates, direct estimates. And that's what doing. If you have many more doubts, this is what is a complex network metastasis. So many options, as I said, and this is, I think, from psychiatry, one of the psychiatric papers. You have plenty of them. The biggest one which you see is perhaps a drug which time alone. I'm not a psychiatrist, sorry. So what I'm trying to say, this is what would happen. And this could be there for a problem for any site. Okay? So network analysis, therefore, is also called as a mixed treatment comparison, or also called as a multiple treatment. These are the three names which NMA or network analysis. So again, coming back to this most crucial aspects of direct, indirect, and mixed estimates. So this is again a network diagram, A, B, C, E, and you see the thickness lines, some dashed lines. So as I said, the thick lines, straight lines are the basically direct estimates where the trials are head-to-head RCT. So that is a single type of what you have a pairwise meta-analysis. Then you have second set, which are the indirect estimate, which are basically the dotted lines. The estimates not obtained from direct head-to-head, but compared through another intermediate. These are the indirect ones. And then, of course, mixed estimates, where you can have a single estimate obtained from both direct and. So these are the three estimates over which the entire NMA is based on. And therefore, one can see this network meta-analysis is evaluating all the treatment options one go. And therefore, a much more higher sample size, therefore, of course, much more. Okay. So that is where is the advantage of carrying out a network analysis over or pairwise. A few things here before one walks into a network analysis, one has to show. First is the transitivity. Transitivity word is basically a similarity. Like we have been talking about risk of bias, and any trial we want to do has to have a similar patient population. So transitivity also is something which cannot be tested statistically. But you have to check for all the effect modifiers and make sure that the inclusion and exclusion criteria have pure group of patients, cannot be mixture of different types of patients. Although it's a network trial, but basic element has to stay. So, like for example, now this is a network diagram. Now you see this study A versus B, A versus C, the right estimate of B versus C. Now, if A, suppose when you're talking about cervix, if A has both the A's, both the trials have only stage cervix, stage 2A to 4B, it is similar. So, therefore, similar patient characteristics and interventions are also probably similar. So, it's cleared for the consideration. This is the first thing. On the other hand, suppose again there is the same AA, but now these two A's are slightly different because they one talks about stage 1 to 3, other talks about stage 2 to 4. So definitely the outcomes can't be same. Or one study talks about squamous cell carcinomas, same cervix stage 3, and the other talks about adenocarcinoma. They can't be same. So one has to make sure that the inclusion criteria of all these trials have to be really homogeneous. So there is nothing we that you are taking dissimilar type of. That is the one of the key important consideration we need to make. So this, of course, would not pass the transit. The second is the coherence. As I said that I am also trying to estimate it indirectly from two direct estimates. I can also then say that this direct estimate, like if I say A versus C is 5 minutes, B versus C is 10 minutes, so A versus C should be 5 plus 10, 15 minutes. So my 5 plus 10, 15 minutes is an estimate. But now let me put A and C in a race directly. I would expect that they run whether he is going to win or C by 15 minutes. So which means that my direct estimates and the indirect estimates are matching. So they are coherent. If they are not coherent, that means that there is some problem. So that is where the coherence comes, and therefore checks for the matching between the direct and the indirect. So this is another network diagram, ABC. Here I am estimating B directly, but here I am estimating B and C directly, same patient population. So therefore, these two has to be similar. So it has can be tested statistically. I'm not going to go into the how to test it. But what is you usually assume that in that entire network, around 90% you are allowed to make a guess of. Might not be. So that's okay, but 90% should. So now you have two key considerations, conservativity and consistency. These are unique to some extent when you're talking about network. So before you embark on any network analysis and select the papers, make sure these are all the papers. Because now you are considering the entire network as one gigantic trial. Huge data, huge data. You have basically collated all the possible interactions which have gone for one particular process. Now you're trying to pick up which is the best out of the entire thing. Makes a lot of sense for the clinics. Okay. So this is first step that you have to be very sure and very careful about. Then you also have to need to make sure that they do not differ in any key effect molecule. Really. You can't compare apples and oranges all the board. Similar. Apples and same. So there has to be fulfillment of the transitivity. And finally, you also have to make sure that the direct and indirect estimates are in statistical agreement. So it fulfills. Of course, other things we deal with the pairwise meta-analysis, the fixed random models, in collaboration for risk of bias, or the great cinema you can use for quality and strength evidence, and of course, sensitivity analysis, or even the cluster analysis. So these are some of the things which are common to. So I'm not going to. So now, what do we finally have? Finally, have a slight modified top. Analysis has now been divided into areas on the top. Let's say. So, for multiple therapeutic interventions, what you have right on the top is overlap. But that should be the highest level of evidence because it allows comparison. It's no wonder this was a search I conducted just about a week back, 7th of November, looking at the PubMed to see how many papers are there in it. So total about 22,000 papers. And we look at the number of papers we are coming from 2000 to 2024, around 15 papers and around 2000, staggering 3,000. Definitely, years to come, you would have more and more and more of it. So it is just crucial that, that we just try to understand what actually is going. Because this is going to be used and is being used to the most national agencies from the policymakers for the health technology assessment for formulating the clinical guidelines also personal paper it becomes 40 and 90. And even Cochrane now has a few network analysis, and you can see here for coronary intervention strategies, presence, and it has even for COVID. And all the drugs which we are talking about, the chloroquines and so on and so forth, they actually, the WHO has basically asked the Cochrane to send them all the NMA data and see where they were trying to come out, which would be the best. So, no, this has to direct relevance, and therefore the Cochrane which came up with like a big way, gradually faded out. Cochrane showed that no, okay. So, what are the steps, though, therefore? Just summarizing the steps. So, you go in with the PICO, same thing, with the conventional analysis, follow the PRISMA guidelines, raised to the trial and the prospect, well-defined inclusion and exclusion criteria, adequate search, certainly, so study selections and study endpoints have to define, quality evidence based on either grade or cinema, and bias, Cochrane, collaboration, and start with. For this, there are a few free softwares available which you can download. Winbugs is the one which I'd use that has metamixing. So that is free, but you can also get it done on our site already. Once you are there and you want to now start, what are you going to get? So once you want to proceed with you are going to have something unusually different from what you normally see on a pairwise analysis. You're going to have this network diagram, which we just discussed. You could also get a forest plot. You would be getting something which is a league table, which summarizes the entire odds ratios along with the constant. All the combination which you have now. Then this thing comes is that you get the ranking. But if I had 10 or 13 different types of treatment for a cancer cervix, you need to know which is the best, which is the worst. So if I have something in which it can be ranked 1, 2, 3, 4, 5, 6, depending on the endpoints which I define. So that is where the super ranking, you can do it, but on anything. You can follow the inconsistency plots because we are looking at the concurrence. And then you can get the cluster plots, and this is not on the data matrix, but you can the spaces. And finally, you can carry out the sensitivity. So all everything what you want, you can do it. Everything. But provided you start with your basics, you correct, make sure there is no transferability and voice. So therefore, coming back to the cancer cervix, so these are the 13 options, and our task is to find out which is the best option, or which are the best few options and use it. So let's try to see if we carry out an NMA, can we really identify the whole game? So this was the uh, paper which we published in 2019 in the journal Relation called Biology Physics, which actually summarizes the entire NMA for cancer cervix for the first time. Everything has been reported, published, easy. So let's go through it step by step. So we had 13 different interactions, okay? And we wanted to look for the clinical endpoints, which includes the long-term low region controls, overall survival. We also wanted to make sure that the acute morbidities were happening to that, and the late morbidity, grade 3, both again. And then we said we want to take all the endpoints together. We are not just saying that give me the best option which gives me the best local regional control, but gives me the worst mortality or morbidity. I know I'm not interested in that. But as a clinician, I need to take care of my patients, not only in terms of disease control, but also make sure that I don't add to his morbidity. So taking all the endpoints into consideration, which would now be the best treatment option? That's what the problem was. So we had the search strategy, so we included only randomized trials and only defined in stage 2B to 4A, made sure that there's no surgical. So we looked at the Embase, PubMed, Cochrane, Scopus, Web of Science, and Hand Search, and all the papers, number of papers you can see there. And finally, we came across 6,285 records. Huge data for us. And then we had to look at these 6,285 records individually as per the Prisma guidelines. Finally, from 6,085, filter out only 61 records. Means almost 90% of the records which. So that is how you try to see what you want to make sure that the data which you have over which it's not the trash in and trash out business. Okay. To make sure that this is the most vital step, and that was the most time consuming. Almost took us almost 1.5 years of job just to make sure that what are the studies that we are doing. So 61 records, 74 to 2018. There were 59 randomized trials, and one trial was a 4-arm, which included all the 13 different interventions. Total number of patients were 9,894. So we are talking about something about 10,000 almost. We are about 10,000 patients, of which 97.4% were local advanced cancer cervix in stage 2B2. So there are some small studies might have a few patients here and there. So we just, okay. So 97% are basically 2B2, right? And each paper was evaluated for bias as well component 2. And as I said, these are the 4 endpoints we are looking. And we made the network analysis for each individual. So this is for the network diagram for the local regional control. You can see that radiotherapy, of course, is the biggest diameter because that was the control arm for most of the studies, and you can see the number of all the 13 interventions here, the number of thickness on the lines which are showing here. Total of 49 studies which reported the local regional control, of the 61 were included. And the total patients in the entire network was 8,197. Started from 9,000, but because of them didn't really put the local regional control, so we could look at 49 studies, but still it had quite a reasonable size of number of patients. It moved 1,000 patients. So this was the network diagram. This is the league table for you. It shows the odds ratios, and you can see this odds ratio compares hypothermia plus radiotherapy versus chemoradiotherapy and adjuvant chemotherapy. This would be hypothermia radiotherapy versus hypothermia chemotherapy, and so on and so forth. You can read it down. And the one which is right on here is part of the best one. The one which is coming here is part of the worst one. Okay, so that is how you can see the yellow ones are one which is again here. And then I said, I use the ranking. Ranking is something which you get with the service under cumulative ranking, that is the supra curves. And based on the rankings, we have the ranking values which ranges from 0 to 1. So 1 means the best, 0 means the worst. So if I rank all the treatment 13 options, and you can see here the hypothermia plus radiotherapy has the highest super ranking at 0.8486 for the local regional control. And the least one is the new adjuvant chemotherapy plus radiotherapy plus active chemotherapy. So now I can rank all methodology from 1 to 2. That is where the ranking helps me. Same thing I could do for the survival. So again, survival, it has 50 studies, totaling about 7,958 patients. At the league table for them, the ranking for all the trials. Here, chemoradiotherapy 3-weekly platinum was the highest rank, followed by hyperthermia plus chemoradiotherapy. And of course, the hyperthermal radiotherapy, which was the first one, fourth here. So now this is the new ranking. We also wanted to look at the acute morbidity. So this is the acute morbidity network diagram in the league table from 44 studies, about 7,183 patients. And again, a ranking here and here, 110th, 113th rank. Same thing for the link morbidity, similarly for about, then all this was from 23 patients, 23 studies, totaling about 6,333 patients. And here again, we can rank it. So now the question is that for a clinician, I have to not only weigh is the best one, not only want the best of the results, but you have to also make sure that it's not be too morbid. So we have to balance between the desirable and the undesirable effects. Desirable, we want the local agent control, we want the overall survivals, and undesirable, we want to minimize the acute morbidity. So therefore, what we can do is that we plot all these ranks for local agent control and overall survivals, morbidity, then perhaps try to add the super values, try to find out now which is the one which actually gives me the best ranking at all these endpoints. Now that's number one. That's number three. Fact. First, radiotherapy. The second comes after chemoradiotherapy. The third is CTRT 3BT. That is how the ranking from these 13 come here. So it was quite interesting to find the hypothermia looking over even the chemoradiotherapy arms, but that is what they may showed us of 59 trials, putting intervention, 9,890, three best therapeutic options for the ranking for local drug cancer rates, radiotherapy, chemotherapy, chemoradiotherapy, PGs. So then the question becomes that okay, this is all about statistics. I don't understand the statistics. I'm not a statistician. The problem is my statistician doesn't understand radiotherapy, and I as a radiotherapist maybe a little bit trying to follow. So where do we meet? Okay, I just gave him the problem. He gave me some figures. I said I don't know what you was trying to say, but then for me, I would be really happy if all the values that I'm getting from these all calculations will get translated. That is what ultimately the purpose of these entire workshops is. So question was how well do the results of the NMA, of the network analysis and NACC translate into clinics? And that's what clinical application validation. That was the third step. And this was not possible in Switzerland. I stayed there over 8 years when I was doing all this thing. So they don't have seen so many patients. So when I came back to India, returned back, joined MJIMS. So there I launched this trial, which is a registry trial, to evaluate the safety and efficacy of hypothermia and local advanced cancer. Cervix, knowing fully well there is no center in India this hypothermia routinely incorporated. Neither do we have any standard hypothermia case. It was a task to how I can get, how I can modify, I can deal with it. Somehow, there was an ongoing study which was approved by the Institute Ethical Committee. And this is a hypothermia center or hypothermia setup that we have. We have a 27.1 megahertz capacitor unit. We have a water wall mounted laser for patient positionings. We have in-house fabricated circulatory water bonus. We wanted to burn the patient's skin, so we wanted to make it cool so this was also developed in-house. Then we also wanted to monitor the temperature by using a fiber optic sensors. And finally, L7, just prior to coming here, I just let the local just have a look at the results, what is happening. Till now, we have treated about 43 patients of fever stage 2B to 4A. That was group that I was targeting. Two patients, of course, were 4B. At 32 months post follow-up, we had a local disease control of about 95.3%. One, we feel outside the pelvis. Now, mind you, hypothermia is a local treatment. Many patients of stage 3Bs would also have microneedling going on. So, some of these patients are given adjuvant chemotherapy. They're just given chemotherapy during the course of 6 weeks of chemotherapy. Failed outside six pelvis were 9. It was pretty substantial. So when we look at the Kaplan plot, so this cause specific MDF, 97.3%, which I think is we feel satisfied looking at the results, but there is scope of these 9 patients who failed outside the pelvis are something which I'm concerned. So in cervix here, you can see here the responses, but MDMS now Severa, we have the biggest, wildest, and the most difficult patients to treat is coming with advanced stages, 3 important groups: cervix, breast, head and neck. That's the group we have. Inoperable patient. Something had to be done for this. That's where we use hypothermia routinely. All these patients, that is a part of the registry trial. In fact, I strongly believe that actually hypothermia, in fact, mention as local or middle. So these are the patients that are dominating in the LMIs. No amount of immunotherapies, those mix and maps, those fancy drugs which cost few lakhs of number. We don't use any MIPS and maps. We don't believe it. We don't believe that you can use chemotherapy to do that. Because if you look very carefully, on one hand you are saying that you need to make the immune system stimulating, and on the other hand you are giving chemotherapy which actually brings the immune system down. They are in contradiction to each other. So we use chemotherapy sparingly along with radiotherapy, but still believe that this is what I think which needs to be considered special for countries. So finally, to conclude, LMA synthesizes three or more therapeutic interventions by using direct and indirect techniques, more precise, allows rankings and the key considerations of consecutive consistency and the confidence of estimates the rate of the bias technique. LMAs are therefore being used by most of the health quality assessment uh, helps to formulate clinical guidelines and each therapeutic intervention. It certainly gives you the highest level. Hence, evidence from LMA could therefore be incorporated into practice. Improve. That is what I really desire to. So finally, to acknowledge all the help. This is from my Canton Hospital at Aarau in Switzerland, where Manuel Stutz and I spent nights and nights working and trying to scan through the 6,280 client people for almost 1.5 years. And of course, when I returned back to my place here at NGIMS, so it was basically Jatin who designed that the water bolus, Pratik and Ashok, of course, colleagues. But then I think the credit goes to the entire team. So it's basically a teamwork because the nursing has to be, clinical staff has to be knowing. So it is basically a teamwork, which I'm really proud of. Thank you very much.
Excellent talk, and I think this illustrates the basic aim of this kind of workshop, like how to critically appraise and generate the evidence from the medical data in abundance now, and how to implement it. So, I mean, we take a few questions, like if there is anything to think.
Thank you, sir, for such a elaborative and practical approach for all the departments. Just like to know, is there any way we can look for the hypothermia for brain tumors also?
Yeah, everything has been used in brain tumors. Has been used. I have not used it, but yes, I know the seniors there. So they have been using it for various blastomas and all. But I certainly would love to use it. See, hypothermia is one such modality which can be used at any sites. It is not going to cause any problems in terms of it is not going to add to the toxicity. And brain has been used for it. So what? I'm going to ask Cynthia.
Very good introduction. I had two questions. One is you mentioned direct estimate, indirect one validated by direct. If we don't have a trial comparing, can we do that? So, like,
Yeah. There are certainly certain conditions in which you may not have a direct estimate to compare with indirect. So they could be few. That is what I'm saying that less than 10% is permissible, where you would have. And then when you are trying to, first for the incoherence, you not only costs which I didn't show, you also actually estimate the DIC values. So DIC has to be less than 5%. So there are two or three categories on which you can try to do it. But yes, you can only do a coherence measurement if you have a direct track. For example, if you don't have a direct track, you just can't.
it just you'll have just the indirect estimate.
Yeah.
And you put it. Other thing, how do we you give a 90, but evidence could be different based on the grade. Let's say that's so grade.
Yes, what you were showing in the rock 2, because we didn't have the rock 2, we didn't, uh, we actually summarized the this thing bias diagram which we have it. It based on all the five, all the four. So we are more worried first, make sure that transitivity is maintained. That was the basic criteria to, I would say, to classify them, the bias, whether the transitivity is maintained or not.
But it could happen that the first one on the red, the quality of evidence could be lower than that, and the second one might be better.
We are talking about 10,000 patients, 61 trials, ranging from 72 to 21. So, there could be some. So, but what I'm trying to say that there could be some noise, but the thing is that how I come out of this noise and try to make it more practical and more pragmatic.
One very basic issue will be we are basing this entire web meta-analysis on some computer-generated software. Now, what is the validity of that software on which we are basing our entire interpretation of comparison of so many studies?
Well, I'm not a computer software specialist. What I can tell you is that network analysis is being computed by using the software basically by two methods, the Wilson methods and the Bayesian methods. Okay, and this has been absolutely tested. The Bayesian type of them in which they use the Markov analysis and all that. This has been done. So I trust them that they are giving us a software which validates this. So I am no one to test on that. So I'm using the software which they have given and try to see whether. And then the question is that forget I don't trust. But then my last step is to validate. The patient is telling me whether my what I got is working or not. Tell me any single drug, any single mechanism. And give it 2.5 years, 97.5% total control. I don't think I have seen anyone. So if my patients are saying that yes, this works, I believe that more than any statistics, forget about any diagrams. I don't believe that in my patient, but it works and not only in cervix, head and neck, as breast, those big tumors. I have some pictures I can show you of tumors which are inoperable. 6 weekly chemotherapy cycles. Who is the tumor? Goes for surgery, comes back, and living fine for 2 3 years. And they are the patients who are giving adjuvant chemotherapy. So that is where I said, still my results, I'm still concerned that why 9 patients fail. So I think ultimately I am more bothered about what my patients are showing. They don't, if they fail, I don't believe any statistics. If they're doing well, if everything, This helps them.
I think we will end the session with this note that clinical validation is the most important thing above all the softwares or hardwares that we are using. And thank you very much, sir, for coming here and enlightening us with this very short notice. I think from the organizers, I thank you. Thank
It's
you.
a pleasure. Thank you very much.
Continue with the next.
Sure, sure, sure.
Yes, thank you, sir. It's a privilege to have you in this session. Now, I would kindly request Dr. Kamath, sir, to continue the session. Thank you, sir.
Yeah, we will not mind.
So, I think this is pre-lunch, difficult time to keep up. So what we'll do is I'll just go through 15 minutes, just a snapshot of risk of bias for non-randomized studies, because this is a we often we are asked during a workshop, why don't you cover non-randomized? So just a rider here that I haven't actually personally done this because I've mainly done on varsities, but I'll just try to understand this and probably I'll share my thoughts on this. I'll do this for 10-15 minutes and then we'll just go to the RevMan. So I believe all of you now have the RevMan on your desktop and we will just do one exercise of data entry, which is what this particular session is on. But I thought just before lunch, this talk will be difficult. Practical will be easier just before lunch. So I'll just go through this, finish this off, then we can go on. So the way I have understood this is that many times now we are always saying, okay, we will include randomized trials, but for some situations and some specialties, it's quite common um, to have randomized trial, truly randomized. There are non-randomized studies, and there needs to be a mechanism to assess the risk for these studies as well. So what I'll do is I'll just tell you how I've understood this, and I will probably share some studies that are there or some materials which can be used later on to study or do this yourself. The first step that is asked for in trying to assess a non-randomized study is to make it hypothetically a target trial. That is, you convert that in your mind to a target trial. So let's say that we have a situation where we can't really do a randomized trial for various feasibility or practical reasons. Then you will convert that into a you'll do a non-randomized study. That is, some patients come, you'll give one arm, some patients you'll give another arm. That's a non-randomized study, but in your mind, you will convert this into a targeted randomized trial. So I have given an example. Let's say you had serious COVID condition and we were in the early stages and we didn't have any drug, and you have a drug now, and at some situation the physicians with discussion with the family and so on are giving one particular drug, whereas another group is not receiving any drug for whatever reason, maybe consultants preference and so on. So there is like, especially in the departments, there might be some consultants who are pro giving these, recent drugs which haven't really gone through the phase 1, 2, 3, but they feel this is a desperate situation and I'd rather give something than not. And the other ones, a little more conservative approach and say, let's not give anything because it's not proven. So there are people who might have this. But it's like a non-randomized study. And now try to convert that into your mind and say it's a randomized study and assess this thing. Why this is required is, as you see here, for non-randomized study, this is a Robbins I tool. What the good part is, post intervention, it just mimics the risk of bias. So I will not go through the post intervention part, which is what we have been discussing from morning. Performance bias, attrition bias, detection bias, and reporting bias. These are the same for Robbins I tool that I'm discussing here, which is what the Cochrane would advise for a non-randomized intervention study. Yeah. The problem is the first two subgroups, that is pre-intervention and at intervention. So I will just give you some examples and stop at that just to make you understand what this means. But remember that I think with our discussion you realized that the first two are mainly dealing with what is there in randomized trial which is not there in the non-randomized. What do you think is the main issue? Which bias is missing here? Problematic? It's a selection bias. If it's non-randomized, that's where the problem will be. That in a randomized trial, you have an eligibility criteria, you have patients walking in, they are eligible, and suppose as discussed in the morning, you will discuss the trial arrangement and the patients are willing, you will just let them in and everything will be randomized at that point and everything remains same from there. But in a non-randomized setting, this is not it's going to be. They come on a particular OPD, one consultant feels to give, the other consultant in the next OPD feels not to give, almost similar patients. So it's a slightly different setting that we are talking. So there are problem of selection bias is the highest here compared to the randomized trial, and that's why this particular domain is different in NRSI. That's what I'm looking at. And there is something called misclassification. I will just explain you these 3, 4 things and then we move on to the data entry aspect. So what I've understood here is bias due to confounders. Now what they are asking you to do to assess this non-randomized study is assess all the potential confounders. Okay, and then address it. So if you are trying to do a systematic review and you have decided to include randomized trial as well as non-randomized trials, assess the non-randomized trials, please list out the potential confounders. So as Sir said, cancer cervix. The confounders would be probably, I would expect, the stage of disease advancement or things like that, or some major comorbidities, or any oncological condition you can see, and if there are comorbidities having a problem with surgical output and so on. So think about the confounders for an NRSI. That's non-randomized studies require you to make that exercise while assessing. There could be some other issues as well, but the larger point here is that you can adjust only for confounders which are at the point of intervention. The confounders that come in once the intervention is launched is not something that can be adjusted. This is a statistical red line which I have understood now. I was not aware of this, but what broadly I'm trying to tell, I'll give you an example, is that a confounder coming in between, once the intervention is launched and halfway through, there are some confounders, you can't adjust for that. You can only adjust pre-intervention. So that example I can drive home here is that if you are looking at antiretroviral therapy and CD4 count is what you are banking on, CD4 count at the baseline you can adjust for. But if you are making the drugs, changes in the drugs after 6 months based on the CD4 count, you can't adjust for that. That's what is clinically what this whole exercise means. So essentially, the bottom line is when you're doing a non-randomized study assessment, please identify all the potential confounders, which the which the studies should have adjusted for. That's what you're trying to identify. You can do a pilot. So this is how the judgment will come. So if you look at that domain, I would just keep it to the first two. The first one is there are no confounders. You potentially feel that the study, even if it's non-randomized, cannot think of a potential confounder. Now, this is an ideal situation that's very, very unlikely to be. But if it's that's the case, you're lucky. You judge this study as good as a randomized trial. Problem is, most of them will fall and start falling on the second one. That is confounding expected. All known important confounders have been measured and controlled for. Reliability and validity of measurement of domains is sufficient, and we do not expect a residual confound. It's a pretty complicated statement. Okay, so I also was, confused in what am I supposed to do, how am I going to explain this. So I had to go within the text. Now, what they are trying to tell is, let's imagine two scenarios. One is a trial which is looking at, let's say, a cardiovascular morbidity and a drug in cardiovascular system, like let's say for myocardial infarction or prevention and so on. And hypertension, presence of hypertension is a confounder. Okay? I'm just trying to jog back my medicine knowledge so I can come up with this. Now, in a randomized trial, what is likely to happen in terms of measuring the BP? When are you going to measure the BP and look at the eligibility and so on? At the baseline, when you are planning to give the intervention. Okay, patient comes, you measure the BP and so on. In a non-randomized study, what is likely to happen is patient comes in an OPD and it's not a randomized study. So the doctor has just given one drug and then you have the other arm where the another consultant doesn't give that drug. And you go back and trying to, look at, you travel back in time and try to see how these people have checked for the blood pressure. In a non-trial setting, not a randomized trial, that blood pressure could have been measured not at that OPD point, it could have been done maybe a couple of months before in the initial visit. Is that plausible? Okay. And at some point, that blood pressure could have been measured by somebody like, many times in busy hospitals, some intern is checking and then the patient goes into the OPD and sees the consultant. It's a normal thing. Okay. Now, compared to that, imagine in a trial setting what is going to happen. Who is going to check, and are you going to be careful about that checking of the blood pressure? We are. We are going to use an instrument. We are going to standardize the instrument. We are going to make sure our trial staff who's trained in measuring that blood pressure records that. So now, can you understand the difference between a setting of a non-randomized study versus a randomized trial? Reliability is how well it has been, that information has been collected. How will you get that information from that for a non-randomized study? You'll go back to the medical records, electronic data, or whatever, wherever it is, and somebody would have written this through 121 by 80 or so. Is it a very reliable method? We don't know. We will have to make a judgment call. But in a trial setting, this is very different. The same information is captured in a very different way, and you will enter that in your data and everything else. You'll have a case report form, CRF form, it will be written. Any issues with that, it will be marked out. But in a non randomized study, it's been there 3 months before the actual recruitment. The drug, when it started in March, but the record is from January. You're getting my point where the problems will be. That way, you might say that BP was fine in January, but in March, whether it was still normal or high, we don't know. Okay, and that's where the problem of residual confounding is. So just this is a point, and then the validity, the reliability. So these are how accurately it was measured. So these are the issues that starts coming into a non-randomized state. So this is just an example of how things can go wrong. That is confounding, and second is selection bias. So these are two different things in the context of non-randomized. I will give an example. Here, you are systematically excluding a particular group of participants or systematically taking off certain parts of the follow-up. Now, I'll just give you sample of this particular statement. How do you do this? So let's say that I think sir is from oncology, so there is a lot of focus on aspirin. There is an aspirin trial. They are doing it in all the cancers and trying to give aspirin to see whether this is working or not. So if you have a non-randomized study and you look at patients who had colorectal, surgery for oncologic reasons and aspirin, and those who did not receive aspirin. Yeah. So do you think there is a problem here in the arm which did not get aspirin? So there is a group of patients who underwent colorectal surgery for advanced colorectal malignancy, and one group received aspirin, the other one did not receive, and you compared the death rates 5 years down the line. Do you think there is a way we could? There is a problem in the bias. There's a bias that can come in the way this study is done. I have mentioned here. Problem is that for starting aspirin, the patient has to basically will come back in some of the systems a month or two later. Okay, and that would be the intervention arm for that non-randomized study. But for the control arm who did not receive aspirin, you will count right from the start of the surgery. What are the normal issues with such morbid surgeries? Some of them might not survive for the follow-up. Yeah, advanced malignancy surgeries can be quite risky. So they will not turn up at the 1 or 2 months of follow where you would have started aspirin for the people who are there in that arm. Whereas here, they will be counted as they were in the no aspirin arm and they didn't survive. Why? Because you had a differential time follow-up. You gave that aspirin arm an undue advantage by only taking up those patients who turned up for a follow-up. You got my point? Do you think this would have happened in a randomized trial? When will you randomize? At the time of surgery. Simple. Yeah. So before surgery, I randomize. I don't know what's going to happen after surgery. And some of them who were in the aspirin arm wouldn't come up for follow-up because they didn't survive the surgical insult. But in a non-randomized setting, it's a problem. This is just a classic example of what all is happening in a non-randomized setting. And it gives certain advantages to a particular group, which we might not be able to think. So you'll have to really think on this, guys. This is another one. Immortal bias. Heart failure patient receiving telemedicine versus usual care. So people who receive telemedicine care survived more than who didn't. What is the thing? It takes 2 to 3 months in UK to settle this thing. So by the time people were recruited to the telemedicine arm, most of them had survived that part, whereas the ones who were not recruited, they just counted them. So it's called the immortal bias. So can we think of that? That wouldn't be the case when the moment you're diagnosed heart failure, you're randomized to telemedicine arm versus though, you won't have this problem. Because it's a non-randomized study, this bias is coming in. And this is what I was trying to link. The selection bias, all this stuff. You are taking off certain group of patients or taking off part of their follow-up and giving an undue advantage to one arm. So this is all the non-randomized study problems. And when we read it, if you don't pick up these things, you are likely to conclude in a different way. This is just my attempt at art and good. And what I was trying to say is you have these two arms. Randomization would have happened here. Whereas for patients who are undergoing surgery and coming up follow-up, then you give the drug, it doesn't work. This is what it is. If you are checking for this domain, look at what is there for low risk. All participants who were eligible for the target trial, remember the target trial, let's say the aspirin, for each participant, start of follow-up and start of intervention coincide. This is what I was trying to tell. You think about that aspirin and colorectal. What you are doing is you are in that study, everybody was given aspirin designation immediately at the point of surgery. That's what should have been done in PAL, but it has not been done. So they go one level down. Selection into study may be related to intervention. Authors they've adjusted for it. Or start to follow up or start of information do not coincide. That's what we were thinking of. But the proportion of such patients is very low. Let's say 1,005 to 10 patients do not have this kind of issue. You are ready to live with that. It's not a big issue. So that kind of a thing. As you go down, this becomes bigger and bigger problem. This is just to highlight how the non-randomized studies can get in. This is the last one which I would think. This is about classification of the intervention. So all I'm trying to do is, I'll give you an example here of vaccination status. If they were doing a study where they wanted to check in Africa post vaccination whether the kids had certain, less mortality and so on versus those who did not receive vaccine for a particular reason. This was a study they were planning. So how do you think they will capture the vaccination data? Remote place. Can you take just one guess? What do we kids have? Vaccination. Exactly. So because this was a study where they were going back, it was just ongoing. So they went to these houses, and if they had a vaccination card, vaccinated. They don't have a vaccination card, not vaccinated. In that, but in certain cultures, vaccination cards are destroyed. The kid dies because they take off all the belongings, and that's a normal thing. Just even though that kid was vaccinated, because the card was not available, the way they captured the data in the intervention was like whether the vaccine has been received or not, has recorded as no vaccination, though that kid had a vaccine. So when and how that intervention has been done, that should be clearly traceable. And in a non-randomized study, those can become a problem. So there is a classification error of the intervention. That's an example. So these are the 3-4 examples of how selection bias and how the intervention has been captured can go very differently in a non-randomized study, which can't happen or unlikely to happen in a randomized trial. Randomized trial, you would receive the vaccine upfront and then follow up, and there are no two ways about it. We won't have now, there will be a trial start and so on. So this is what I was trying to say. So if intervention status is well defined or intervention is information was collected at the time of intervention, then it is fine. It's like a randomized trial, low risk of bias. Whereas intervention is defined with some aspects of assignment of intervention were determined retrospectively, then there's a problem, goes down, and then gets worse down. So these are the ways, and the same as I said, like ROV2, you make those judgments, yes, probably, yes, no, and all. And finally, when you have those, I mentioned 7 of them, all those domains, if they are no risk of bias, that is, you have made everybody is at low risk of bias, which is very unlikely. Or you might have low to moderate for some domains. This is the final judgment of that study. What it will do is eventually it should go to the grade. And for grade, when you're doing using Robbins I, any study which is contributing to the grade is at downgraded by 2 levels to start with. Okay, that is, you come down from high quality to moderate, you're actually starting at low quality because you've included a non-randomized. But you can upgrade based on your judgment of that study. I'm just stopping at this. Please remember, when you have randomized trial, grade starts at the highest level. High, moderate, low, very low. So you can only come down in randomized trial. But when you start including non-randomized study, you start with low because you've got a big question mark on selection math. You can upgrade it based on what your judgment of those 7 domains were. In that, the first 3 are the heart of it. What we mentioned, pre-intervention and intervention. Post-intervention, it just goes on along the same as an RCT. So I would probably stop here and one question and then we move on if there's anything else. Uh, Anything to add, sir? Is it too much? Time. So essentially, it depends upon specialty to specialty. The good principle is not to use non-randomized, go only by truly, but in certain situations we can use, but then we segregate those data. It's not like you pool both. Differently is one of the ways of doing it. You don't pool together. Um, we do see many forest plots having both of them together, which is very problematic. I understand. Yeah. So grade would eventually it has to feed to grade, and what will you will bring down the whole quality of evidence, even though randomized trials are fine because of the non-randomized. We should, but yeah, only thing is like certain lot of specialties you don't have randomized or very few randomized and very lot of non-randomized. That you need to start putting. So I would just probably take you through this. Can you just open this? Just data entry. They are doing the studies and everything else, the other group, and they are taking 1 hour to that, 1.5, and then they are doing the ROB2 thing. So I'm taking data entry now, maybe a bit of putting the risk of bias. Can you just let me know if you guys have opened this? Then I'll take you through the steps because this is very important. Free lunch. Take 15 minutes extra. We'll stop at 1:15. Are we here? Okay, because I had to work around this yesterday. And we now, like for us, we are using a lot of Redman web, so we don't have to go through. But I will use this. So what I will do probably is, can you click this file? Go for new. Okay. Oh, this one opens up. Also, I just created one file yesterday, so I thought I will run through this again and then open that. Are you with me till here? Then intervention review. That's the top one. Okay. Next, I will go to full review here. Not review. Okay, fill in something. I put. Okay, I'll put. For filling crossroad. Whatever you want to do. What is the title? You got this only, no? Full review. Its default is protocol. I put full review. This is very crucial because then only we can feed the data. So I'm okay to wait here. Yeah. I just put screening hysteroscopy. Sorry, screening hysteroscopy for women under. Are you with me here? Come till full review and finish. You finish that? Yeah, I'm good. Okay. Is that what it is? Come till here? Okay. Now I'm just going to show the data entry part. So can you come to that data analysis? Are you ready? Data analysis, drop down. Right click. This is very important. I'm going slow. We reached here. And comparison. Trying to do that, there's a drop down. Comparison is process. Can put basically intervention versus control. Now with me till here. I'm going to. I think it should come now. Can you see now if you click that comparison has come? Finish. Yeah, वापस करना है. Add comparison again. Something. Next. Finish करो उसको. आ जाएगा. Okay. Is it there? I can't keep going back. Okay, this is not. You're there now? Okay. This is getting recorded. No, anyway, people can go back to that because we have lunch coming up. And so now what I'm trying to do is I'm going to stick to the first comparison only. Remember, that's your broad comparison. Now, COVID A drug versus COVID B. No one thing, it's a pairwise comparison. A versus drug B. Drug B is control. So I've just put screening hysteroscopy because I'm familiar with that, but you all have to use. But I'll show you a Cochrane example and we'll see if you reach the same output. So now you right click on that, add outcome. No, no, you just click that and both will open. Double click on the data analysis. Okay, double click. So I've come till there. Okay. If people are ready to forego the lunch for some time, we can go slow. Okay. Because that's what is separating. Yeah, yeah. So I'm just taking you through. Now we'll have one more session. Double click here, you open the outcome. The same comparison what you have just entered as now. मैं एक काम करता हूँ आई विल ओके आप आउटकम तक पहुंचे यहाँ पे कंपैरिजन चल रहा है अभी आई नीड टू बी आई विल रीच देयर सर इसको डबल क्लिक करें इसके ऊपर डबल क्लिक add comparison right click and add comparison outcome I will put right birth just put next dichotomous dichotomous आया ना उसको dichotomous डाल के you can keep going I'm here to be a light bulb next you start I put light bulb table 1 is hysteroscopy no hysteroscopy I'm not this is all like we can decide I go on risk ratio but don't worry about this it's all by default probably finish it here yeah what will come we reach here or you just that default you leave it yeah just keep doing next or I'll show you that again I'll put one more outcome I'm adding one more outcome dichotomous here I put clinical pregnancy and I'm putting next so I'm this outcome I'm repeating now I put now clinical pregnancy next you can keep this is the default I like to use risk ratio more than odds ratio I find it easier to understand even statistics. So I'll just click that, but you can leave it as odds ratio or risk ratio. Just go and click on the risk ratio. Don't do anything else. We are here. Next, the interval, confidence interval, everything is there. Subtotals you can decide. Right now, just leave it because simplicity. I just want to keep basics. Other things will be difficult to. Is that okay? Yeah. Okay. Okay. This I can change it, but I'll put left label is favoring control. Just doing it. If you are not able to do this part, it's okay. Right wala. After this, I'll put finish. Just this. I'll explain you how it is. It's the left side of the forest plot. It's a good outcome. It's a positive outcome. Usually, we'll keep the intervention on the right side. So that's why there is some. We'll look at this at some point. Just enter it as it is. Yeah. Yeah. Are we okay? Okay. 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 Got it? Feeling good about this. Okay, now I need to add the study. So I'll just add, can you click studies and references? Actually, this would have been done in your search and everything. Now I'm just going the reverse way. So you need to click to study. Okay. So have you clicked studies and references? I put references to studies clicked again, and then there was a drop down. Double click, have a drop down of included, excluded, awaiting classification. You got there? Included pay, right click, because we are interested in only included studies. Okay? I'm putting Smith 2016. Okay. So we are putting, because I have two studies in mind, I'll share the data of these two studies to fill in. So I remember the name. Just put this Smith 2016. All this would have been actually done earlier when you would have come through studies. I'm just going the other way. Finish. Add study, you click that, you get the drop down, pop up. You just put the study ID is the author name and the year. No at all. Okay. Yes. Published, unpublished, it's fine. Just keep it full. Just put finish. Study would come there. Yeah. What we'll do is we'll include one more study. Add one more study. LC Rohi. One more study. Put that included me. One more study. So, okay. So at least two studies so that you have a meta answer. That's why. NC 2018. Not that difficult. Then right click, left click, wait, just as you work around. This is an idea. Okay. Don't try to memorize now. You can find out. In fact, you'll have YouTube's also on this. I'm going to freeze this one. So we have two studies put in now, the data. Yeah. So now we have created comparison. We have kept one or two outcomes. I'm just talking about live birth and telling hysteroscopy versus flow hysteroscopy, and we are going to pull data from two studies. Yeah. So we go back to live birth. Can you reach live birth again? And open this forest plot. Come till here, you let me know. No, dana hai na? Okay. So now we got this forest plot open. Now you go here. Can you see this? If you just gently hover on that, it will show what it is. Add study. Once you click that, because we have included those two studies, it is appearing now. Can you include one by one or both together? And just so one has come, I'm going to include the second one also. Okay. Both studies are now on the. It's come in the forest plot. I'll show you again here. It is a blank forest plot. I've gone to studies which are included. Pick one, finish. You want to add another one? Hit finish. Can you see? Both are there. Can do, yeah. Basically, you can. I'm just figuring that out. I think you can scroll. You can mark out both. Yes. Are you with me until now? Okay. Now is the interesting part. I'm going to give you some data which we will just fit in, and that's more. So I'm going to open to you unless the Cochrane. This is the forest plot. We are going to get here. Okay. So this is what the idea is. So I'm going to give you the data. This is the data. Forget the clinical pregnancy. So we did the step one, getting comparison. Step two, adding the outcome, and then we are adding the studies now. Both the studies are with you. Yeah. Now let's see. I just forget the clinical pregnancy. Just take it the right ones. Okay. I'm just changing it. Otherwise, people use by birth. This data has been extracted from the manuscript. Yeah. So can you just keep this in mind? 71 and 373. So this is interventionist enlarged. Sorry. Uh, can you guys keep that? Now you people have to remember. Okay, for me, events is 71. Total in the intervention is 373. 75 events in the control arm, no hysteroscopy. 377 on the. Can you just narrate that to me? Uh, just note it down. Note it down and then I will take you through because I'm not able to open both simultaneously. अच्छा एक एक करते हैं ना स्मिथ इट ऑल जस्ट टेल मी 71 373 75 377 हाँ okay so shall we just feed that data tell me smith et al 71 is the event live birth yeah outcome what is the intervention number sir? That is actually what actually 373 is what randomized in intervention now so the data you got from the what about control See? Okay now can you give the next 102 33 101 you note it down done now tell me the first one trying to send this to all of you yesterday but doesn't have connection okay I'm just feeding so tell me the 102 and then okay so now and this first I want to check what is the result here this is the forest plot what is it 1.2 0.96 1.49 yeah I don't know हमने कुछ गलती किया okay whatever this is the output can you see that forest plot Achha, I will show you that but this is the output can you see here one by one okay this is risk ratio this is it's like this is the forest plot can you just hover in that it will come so if I click that this comes Hmm? Yeah, it's exactly the same. Can you see that? This cut 1.2, 0.96, 1.49, and that's what you guys have got. Clear? So I'll just fiddle around a bit on this and we stop. Can you see this risk ratio? So if I want to make it this difference, or more importantly, odds ratio, I keep changing it. Can you see that? Hmm? And the last bit I want to probably show is I'll just quickly take you through this. So, feeding this data, I'll just show you one. This is the last 5 minutes exercise where we are going to make a quick judgment and feed this. Yeah. So I've just gone to the studies, right click it, study characteristics. Edit that. If you click that, you will have the risk of bias table coming in. Yeah. Now we'll make some judgments quickly. Yeah. So let's say, what is your judgment for this one? Random generation sequence. Low risk. Yeah. This is allocation concealment. Yeah, it is unclear to me. Unclear. They responded like that, but we are not sure. Yeah. Now I have given the judgment reason for it. I have made the judgment and given the supportive reason. I'm just going back and asking you what is your judgment based on that. Unclear. Blinding was not done. Unlikely to have a performance bias, even if blinding is not done. What do you think it is? Or is? But वो मतलब एक hypothetical situation में where I'm just giving a thing, it is unlikely to have a performance. It's just a hypothetical thing, just for your judgment, because I want you to feed that data. Okay, both are low risk, and then I'm just going back to this attrition bias. All were followed up. What is it? Reporting bias. Everything published protocol. Everything is there. Low risk. Original sample size 300. Trial was stopped early. What do you think? It's a worry? I'm worried. Okay. Now, what I'm going to do is I'm going to use this data. Let's say random generation. What was it? Low risk. And supportive judgment will be there. I'm not feeding the data now, but just for so our judgment was low risk. Allocation में unclear था. Can you see when I click that the drop down is coming? It is unclear. Rest all were low risk. Incomplete also was low risk. Reporting was low risk. And last one was high risk. Yeah. Now I'm not going to do this, or let me finish this also. I'll just come all low risk. Yeah, you do the same thing. I'm just finishing off so that forest plot is with the risk of bias. Smith was good study. So okay. No, this is a different study at low risk for all. That was the one. So now, and I'm just going back to the forest plot. Okay. I'm just going back with this data. I've finished the risk of bias with you for both the trials. What I want to know is, I want to see the risk of bias also. So now I have clicked that. Yeah. I'll just give you an example. Now, you tell me, is the forest plot, the risk of bias appearing here? You don't know right now, looking at the forest plot, no? I'll take this off. Now I'll ask them to show me the disco bars. Can you see that? That one dabba is missing white, so I didn't fill in. Okay, but otherwise you can see because of low risk. Very good. Go. Sorry, go. You got it till there, no? Yeah. Thank you back. Yeah, you can save it in desktop.
If you would have found that first line, first trial,
Yeah.
right? Because it is the default of not all people
Yeah.
have to actually fill. If that reason, then you should program knows that you actually intention, then it will come to it.
So I think I lost that file. So these are not closed, but I think you guys are clear now. So yeah, I lost it there. Yeah. So that I think I lost the original one. The one which we had felt it is gone, but that's I didn't save it. I think it went off.
Kind of how was and that now
Yeah, automatically doing.
automatically policy.
I'm just making everything low risk. Just showing you. So this is what it is. You can see if I would have entered something, it will come. So if you enter things, it will come. What we got. Yeah, it just can take every time, but I think we'll have this exercise, but this is what it is all. We discuss risk of bias, that judgment will take time. Finally, the output you reach where you want it. Okay, in this. Save this, but I think, yeah, we have, yeah, please. Actor, I think there is a problem with that. Basically, that please remember this is not, we are just using old versions now, it's not updated. So, we just are managing to hold on to that software now, pen drive, but there are some compatibility issues with Mac. All you need to do is borrow your friend's startup laptop and manage it. Because these are all the older versions, they're not supported anymore. Yeah, if I install this in a new comp, it won't work. People are doing, yeah, it should match. Error, though, it is always going to be there. It's difficult. So that's why everybody has to do it twice. Two people are doing it. So that's all right. And there are always, if you look at the Cochrane, there's right, two people do it, and the third person is a referee. So one person, if there is a disagreement, the third person will have to take it. Never, it's a teamwork. One person, the senior guy will say this is what our end. If it's a major disagreement, then the whole team will say. You ask me peer reviewing, this is a nightmare. We can't really cross check everything, and they're all honorary. So that's why systematic reviews are very difficult to peer review. You tell me who am I? I'm going to sit and check what data I will enter. Bhagwan knows everything. Can't do anything. So if you ask me, you expect me to go and cross check that as a reviewer, we can't do that. That's possible nahi hai. So it's a thankless job. So we just expect people to do it properly. The only thing I can share with you is when we do updates for the previous review, then we find a lot of discrepancies. Oh, then we figure out why this person has entered like this, it was wrong and all that. But then it's too late. It's already that person has moved on. That's the way. So I'll stop here. That's why I kept this pre-run so that we can push this. Instead of the lecture, you would have all slept off. Thank you. I think don't get overwhelmed by what you think and what you it's a long journey. Important thing is to start it with this much. After it.
If people have settled, should we start? Yes. So, we've heard about the ROB 2 tool, bit about the ROB 1, an introduction as to how you enter data into Redman Web, into Redman Web yesterday and today in the desktop version. So, what we'll do is we have heard about the risk of bias, but the most important thing is knowing what exactly bias is. What does it mean? Anyone can explain or give me a definition what a bias means? Oh, bias, what is the factual dictionary meaning of bias? Exactly. In the context of research, this bias can have several ways where you get prejudiced or you are made to believe something which was not a fact, or there was no appropriate reason or justification behind that. This is what is bias. We'll see what is the official definition of a confounder. Confounder is when you do not have the exact relationship, but the causal effect with the effect is present. We'll go through this thing. So the title is Biases and Confounders in Clinical Trials, or call it in research. They do not have any significant uh, conflicts of interest, and we'll try to cite whatever we have been doing. So I'll walk you through the introduction, the types of bias that we have, the biases, individual biases, and if a bias is present, so how we can actually address that bias. Okay. So there are several biases which are there. If we see, there are 5 explanations for an association. Okay. Whenever you come across something, you try to associate this thing. We heard a lot about p-value. So the first thing that there anything is because of chance or a random error is something which is defined by the p-value. So this is something which is sorted. If you can believe into something or something has been proven to be either causal or reverse causal, this is proven. What you are left with is bias and confounding. So we've taken the first thing with the help of p-value that it did not occur because of chance. So the first thing is taken care of. If something was truly causal, then there is no issue. The issue remains with a bias and confounding. So how do we differentiate a random error from a systematic error? Well, as was very rightly said, that the bias that we would be considering is a systematic error. So what is the difference? There are 2 types of error that may affect the estimate of effect. A random error, which is also known as a non-differential error, something which occurs by chance. And then you have the systematic error, which is a differential error and is a true bias. Why is it important? It is important if you look at the sample estimate that you test. So you have taken a sample which was probably, possibly representative of the population. You tried then estimate out of it. There was an error associated with this. That was a random error. What creeps inside is a systematic error. If you look at the linear equation, if this linear equation you can see, you have the linear component which is there whenever you're doing the maths behind it, just for the sake of giving you the concept of random error. You always have this epsilon I, which is the random error term. So this is the term that takes care of error which is occurring by chance. At the end of the day, what now you have to look into is that there is no bias. ठीक है, तो आपने बाकी सब चीजों को देख लिया, कैलकुलेशन देख लिया, बायस बचता है. So if we see random error, it is defined as a natural periodic fluctuation or variation in the accuracy or precision of whatever you are doing. I'll give you an example that will get the concept nicely. You measure blood pressure. I take Dr. Neeraj over a period of next 30 minutes. I take his blood pressure 10 times at every 3 minutes interval. Will all the readings be same? Why? हमने बीपी इंस्ट्रूमेंट को लिया जो कि स्टैंडर्डाइज था, जो कि रिकमेंडेड था, हमारा कप साइज सेम है और हम जो ट्रेन है उसमें हम उसको मेजर कर रहे हैं. एरर क्यों आ रहा है? एरर आ रहा है बिकॉज ऑफ द फिजियोलॉजिकल मॉडिफिकेशन, फिजियोलॉजिकल वेरिएशंस, ब्रेड टू ब्रेड डिफरेंस, spontaneous fluctuations in the blood pressure. These are all the terms, all the errors, all the variations that creep in, but they are not in our voluntary control. This is what is the random error. It is because of moment to moment change because of the respiration, emotion, exercise. After 5 minutes, you will feel that I've been made a guinea pig. ब्लड प्रेशर थोड़ा सा बढ़ गया, थोड़ी देर में समझ में आया नहीं यार कोई फायदा नहीं है, आधा घंटा बैठने ही पड़ेगा, ब्लड प्रेशर थोड़ा कम हो गया, थोड़ा टेकिकार्डिया हुआ, सेटल डाउन हो गया. So these are variations which are not cause of the disease. This is what is random error. Remember this example because now we'll shift so that you can correlate, you can compare what is the difference when we are talking of a systematic error. Systematic error is a non-random variation that distorts the actual findings of the study in one single direction. It arises from an innate flaw in the data sampling technique or the measurement instrument. So both the things are important. Data sampling आप कैसे कर रहे हो and measurement flaw. We go back to the example, measurement of blood pressure. Now he was here, Dr. Neeraj is the same person. Now the sister comes, he is not trained. तो एक बार कफ यहाँ बांधा, एक बार थोड़ा सा कफ नीचे बांधा, कफ ज्यादा ऊपर चला गया, आपका जो इन्फ्लेशन सेगमेंट था दैट वाज नॉट मीडियली, थोड़ा सा लेटरली प्लेस हो गया. उसको यही टेक्निक पता है, तो इनके अलावा जितने लोगों की मेजर करेगी ना तो वो उतना एरर हर किसी में आता जाएगा. सो दिस विल बी एन एरर व्हिच इज नॉट dependent on the individual physiological variations but based on a error or incorrect. What is the second problem? आप अपना बीपी मेजर कर रहे हो उस मशीन से जो स्टैंडर्डाइज नहीं है, उसी में फ्लॉ है. कि स्टैंडर्ड मशीन अगर 120/80 ब्लड प्रेशर देती है तो ये 130/90 मेजर करता है. यही मशीन हम लेके आते हैं, क्यों कहते हैं कि स्टैंडर्डाइज्ड है, प्लस माइनस इतने का एरर है, आपने सब में मशीन यूज करेंगे, दे डू टेल यू दिस इज द एरर व्हिच इज प्रेजेंट. So if the instrument is faulty, if the technique is faulty, this is the type of bias that creeps in, and this is what is known as a systematic error. So if you are using an incorrect cuff, if you're using an incorrect machine, if you're using an incorrect technique, all these will lead to bias. So with this background, what we'll do is we'll jump on to how sample size makes a difference. Now, the importance on the very first day, Dr. Pratap very nicely told you that if you're having a good sample size, then the p-value and the precision, they are altered. Isn't it? If the sample size is large, even though difference was same, what was happening? The p-value was becoming very significant. Isn't it? तो जैसे जैसे सैंपल साइज बढ़ रहा है वैसे वैसे जो प्रिसीजन है बढ़ रहा है, जो कॉन्फिडेंस इंटरवल्स हैं वो नैरो हो रहे हैं. If you are seeing this graph, you can see it that this is the amount of error on the y-axis. This is the study sample size. As the sample size increases, the random error decreases. ठीक है, इसीलिए जो p की वैल्यू है वो 0.05 से और कम होती जाएगी और कम होती जाएगी, तो सिस्टमैटिक एरर ठीक नहीं होगा. ठीक है. इसकी इनकरेक्ट टेक्निक थी, आप उसको 10 लोग देंगे, उसको 100 लोग देंगे, हार्डली मैटर्स. If your instrument was detecting something incorrectly, whether it was for the 10 patients or the 100 patients, the error would remain same. That is the reason the systematic error or the bias remains static and is independent of the sample size, whereas the random error increases. And this is the principle behind having a sample size for the study. अगर आप sample size ठीक नहीं लेते हैं, then you are not balancing that random error which should have been balanced. ठीक है, तो जो चीज आपके हाथ में है, एटलीस्ट यू शुड बी मूविंग अहेड नाइसली. एंड हाउ डज इट ट्रांसलेट इनटू अ सिस्टमैटिक रिव्यू और मेटा एनालिसिस? इट ट्रांसलेट्स कि जब आपने स्टडीज पूल करते हो, अगर उतनी सारी स्टडीज नहीं है, जो आपको ये बोला जाता है कि अगर आपके पास एडिक्वेट अमाउंट ऑफ स्टडीज, एडिक्वेट नंबर ऑफ स्टडीज नहीं है, डू नॉट पूल द इफेक्ट, डू नॉट मेटा एनालाइज. ऐसे ही ऑप्टिमल इंफॉर्मेशन साइज एक टर्म है जो कि यूज होती है. यू विल बी इंट्रोड्यूस टू दिस टर्म टुमारो व्हेन वी आर डूइंग द ग्रेड असेसमेंट. दैट टेल्स यू कि कितना सैंपल साइज एडिक्वेट है. ठीक है, जब आप मेटा एनालाइज कर रहे हो for a individual primary study, depending upon the study, whether it is a RCT, a case control study, a cohort study, you are doing a cross sectional, उनके अलग अलग फॉर्मूले हैं, उनके बेसिस पे आप सैंपल साइज कैलकुलेट करते हो. तो दिस इज द बेसिक फंडामेंटल and it forms the background of our topic. If you look at the biases, we can divide the biases by and large into three forms. First and the foremost is occurring at the level of inclusion of patients, how the patients are getting exposed to the intervention or a variable of interest. Finally, at the level of measurement and assessment of outcomes. Okay, so we'll move systematically. So the first and the foremost thing is the sampling bias. Sampling bias is also known as a recruitment bias, and anyone wants to tell us what sampling bias actually means? Sampling bias is very important because it is one of those biases which affect the external validity of the study. Until otherwise proved, all other biases are affecting the internal validity. So if you are sampling a population, suppose I want to sample a population from this room, okay? This study has to be representative of whosoever is sitting inside. And what I do is, मैं जो बाहर टेबल लगी है वहां चला जाता हूँ, साथ वाले कमरे से 10 लोग सैंपल कर लेता हूँ. So they would not be representative of the population जिनके लिए मैं स्टडी कर रहा हूँ. If this is so, if the sampling is occurring, तो जो आप क्या कर रहे हो, अगर इंडिया की पॉपुलेशन 140 crores है, you cannot go house to house, take a sample of everyone. This is the reason why you take from the population a sample. ठीक है, क्योंकि आप सबके पास जाके नहीं ले सकते. एंड यू वांट अ सैंपल दैट इज रिप्रेजेंटेटिव. अगर वो उनको रिप्रेजेंट ही नहीं करेगा तो आप स्टडी को कैसे उस तक कोई एस्टिमेट करना है, कोई भी चीज आपको उससे असेस करनी है, यू वांट टू ड्रॉ कंक्लूजन, यू कैन नॉट डू दैट. So if the sampling bias is introduced, if the recruitment methods are not clearly described and the results are generalizable to groups that were not eligible for this study, so the sample is not representative of the general population and it compromises the external validity or generalizability. Okay, rest all other biases as a rule of thumb affect the internal validity. इसलिए इसकी importance बहुत ज़्यादा है. Amongst these sampling biases, this is a bias which is known as a Neyman bias. His name on Dr. Jerzy Neyman. Anyone has an idea what is a Neyman bias? I'm taking the historical concepts so that you get a hang of how these have been translated into the primary studies and have trickled down to the systematic reviews and meta-analysis. So the Neyman bias is also known as the prevalence incidence bias. So what happens is when you are having a look at someone who has been exposed, एक वो disease है, जैसे severe COVID हुआ, तो जो वो पेशेंट्स थे वो जल्दी एक्सपायर कर गए, वो आप तक पहुंचे नहीं. आपने जब स्टडी अपनी डिजाइन करी उसमें उस हिसाब से डिजाइन किया कि आपके पास जो पेशेंट्स हैं आप कब ले रहे हो, उसमें मैं 2 वीक्स के बाद ले रहा हूँ, और जो वो डिजीज था उसके अंदर एक परमानेंट वेरिएंट था जिसके अंदर डेथ 7 डेज में हो जाती है। तो जो पेशेंट्स एक्सपायर कर गए वो तो आपके पास पहुंचेंगे नहीं, और जो सर्वाइव कर रहे होंगे वो होंगे जिनमें डिजीज की सीवियरिटी ज्यादा नहीं हो, isn't it? This is what is the concept. A late look at those exposed or affected early will miss fatal or other short episodes, and what you will receive would be patients who are either mild, subclinical, or silent patients. So, this will lead to an underestimation of the true association. So, whenever you are looking at these studies, whenever an estimation is done in the systematic reviews, फर्स्ट थिंग इज कॉन्कॉर्डेंस। अगर आप किसी एक टाइम पॉइंट पे देख रहे हो तो सारी स्टडीज में उसी टाइम पॉइंट पे देखा होना चाहिए। दिस इज वन थिंग विच इज इम्पोर्टेंट। द अदर थिंग इज दैट टाइम पॉइंट शुड जेल विद द डिजीज अंडर कंसिडरेशन। ओके, अगर आपके पास कोई पेशेंट आया, सपोज कार्सिनोमा बहुत ज्यादा है आपके पास वो डिसऑर्डर्स हैं जैसे इंसेफेलाइटिस है। इंसेफेलाइटिस में तो डे नाइट चेंज हो जाता है एट 7 days। the patients may expire, the patients may not be in a condition to come to you। तो वो जो पेशेंट्स आपके पास आ ही नहीं पाएंगे, आप उनको रिक्रूट कैसे करोगे? तो दोनों ही कंडीशन में क्या हुआ, यू मिस दोज पेशेंट्स व्हिच वर वेरी इंपॉर्टेंट। So this is the prevalence incidence bias, and for the sake of remembering the name, this was given by Dr. Jerzy Neyman. This is also known as a Neyman bias. We have two examples. As I gave the example of stroke, अगर वो पेशेंट इतना डिसेबल्ड हो गया आपके पास नहीं आया, यू विल मिस दोस पेशेंट्स। सिमिलरली those patients who are having, you're looking at smoking or lung cancer, तो जो lung cancer के साथ who have already died because of the aggressive disease, you will miss those patients। So these are the few examples। We look on to the second thing, which is also known as the lead time bias। Lead time bias is also known as an initial completion mismatch। If you're not reading this thing, any idea into this thing, because now this is coming up as a huge problem because of a lot of things। You are having cervical cancer screening, you have screening for leukemia, you have screening for lymphomas, you have breast cancer screening। So what it is leading to? It is leading to early detection of cancer। तो जब early detection of cancer होगा तो आप किस चीज पे fault कर सकते हो? Suppose you have a female who has breast carcinoma, वो breast carcinoma यूजुअली एविडेंट होता है 2 साल पे। आप अपना प्रोग्राम चला रहे हैं स्क्रीनिंग का, वो आपने डिटेक्ट कर लिया 1 साल पे, ठीक है? तो व्हाट विल यू गेट? false sense into the survival। If that lady had to die at 5 years or 7 years or 10 years, तो जो 1 साल पहले आपने उसे डायग्नोज कर लिया, यू विल एड दिस टू द लाइफ ऑफ द पेशेंट इनकरेक्टली, इनएडवर्टेंटली। और जब आप उसको जल्दी दवाई दे दोगे तो आप ये कहोगे कि दिस वाज बिकॉज ऑफ द ड्रग। Anyhow, that lady would have survived for another 5 years, 7 years down the line, जो कि natural course of disease से define हो। I hope you understand what is the natural course of the disease। Anyone can please define what is the natural course of disease? Exactly, very good। So any non-intervened course of a disease is the natural course of disease। यदि किसी भी सूरत में आप उसके साथ कुछ tinkering नहीं करते, that is the natural course। So what happens here is you have a group 1 and group 2, which is the screening group to diagnose the cancer early, then the non-screening group, what we are leading to, you are overestimating the। So this is what is known as an initial completion mismatch। अदरवाइज को इनिशिएशन कब करते हैं? जब पेशेंट आपके पास सिम्टम के साथ आता है आती है, डायग्नोजिंग अर्ली, एंड दिस इज लीडिंग टू द बायस व्हिच इज नोन एज अ लीड टाइम बायस। हाउ डू वी मिटिगेट दिस? वी हैव सीन सैम्पलिंग में क्या क्या एरर्स हो सकते हैं। हाउ डू मिटिगेट दिस थिंग? I'm taking up the mitigation strategy so that you are aware of कि इसको काउंटर कैसे किया जा सकता है। So what you do is you do a pool data analysis, ताकि जो जो पेशेंट्स आपके पास आए उनका एक पूल बना के उसके अनुसार आप उसका इवैल्यूएशन करें। You take up the registry data इस रजिस्ट्री डेटा में आपको ये पता चले कि वो डेटा किस चीज के लिए हो रहा था. Was that for screening? Was that for when the patients presented with their clinical symptoms? Complication. You meta analyze and find. ये हम करने के लिए बैठे हैं कि हम मेटा एनालाइज करके देख रहे हैं कि क्या जिनको स्क्रीन किया गया और जो लोग फीचर्स क्लिनिकल फीचर्स के साथ आए उनमें क्या डिफरेंस था. एंड देन अप्रोप्रिएट स्टैटिस्टिकल मेथड्स और सर्वाइवल एनालिसिस. तो सर्वाइवल एनालिसिस में टाइम पॉइंट्स बनाते हैं. So what is the curve which is used for survival analysis? Kaplan-Meier curve or the Kaplan-Meier projection. So when you are looking at the Kaplan-Meier projection, आपको पता चलता रहता है कि किस टाइम पॉइंट पे ना कितने लोग डिजीज हुए या नहीं हुए. So this is the lead time bias. Now we coming on to the other bias which is a selection bias. As a word of caution, the first thing was a sampling bias. Sampling bias और selection bias में जमीन आसमान का difference है. So never confuse yourself between the sampling, जो कि first primary recruitment का step है. Then you have the selection bias. This is occurring at the level of the allocation. We have been reading about the allocation concealment, whether or not proper allocation was done or not, opaque envelopes were given or not, or a computer generated randomization was there which was done or not. Okay. So this is what is also known as a allocation bias or a self-selection bias. The investigator, if it has not been done, sir, give you an example of a nurse. She knew a lady who had, and her child had come with a severe pneumonia. तो उसको लगा इसका pneumonia severe है, इसको ज्यादा अच्छा आराम आए तो हम इसको इसमें allocate कर देते हैं. ठीक है. अगर वो proper यानी allocation concealment होता, no one was aware of कि वो इस ग्रुप में जाएगी, तो ये allocation bias नहीं होता. ठीक है. There are trials where the patients are given this option that you can be a part of the control or you can be a part of the intervention. So in those trials, जैसे lifestyle modification के trials हैं, breathing, behavioral abnormality को देखने के लिए behavioral trials हैं, where these are the types of interventions. कुछ ऐसे interventions हैं जिसमें nutritional supplements देते हैं. उन सब में क्या problem आती है? Give the participant a chance whether he or she wants to get himself included. This is a self-selection bias. उसका एक फ्रेंड है जो ऑलरेडी एनरोल्ड है, वो आप उसको बता रहे हैं जब से मैंने लिया है मेरे को बहुत फायदा है. ठीक है. तो बॉस मेरे को इसी ग्रुप में जाना है, मैं तो दूसरे ग्रुप में नहीं जाऊंगा. दिस इज अ सेल्फ सिलेक्शन. सो दिस कैन, तो पेशेंट इज एलोकेटिंग हिमसेल्फ और हरसेल्फ, तो वो उसके लेवल पे हो गया. कोई कर रहा है दूसरा तो एलोकेशन बायस कहलाएगा. दिस इज अ सेल्फ सिलेक्शन वर्सेस अ एलोकेशन. This can occur even if a RCT or the observers have been blinded. I'll show you how it is done and give you an example so that you can understand the next slide. अब आपने क्या किया कि आपने सबको रैंडमाइज किया. अब आपने जो रैंडमाइजेशन किया उस रैंडमाइजेशन के अंदर जो क्लस्टर्स बनाए, तो स्ट्रेटिफिकेशन किया या क्लस्टर्स में छोटे छोटे बनाए, 4-4 पेशेंट्स के बनाए. 4 पेशेंट्स के अगर बनाए तो 2 पेशेंट्स का अगर हो गया तो उसको पता है कि बाकी के 2 में या तो यस होगा या नो होगा. तो ये एक प्रिंसिपल इंपॉर्टेंट होता है दैट यू विल फाइंड इन subsequent slides, that even this matters, that randomization can be misleading. And we are moving on to the basic randomization जिस पे आपने most of you have gone through the BCBR course and other courses on statistics where they say that simple randomization is not fruitful, does not hold true now. Simple randomization is very powerful. What is more important is how many events you are trying to judge in a systematic review, or how many patients are you recruiting in your trial. This is which is to be remembered. I'll show you why. Okay, go through this bias and I'll touch upon that. This is another bias which is known as a admission rate bias, Bergson's bias, or a Bergson's paradox. Any idea about this? It's a epidemiology now getting translated into the systematic review and meta-analysis. Okay. So what is happening in this? This was given by Dr. Joseph, is in the name of Dr. Joseph Bergson. You're sitting in AIIMS, you start a study, that is a case control study. And in this case control study, what we did, we are sampling the patients from the hospitals. Dr. Pradap probably said multiple times how CER, control event rate, isn't it? And you know that the control event rate monitors or kind of indirectly determines what would be the final effect be, है ना? अगर वो ज्यादा है या अगर वो कम है, उसी के बेसिस पे डिफर करेगा कि दो ग्रुप्स के बीच का डिफरेंस कितना है, ठीक है? What happens when you are recruiting your patients from a hospital setting? There are chances for mixing and matching of the cases and the controls. इसीलिए जब भी आप अपनी स्टडीज एथिकल रिव्यू के लिए सबमिट करते हैं, इट्स नॉट ओनली अबाउट द केसेस, इट इज आल्सो अबाउट द कंट्रोल्स। वो आपसे बार बार पूछते हैं कि कंट्रोल्स डिफाइन करो, आप कंट्रोल्स लोगे कहाँ से? वो रिलेटेड कंट्रोल्स होंगे या अनरिलेटेड कंट्रोल्स होंगे? आप एक जेनेटिक स्टडी कर रहे हो, सिकल सेल एनीमिया एंडेमिक किस जोन में है, आप कर रहे हो, आपने कंट्रोल पॉपुलेशन किसको किया कि उसकी जो बहन साथ में आती है या भाई साथ में आते हैं उसको कंट्रोल ले लिया। विल दिस बी अ वाइज थिंग टू डू? नो, है ना? तो आपका कंट्रोल रिलेटेड होगा, अनरिलेटेड होगा, सोर्स्ड फ्रॉम द हॉस्पिटल पॉपुलेशन होगा, फ्रॉम द कम्युनिटी होगा, रैंडमाइज करके किसी प्रोसेस से लेंगे, दिस बिकम्स वेरी इंपॉर्टेंट। So when you're looking at the cases and controls, these controls that are selected, these cases that are selected are non-representative of the general population. अब एम्स के पास कौन सी पॉपुलेशन आएगी? Obviously, no one is coming to you कि डॉक्टर साहब मेरा गला खराब है, देख लीजिए, ठीक है? A lot of patients you will have who would come after they have been referred to already institute. They will come to you after they have had at least, you know, a couple of exposures. ठीक है, उसने कहीं ना कहीं कुछ करके, भले वो आयुष हो नॉन आयुष हो, कहीं भी जाके आए, पर कुछ ना कुछ दिखा के अब यहाँ पे आएगा। So this is a problem that is associated with the apex institutes. When you are getting the patient, more often than not, you do not get drug naive patients. उनको कुछ ना कुछ दिया जाता है या उनको किसी कारण से रेफर किया जाता है। आप इलाज कर रहे हो, नहीं फायदा आया कि डॉक्टर साहब हमें रेफर कर दीजिए एम्स, तो वो रेफर हो गया। So these people would not be representative of the general population, and what it will lead to, क्योंकि CER चेंज हो गया, तो इफेक्ट में क्या हो गया? रिड्यूस हो गया। Okay, so this will lead to an underestimation of the effect. Let's just look at an example. आप अगर ओबेसिटी की बात कर रहे हो एज अ रिस्क फैक्टर फॉर डायबिटीज, तो लॉट ऑफ पेशेंट्स, अगर हम हाथ से आप सोर्स कर रहे हो और उसमें आपके पास पेशेंट्स ओबीस भी आ रहे हैं, एंड ओबेसिटी इन इटसेल्फ इज एन अ फैक्टर दैट कैन predispose you or increase your chance of developing a borderline or a full-fledged diabetes. So this is one of those examples when you are taking non-diabetic patients and not defining whether those patients might be obese or not. This will be a flaw in your study. Okay. So this is what is known as a Bergson's paradox or a Bergson's bias. Now, how can we mitigate this thing? Simple randomization, as I said. And as a rule of thumb, if you have a sample size which is more than 200, you do not need to do anything. Okay. Simple randomization is good enough. आप कितनी बार सिक्का उछालोगे? Just imagine this thing. 200 का सैंपल है, मेरे पास आता है, मेरे को सब कुछ पता है स्टडी के बारे में, मैं कैसे प्रिडिक्ट करूंगा कि उन 200 में से अगले को क्या मिल रहा है? यही अगर 4 का क्लस्टर होता तो 25% चांस था जब पहला निकलता, और उसके बाद 1/3 के अंदर से और कम हो गया, 2 बचे, तो मैं 50% ऑफ द टाइम्स करेक्ट हूँ। सिंपल रैंडमाइजेशन में क्या होगा? बहुत बड़ा फैक्ट। हो सकता है आपके सारे जो केसेस हैं वो सेंटर में क्लस्टर्ड हैं और 2 एंड्स पे केवल कंट्रोल चल रहे हैं, आप कुछ उसमें प्रिडिक्ट नहीं कर सकते। इफ योर सैंपल साइज इज गुड, सिंपल रैंडमाइजेशन इज गुड इनफ। If the sample size is less than 200, then what you can do is have a block randomization. Make blocks. और blocks बनाने की ब्यूटी क्या है कि make blocks which are larger. 8 से 10 तक का ब्लॉक मिनिमम बनाइए। So as a rule of thumb, make a block of at least 10, so that जो आदमी एलोकेट कर रहा है, जो आदमी डिफाइन करने की कोशिश कर रहा है, या जो असेसर है, ऑब्जर्वर है, वो चांसेस उसके प्रिडिक्शन के मिनिमम हो जाए। Okay. So whatever block you have to consider, whatever cluster you have to consider, you should be smart enough to see whether this is applicable or not. आप जैसे पूरा ग्रुप होता है तो उस ग्रुप के अंदर ब्लॉक्स बनाते हैं। ब्लॉक रैंडमाइजेशन करते क्यों है? इट्स इंपॉर्टेंट फॉर यू टू अंडरस्टैंड दिस थिंग कि ब्लॉक रैंडमाइजेशन क्यों करते हैं। परफेक्ट। हाँ, तो अब आपने जैसे 30 का सैंपल साइज लिया, अब आपके पास चांसेस है या तो आप स्टडी शायद कंप्लीट नहीं कर पाओ, या आपको ऐसा लगता है कि उसमें इम्बैलेंस हो सकता है। तो आप क्या करोगे कि ब्लॉक रैंडमाइजेशन कर लोगे। तो आपने जैसे 6 का ब्लॉक बनाया, 6 केसेस 6 कंट्रोल। अब किसी भी पॉइंट पे सडनली आपकी स्टडी बंद हो जाती है, फाइनेंसेस खत्म हो जाते हैं, ये जैसे पैंडेमिक आ गया, तो जितने ब्लॉक्स कंप्लीट हो गए थे उनका बैलेंस तो ठीक रहेगा, है ना? जो बचे हुए ब्लॉक्स हैं उसमें मैक्सिमम इम्बैलेंस कितने का आएगा? 3 कंट्रोल का या 3 केसेस। तो जो ब्लॉक्स आप उसके अंदर कंसिडर करते हैं, आई आई थॉट दैट इट वाज नॉट रिक्वायर्ड, सो आई हैड नो। I can show you the blocking here. So what you are doing is you can make one block, you can make a second block, you can make a third block, और उसी ब्लॉक के हिसाब से इन ब्लॉक्स में अलग अलग इंटरवेंशन कंट्रोल कर लेते हो। तो अगर किसी भी पॉइंट पे स्टडी टर्मिनेट होती है तो उसके टर्मिनेशन से जो नेट बैलेंस है जितने आपने इंक्लूड कर ले, एटलीस्ट यू कैन ड्रॉ अ मीनिंगफुल कंक्लूजन आउट ऑफ इट। तो दिस इज द रीजन। यस सर। जैसे क्रॉस ओवर रैंडमाइजेशन डिजाइन है, यू माइट हैव सीन देयर आर लॉट ऑफ पीपल। क्रॉस ओवर रैंडमाइजेशन डिजाइन यूज किया जाता है। दिस इज वन ऑफ दोज डिजाइंस व्हिच आर एक्सट्रीमली ट्रिकी, वन ऑफ द मोस्ट ट्रिकी डिजाइंस when you are including these studies as part of your systematic review. Okay, there are several reasons for it. What you have to deal with is a carryover effect. आपका ड्रग का इफेक्ट तब तक जा रहा है, आपने कहा कि मैं 4 हफ्ते तक पेशेंट को इंक्लूड करूंगा, ड्रग जो था वो लिपिड सॉल्युबल था, वो फैट में था, पता चला उसको जब तक बॉडी से वो वॉश आउट उसका होगा तब तक ऑलरेडी 4 to 6 वीक्स हो चुके होंगे। देयर आर पीरियड इफेक्ट्स। एक ही पेशेंट है, उसको सिक्वेंशियली आप वॉश आउट पीरियड के बाद इंटरवेंशन दे रहे हो। जो आप बीमारी कंसिडर कर रहे हो उसका जो एक्चुअल पीरियड था, सपोज इन्फ्लुएंजा या कोविड ले लें, टेक सिंपल एग्जांपल्स। ठीक है, वेदर यू गिव ड्रग्स और नॉट, 7 to 14 डेज के अंदर आपको पता चल जाएगा, ऑटोमेटिकली ठीक हो जाएगा। इफ टेकिंग डिजीजेस लाइक दिस बिकॉज ऑफ द पीरियड इफेक्ट, जब तक उसका दूसरे इंटरवेंशन पे आएगा वो होगा कि जो पेशेंट था वो तो ठीक हो गया जबकि दूसरी दवाई ने कुछ नहीं करना था। दीज आर द पीरियड इफेक्ट्स। देन यू हैव लर्निंग और बिहेवियरल अडेप्टेशंस। People learn by intermixing. People learn from other people. If you are learning those behavioral patterns, कि आप सुबह उठ के ब्रश करो, रात को सोने से पहले ब्रश करो। लाइफस्टाइल, सिंपल लाइफस्टाइल मॉडिफिकेशन। एक ग्रुप को बोला कर रहे हैं, एक को नहीं। दूसरे ने उसको बताया है कि मैं तो ब्रश करके सोता हूँ। अच्छा, ब्रश करके, ठीक है, मैं भी ब्रश करके सोऊंगा। You're, what are you doing? What you are measuring the impact of brushing, toothbrushing on dental caries. कंटामिनेट हो गया। ठीक, आपने आजकल सीड्स का चल रहा है, आपने क्या बोला कि मैं अलसी की सीड्स ले रही हूँ, हमने बोला मैं पपाया का, आई एम टेकिंग अ मिक्सचर। वेंट अहेड विद द लाइफस्टाइल मॉडिफिकेशन। आप क्या कर रहे हो? लिपिड पे इफेक्ट्स देख रहे हो, तो आप कह रहे हो कंट्रोल पॉपुलेशन के अंदर भी जो लिपिड का कंट्रोल है बहुत अच्छा आ रहा है। ही डिड नॉट टेल यू दैट ही इज ऑलरेडी ऑन दोस सीड्स दैट यू हैव गिवन टू द अदर ग्रुप। So these are the learning and the behavioral adaptations that are there. Then there is a dropout bias. This is extremely important. ड्रॉप आउट किसी भी और डिजाइन के अंदर कभी भी होता है, दैट हैज अ लेसर इफेक्ट देन क्रॉस ओवर इफेक्ट। क्यों? क्योंकि क्रॉस ओवर इफेक्ट इज अ प्री एंड पोस्ट डिटर्मिनेशन। जैसे आप पीरियड एग्जाम्पल क्या है, जैसे जीटीटी एक ही पेशेंट आपने अलग अलग टाइम 4 या 5, यहाँ पे क्या है, प्री एंड पोस्ट इंटरवेंशन। अगर एक ड्रॉप आउट होता है तो आपके 2 इंटरवेंशन, whatever dropouts are there, that would have डबल। और जब आप सैंपल साइज कर, यही इसकी पॉजिटिव चीज है कि आपको सैंपल क्योंकि फर्स्ट participants are the whom. So, with respect to the low sample size versus a parallel design, the problem patient has to be for a longer period. जैसे 350. So he's in a trial for around about 3. This is why when you are doing a crossover randomization or evaluating a study, careful of what are the advantages and the prerequisites. So the advantages have been strict comparison, certain requirements. But the prerequisites are that the condition, Dr. Ram had already alluded to this thing, that the condition should be chronic or stable. जल्दी alter ना हो. The intervention effect is reversible or transient. It has an effect that stays in the body and has some component soluble that's bound to stay. Be skeptical when you are evaluating such studies, and outcomes can be measured relatively quickly. So, जो total problem. The other thing that is important is what can be the types. We look at the single dose pharmacokinetic. तो ड्रग्स हमारे पास वो आते हैं बॉडी में रिटेन के पास स्टडी आ रहे हैं longer acting wash out, that is the samples in their now the cluster randomization design happens when taken an sample of family, the family cluster. It is there are actually just the demographics, the socio-economic of practices. And within that cluster, change the things. As said, 5 people are a family. You have to take this thing, take the other thing, third thing, how supplementation. एक ही घर के अंदर 5 लोग 5 खान 5 तरीके practical. Science, whatever changes, then you have intra-cluster correlation bias. This is the same. तो एक आदमी दूसरे आदमी के behavior influence करेगा. Similarly, you may have a contamination differential loss of follow-up at the cluster. So suppose if you have a cluster that was filled with a now that cluster some family they left for some reality they dropped out of the what is happening out of last but not the least it is extremely difficult just for the co to एक फैमिली तरीके से सारी चीजें इकोनॉमिक आपके उस काफी नहीं बट ज्यादा this leads to a lot of the types of bias for the sake of no, you will not come across them they're not more types of bias but rest of them are very coming on to the all bias which is also known as the bias. What happens is for doing this control or a study आपको होगा कि हम क्या करेंगे what happens आपके पास try to go. What are the chances? Carcinoma based occupation problem only. I say, one question. So compared to the controls without the case is likely to provide an extensive and complete of the true. लेकिन आपकी तबीयत खराब हुई तो आपने बोला प्रॉक्सिमिटी को जो प्रॉब्लम हो सकता है आपको दे आएगा टाइम की से फैक्टर that will come the other than so it's the mitigation strategy तो एक हमारे पास मिटिगेशन करेंगे रैंडम तो हम दो सारे हम not go through tell you important तो आदमी बात और क्वेश्चन कोई बात as doctor we have this tendency अगर कोई आदमी से तो और more get out of साथ के साथ तो कोई क्या what is required is either a participant in the case or a person who is having person who should be स्टैंडर्ड क्वेश्चन है कि आपको ये सवाल पूछ पार्टिसिपेंट कोई होगा कोई ईमानदारी से you be having a check on the number for delivering or favor then data gatherers should be able to use the same memory aid same memory aids में ज़्यादा वेट बाढ़ आ गई आग लग गई सब की रैली थी एक दिन पहले आपको हुआ एक दिन बाद में हुआ तब दी यूज साथ में आप होती और नहीं तब दी इवेंट तो आपको ये पता होगा अब हुआ मेरे साथ दिवाली से 2 दिन पहले तो वो भी एग्जिस्ट in mitigations. Now the observer bias is defined. Important here is few outcomes are independent of an effect to यहाँ पे वो outcome आदमी ऐसे घटे लाइफ इज अ लाइफ इट इज दैट हाईएस्ट एडमिशन है ना पेशेंट बड़ी बात है क्या तो रेजिडेंट ने कहा कि बहुत बस आज बहुत कम है मैं रोज इन्वेस्टिंग आप और आपको ऑब्जर्व करना है मेरी बहुत प्रॉब्लम आपका वहां पे कहना तो यू एक्टिव केसेस कैन बी simple when you have an objective basis or to very important here कि अगर ऑब्जर्वर बायस होता भी है, you have a study tomorrow in the हम उस स्टडी में डेप्थ के साथ आप उसको fit नहीं कर डेप्थ का असेसमेंट आप जैसे पावर देख तरह के जो तो आफ्टर पेज तो we have a lady here एक स्केल लगाया इन्होंने बट इसके बियॉन्ड स्टेबिलिटी अब आप उसको plenty of evidence अब आपने कहते एक पैन का ब्लड शुगर बहुत कंसर्न जो आ रहा है plenty of evidence sir few charts now this is not moving last one what you are name so this is observational bias this is also known as Hawthorne effect सब चीजें हाँ else Hawthorne था क्या ऐसे just because so that point of idea के इंस्ट्रूमेंट्स होते हैं करते हैं है कि साहब अब हम ऑब्जर्व नाउ पर अंदर के भले कार भी ना have this idea that कैमरा होगा या नहीं तो जो मैंने पाया और तो कीपिंग tab on प्रॉपरली स्ट्रेटेजी अपनाई तो ओवरऑल प्रोडक्ट हम उसको प्रैक्टिकली कैसे करना तो ऑब्जर्व दवाई खाओ ट्यूबरकुलोसिस के लिए इट वाज डन आप अपने सामने जब क्या आते जो आयरन ऐसा मत आशा वर्कर आने के लिए दिस इज व्हाट इज नोन हमारी जो ये है हमारे आज के समय पे वन ऑफ द हैंड वॉशिंग स्ट्रेटेजी ताकि टेस्ट ज्यादातर जो आपके वॉच तो उसके अंदर तो उस समय पे आदमी को जैसे जैसे रेफरिक्स चला अगर आज वही चीज वापस स्टार्ट हो जाएगी कि गिव दिस एग्जांपल वर्कशॉप आप अपने आपके घर हाथ धो के wash your hand out this I can do anything no but if you can do this कि आप हम आपको मॉनिटर कर रहे हैं मींस whether you are using mitigation क्या आता है mitigation this I have done myself right monitoring of the soap and sanitizer yes it's the true thing We have a separate washroom. There's own, and we monitor the use. वो soap 6 हफ्ते तक घिसता नहीं. That tells you that marker of whether variable under consideration. अगर आप उसको डायरेक्टली ऑब्जर्व नहीं करते, आप ऐसे ऑब्जर्व कर सकते. आपने सैनिटाइजर की बॉटल तो 1 ही लीटर की आपकी आएगी, 500 ml की आएगी. वो अगर पड़ी है यूज बात है, कोई पॉइंट आपको ज्यादा है. बस अगर आप कोशिश तो आप लिक्विड बॉटल पर निशान लगा दो, ये फर्स्ट मार्च का निशान है. Strategy that you use the proxy. You're doing this thing to mitigate if you really want. Attrition bias is simple. The dropouts को ध्यान. If the attrition is very, it is counting for that. है ना? वो बताता है आपकी से बाहर गए. So to be on the safer side, always that has been before or not. The other thing is that all the reasons besides this thing that include important. An indirect marker of probably the mitigation. Then there are other things logistic. हमारे पास गाड़ी नहीं आ पाए, हम आगे have all these. But considering now the thing is, तो हम प्राइमरी स्टडी के लिए किया था. जब हम सैंपल साइज लेते हैं तो सैंपल साइज कैलकुलेट क्या करते हैं, कैलकुलेट करते हैं. हर चीज लैब है, लैब में क्या हो सकता है कि लैब के सैंपल आपने लगाया, आपकी खराब हो गया. Less than 5 to 10. तो जब आप सैंपल साइज कैलकुलेट करते हैं, have this fear for this thing. आप सैंपल कैलकुलेट here, dropouts in my study will अब आगे community based study आपको लगता है lot of sample whatever maybe back end around 20 your sample for the attrition always so less than time attrition is good percent. And then there are few critical procedures. तो ये ज्यादातर जितने पढ़ेंगे उसमें 2 प्रोसीजर्स और few. Anyone what is the difference? Not good. All these things. ठीक है. उन्हें कम को ही when you said an idea is the difference. So suppose you started with 100 patients. There were 90 completers in the treatment group as well as in the placebo group and drop. There were 54 responders in the treatment, 56 responders. what happens with first group? The intention to the denominator does not take into consideration when you are looking at the per protocol analysis. Denominator will take of 100 is out of, if the denominator is low, it would be higher. But you are not performing an intention to or overestimate. There is a confusion, and as sir said that for purists, otherwise proof is the two analysis आप कर सकते हैं. But typically what you have to do, report. Suppose does not make take a lot of analysis. जैसे आपने click किया तो intention protocol आपका हो. It does not take a lot of effort. Putting both the things does a lot that is end user. अगर वो end user policy में एक analyst एक कौन end user है, think about this thing. As I said, that intention to treat population is the method of choice of primary analysis. Per protocol is reasonable strategy for sensitivity. So then there is the misclassification bias. So what are the misclassification bias? आज आपने ROB की, ROB करते हो क्या किया आपने? इस पेशेंट को जिसमें डालना था और में डाला. से ही प्राइमरी एनालिसिस जब हो रही, उन्होंने क्या किया? इस पेशेंट स्टेज 1 का पेशेंट. So this type of misclassification can be there at the type of or at the not the bias. Bias do not have to mug them. But when you are in asked you the system, but you should that you would, what is the mitigation strategy? हम क्या सिस्टमैटिकली करते आ रहे हैं? हम दो आदमी हो. आदमी क्या, अगर आपके बीच accordance है, the first and the foremost is entry cross check mechanism and data validation कर रहा है और validate जब हम दो आदमी बैठे फिल करते हैं दो आदमी की. The third thing is cross linking का क्या है? एक पेज अब उसने एक जगह अपना अलग है, दूसरी now you have link आपको एक जगह से आपको डेटा but to at least one data the other of the that is being the end is just to highlight you may have measurement by some practice common example update आपके पास फॉर्म में ले रहे हो AIIMS के नंबर बहुत यूज हो. तो इफ आर देयर और आपने इस तरीके से कंबाइन जस्ट यू आर गोइंग फॉर एसेंट एनालिसिस अगर आप नहीं या इनकरेक्टली आप ये सोच रहे हो फिर तो आपको वही then that will be a gross part. You have a spectrum bias. They have already एक स्टेज का एक last one is different protocol. आएंगे तो आपने थीम क्या एक ट्रीटमेंट को कंपेयर नहीं कर सकते, आउटकम को कर देते। अगर को ट्रीट होना एप्पल्स विद एप्पल्स लॉस नहीं हो, हम एक है तो आउटकम अब आप कर सकते हो रिजीव को कंपेयर। amongst the last parts, तो अब हमने जैसे जैसे पेशेंट आया हमारे पास हमने किया, हमने जो पब्लिक has already been discussed, positive findings or the likelihood wants that the sponsor wants to push his drug. I will mitigation क्या है? ऐसे हमने प्रोफेसरों का बोला कि कोई आदमी आपका सिस्टमैटिक रिव्यू आपने कुछ सारी स्टडी तो रजिस्ट्रेशन होना चाहिए so that if you are getting तो कॉल एक और इम्पोर्टेंट चीज just what about languages have not been अगर रजिस्टर्ड होंगी तभी पक्का हो गया ये जब हम सिस्टमैटिक रिव्यू रजिस्टर अगर वो स्टडी पब्लिश नहीं हुई लेकिन वो उस टॉपिक से रिलेटेड थी तब या तो उसका there are few yes you but you will understand what are the biases which you observe directly with हम कहेंगे सर्च बायस आपने सारी के सारे as per the algorithm वो so the search bias or a search related then there is the time lag bias. The time lag bias is all those studies can occur in two. First, from positive cut off दिया, they say that you provide a cut that I'll be taking all studies from first object. और जो negative studies के बाद आए तो उसी से related. Next session हम क्यों बोलते हैं अलग डेटा गवर्नमेंट में next session क्या आ गया के बाद क्या कर रहे had a cutoff. That cutoff had appeared in PubMed was not available. Had not been searching the PubMed. This is a specific type of bias, and what finds this is a timeline of the usko. Last one is hacking or selective analysis. Hacking is if you tinker with this, individual studies जो आपकी थी अपना डेटा और this is if you not account for this for doing ROB for general overview of analysis, extract. This is what is known as but it leads to can shift in 1 to 1 positives. Coming on to the second parts, that is anyone is confirmed. Here, a simple definition is, and in the very first slide discussed, I've explained confounding variable or a confounder as such is a variable that correlates into with both the exposure and the outcome, but is not a part of the can be a major problem with any observation having mathematic reason. What did we talk about analysis और analysis आपके पास आप जरूरत tables and the like have some sensitivity. So type should be over include overfitting. So causal diagrams, triangle as a detected case graphs. There's a visual representation of the causal tips need to exist between the people of and so just see said that it correlates with the causally related to the dependent. So what do you what is where? This was a study that rate of ice cream consumption is directly related to the number of some is the temperature to nahi sir at the rate of ice cream consumption is related to the number sunburns. Sunburns the exposure is the such differences have been better to create. So here hot temperature correlates with the dependent variable. The temperature is chances, but hot temperature is causally related to और हम स्टडी का ये वाला पार्ट शो कर that is just have a look. So this is another example. Socioeconomic status is directly related to the child's the likelihood that those people who are well off, parents' education status are true. So the likelihood that they are more educated would actually, if not, reach their founding here is if you are not considering the parents' education, this is just move specific thing. Of coffee is related to coronary. Causal education in terms of the good those four very ample from on people who drank coffee or smoke. If you're missing on to this variable, there's a confounding in say coffee. No one wants this. Then you have to interpret the last alcohol is directly related. So whether it is do you see that alcohol show they have to be extremely critical. If you did alcohol consumption, just things in context, your gene, your age, head, gender, and post menopause. How this is about planning this. You have types of that is this is and a post. That if you are looking at before and after, this is important. So इसलिए important है we are looking at the randomized sequence generation and allocation. Observers are going ahead with the I keep over them. Action attainment. This is by fitting up. This is why I always said what was the randomized or not with really said that single, double, triple investment sponsor participate, labeling them important rather than just as good as the three. Those three are not critical. Isn't it? Is this important in a country? I'm giving यार ये तो कहाँ से ये तो डिग्री कोई भी ले आएगा. Blinding might just be a number. पर blinding है. जैसा मैंने सफाई वाले को ब्लाइंड कर दिया था, ड्रग लेके आता था उसको ब्लाइंड कर दिया था, और जो खाना लेके लेडी आती थी दिस इज माय ट्रिपल. You do not have the participant, not have the player, you do not have the or the so this is thing that you take of the numbers tables. So the selection bias and the we have already discussed they may have type 1, type 2 error, this selection mitigation strategy with the gap. These are problems. Not included. So there is no match on the participant. Several cases you find. आपने क्या किया हम मैच कंट्रोल ये जेंडर में तो एक ही कोहॉर्ट से लेना है, एक ही कोहॉर्ट का एक ही स्मोकर्स का ही ग्रुप एक साल से स्मोक कर रहा था जेनेटिक्स के साइट ऑफ him being a smoker क्या इफेक्ट था randomized they've already these are statistical apps and has become very powerful. So we have two types of error. Static error and a random error. We have systematic errors or biases which are non-random variations of findings of a research in one direction. Biases and confounding are common potential explanations have to do such the understanding interactions is a workshop. What is a observation? It's been named as well. This happens with a lot of students. I'll predict for next. What is as a quad? I design a that I want to confirm. I will take other belief. This is the time I am exception. फिर हम next. तो मैं सोच रहा था बोलने. I do. We trust it. But this is I highlight my thought. I publish. I highlight those first in context on. People should have. This is this one. We're going with it. Up to application. Not the all of the biases are often I feel it then. Ah, so that, I think we should have a couple so that and if they have their brains open, I go.
Sir, for such an amazing talk. And I would like to invite everyone for the tea break, and we'll continue after the tea break. Thank you, everyone.
Even yeah, okay. Other scheme, I said, रेंडर किया आपने मौका लगाया अभी उनको को क्या कंट्रोल ग्रुप पे आपने और रेंडर अभी है एप्लीकेशन अब यहाँ पे एंट्री में कोई अपने आप अभी प्रयत्न तो अपना उस नेटवर्क में के अंदर आप एंटर नहीं तो मेरा मैं अपना आइडिया चाहिए रिव्यू हाथ में
लास्ट ऑप्शन हाईलाइट फाइल में हाँ हाँ कल व्हाट्सएप पे बाकी चीज शेयर करी थी ना पीडीएफ शेयर की थी व्हाट्सएप ग्रुप में भी कुछ शेयर करी थी नहीं हो आप उसको क्लिक करोगे तो क्या है फिर मैक्रोज वाली इशू आ रही है ना मैं आपको मैक्रोज go on file को क्या होगा मैक्रोज जिसका इनेबल आ रहा है फाइल से डाउनलोड हो गई क्या करें डाउनलोड क्या है मैक्रोज इनेबल करने के लिए क्या करें किसी मैक्रोज वो डिस्प्ले आ रहे हैं फिल करना है आप इस पे देखो एक फाइल का ऑप्शन आएगा क्लिक करो फाइल के ऑप्शन के बाद से लेफ्ट हैंड साइड में एक हाथ में ऑप्शन का क्लिक देयर ऑप्शन क्लिक करने के बाद से देयर इज अ ट्रस्ट सेंटर लास्ट में ट्रस्ट सेंटर का ऑप्शन में फिर जाओगे ट्रस्ट सेंटर हेलो फाइल के ऑप्शंस पे गए आप फाइल के बाद क्लिक किया तो ऑप्शन आएगा लास्ट में लेफ्ट हैंड साइड पे बॉटम पे देन देयर इज एन ऑप्शन ट्रस्ट सेंटर विल बी कमिंग है ना यहाँ तक आए अगर मोर करके देख लो और उसमें एक ट्रस्ट सेंटर का सेटिंग्स का ऑप्शन आ रहा होगा उसको क्लिक करोगे आप तो यहाँ पे ये 4 डॉट्स दिख रहे होंगे उसमें इनेबल ऑल माइक्रोज जो लास्ट वाला ऑप्शन है इनेबल ऑल माइक्रोज ठीक है ये ट्रस्ट सेंटर की सेटिंग्स में इनेबल ऑल माइक्रोज कर दो उसके बाद वापस फाइल क्लिक करके देखो खुल जानी चाहिए फाइल जो डाउनलोड करी है उस पे ये फाइल पे क्लिक करना आप एक्सेल ओपन करोगे तो वो लिख के आएगा उस पे एक फाइल का ऑप्शन लेफ्ट हैंड साइड पे ऊपर दिख रहा होगा उस पे क्लिक करने के बाद से इसमें एक्सेल फाइल में एक ऑप्शंस का ऑप्शन आ रहा होगा लास्ट में इस ऑप्शंस को आप क्लिक करो देन ट्रस्ट सेंटर का एक ऑप्शन आ रहा होगा देन ट्रस्ट सेंटर के अंदर फिर एक क्लिक करने पे ट्रस्ट सेंटर सेटिंग्स का ऑप्शन आ रहा होगा देन इनेबल ऑल माइक्रोज का ऑप्शन यहाँ पे क्लिक करना है लास्ट वाला हाँ लॉगिन तो फिर आपका उस पे लॉगिन नहीं होगा माइक्रोसॉफ्ट वर्ड उस पे हाँ हाँ वो अभी उस पे हाँ उस पे आप वर्क करना बताएंगे यहाँ तक हो गया अगर किसी का नहीं हो रहा है तो वो अपने कोलीग में देख ले क्योंकि फिर टाइम ज़्यादा वेस्ट होगा तो यू कैन सिट विद योर कोलीग हाँ ऐप में हो जा रहा है ना तो you can help someone create. We can start. So in the morning session, what you have learned is the morning session you have learned about as. In the afternoon session you have learned about as. So in the evening session you will be as. तो आज पूरे दिन बैच ही पढ़ाया गया है लेकिन एक डिफरेंस था कि दे आर जो टूल असेसमेंट का है दे आर टू टाइप्स ऑफ टूल आरओबी 1 एंड आरओबी 2 आरओबी 1 वाज टेकन बाय डॉक्टर कामत उन्होंने आरओबी 1 जो बताया वो रेगमन का जो डेस्कटॉप वर्जन है उस पे काम करता है बट अब जो टूल यूज होता है 2019-26 दैट इज अ टूल व्हिच इज आरओबी 2 टूल एंड द रेगमन व्हिच इज यूज्ड इज रेगमन वेब बट ये अभी उससे इंटीग्रेट नहीं हुआ है तो इसीलिए ये एक्सेल फॉर्म में इसमें डिस्प्ले कर रहे हैं कि कैसे ये वेव सेलेक्ट करते हैं एंड देन हाउ यू कैन जनरेट द बायस टेबल और फिगर तो the simple there are some fundamentals regarding this tool that RB2 tool has some series of domains अगर हमें जितने भी डिस्क हमने पढ़े हैं उसको हम 5 कैटेगरीज में अलग अलग सेलेक्ट करेंगे इसमें टूल में there are 5 domains under which you have to okay. आप बैकग्राउंड में से कर आप बाद में कर लेना अभी हम टूल जब चालू करेंगे ना फिर से दिखा देंगे वो ये आप लेक्चर्स के बाद में भी हम डेमोंस्ट्रेट करेंगे बिकॉज इट वाज अ फ्री टाइम तो in ROV2 tools we have to select in 5 domains so there are 5 domains and in 5 domains we have to see how, what is the risk of bias so 5 domains कौन-कौन से हैं the first one is related to randomization process जो हमने first पढ़ा तो जो हरदीप सर का भी लेक्चर था उसमें there was in randomization there was allocation concealment and the process of randomization the second was bias due to deviation from the intended intervention सेकेंड स्टेप क्या होता है जब हम रेंडमाइज कर देते हैं तो इंटरवेंशन ग्रुप में पेशेंट चले जाते हैं तो देयर मे बी so the second domain is regarding deviation from the intended interventions so it is concerning to the blinding of the participants in participants or caregivers or assessors the third is bias due to missing outcome data तो जो भी डेटा मिसिंग है उससे रिलेटेड जो बायस आएंगे वो थर्ड डोमेन में फिल किए जाएंगे तो फोर्थ विल बी बायस इन द मेजरमेंट ऑफ द आउटकम तो जो भी आउटकम मेजरमेंट्स के टूल थे इंस्ट्रूमेंट थे पर्सन थे वो सारे जो है फोर्थ डोमेन में फिल करे जाते हैं एंड देन फिफ्थ इज द बायस ड्यू टू सेलेक्टिव रिपोर्टिंग कि हमने जो अपना काम तो बहुत सारा किया लेकिन रिजल्ट्स कुछ सेलेक्टेड ही पब्लिश किए तो दिस टूल this is the just a flow diagram of what I have said. So in ROB2, you will be having in each domain you will be having signaling questions. कुछ उसमें questions होंगे. उस questions के answers में yes, no, not implementable इस तरह से या not defined इस तरह से options आएंगे. And then you have to choose that option. And there will be some judgment about risk of bias you will be judging on that tool and there will be free text boxes also जिसके अंदर आप टाइप भी कर सकते हैं कुछ इन्फॉर्मेशन हो एंड इवन यू कैन सेलेक्ट अ डायरेक्शन अगर आपको लगता है कि किसी पर्टिकुलर बायस की वजह से फेवर कर रहा है किसी इंटरवेंशन को तो वो उसमें लिख भी सकते हैं और छोड़ भी सकते हैं वो टूल जो है वैसे ही उसको असेस भी कर लेगा अपने आप So there, what are the signaling questions? So there were 5 domains and there are 5 signaling questions. Yes, probable no, no, and no information. So you have to select either of these options. And after selecting these options, that particular the bias of the overall bias will be either low risk of bias, some concerns, or high risk of bias. So the tool has an algorithm which will map automatically what you have entered. फ्री टेक्स्ट बॉक्स में आप उससे रिलेटेड इन्फॉर्मेशन कॉपी करके भी लिख सकते हैं, टाइप करके भी लिख सकते हैं, जिस भी आर्टिकल से आप देख रहे हो, जिस भी आर्टिकल को। डायरेक्शन ऑफ बायस, तो एक्सेल टूल आपको दी गई है, जब आप उसको ओपन करोगे, अभी अभी नहीं करना, जब बताएंगे, then you will have this type of window in which all these informations has to be filled, and there are domain 1, domain 2, domain 3, domain 4, domain 5, and an overall bias. Then overall bias is showing the colors of all the domains, whether it is low risk of bias or some concerns, and then overall risk of bias of judgment. आरओबी 1 में क्या था? जब हम रिस्क ऑफ बायस एसेस करते थे तो वी वर असेसिंग फॉर अ पर्टिकुलर आर्टिकल, एक स्टडी का कि ये पेपर जो है उसमें रिस्क ऑफ बायस है नहीं है तो कैसा है ना, बस इतना। आरओबी 2 में क्या चेंज हो गया है? द रिस्क ऑफ बायस इज टू बी कैलकुलेटेड और मेजर्ड और इनपुटेड फॉर ईच आउटकम। मतलब अगर आपने अपनी स्टडी में 10 आउटकम दिखाए हैं कि हम मोर्टेलिटी भी देखेंगे, अर्ली हॉस्पिटल डिस्चार्ज भी देखेंगे, अगर हम उसे पेन के स्केल पे भी मेजर करेंगे, जितने आउटकम्स आपने डिफाइन किए हैं उन सब आउटकम्स का, अब वो पर्टिकुलर आउटकम्स हो सकता है कि हर स्टडी में ना हो, मतलब मे बी की पॉसिबिलिटी कि यू हैव टेकन 10 आउटकम्स and you have finally arrived at around 18 randomized controlled trials, which will be having in some articles there will be 5 outcomes defined. तो 5 ही outcome के बारे में उन्होंने बात की है, 10 के बारे में बात नहीं की है। For each outcome that some has 5 articles you have to see, in some you have to see only 3 articles for each outcome. The number of articles or RCTs which will be seen will be different. ठीक है, समझ में आ रहा है आपको? ठीक है, सिंपल सा है कि अगर आपने एक, जब आप स्क्रीन करते हो, इंक्लूड करते हो, तो क्या करते हो कि जितने मैक्सिमम आरसीटी हो सकते हैं सबको इंक्लूड करते हो। जब आउटकम्स आपने ज़्यादा लिए हुए हैं, 3 लिए, 4 लिए, 5 लिए या 10 लिए हैं, क्या होगा कि नंबर ऑफ आर्टिकल्स भी बढ़ जाएँगे। किसी आर्टिकल में हो सकता है आपने जो 10 आउटकम डिफाइन किए हैं अपने मेटा एनालिसिस के लिए, वो आउटकम जो है, उसमें से 2 आउटकम के बारे में उसमें इन्फॉर्मेशन हो, सारे के बारे में नहीं हो, लेकिन तब भी वो स्टडी उसमें इंक्लूड हो जाएगी। ठीक है? जब स्टडीज़ इंक्लूड हो गई, अब व्हेन यू आर टॉकिंग अबाउट वन पर्टिकुलर आउटकम, अगर हम डेप्थ के बारे में बात कर रहे हैं, तो हो सकता है कि जो सारी आर्टिकल्स हैं, सारे आरसीटीज़ हैं, वो उस पर्टिकुलर आउटकम को उन्होंने नहीं मेज़र किया होगा। या आर्टिकल से हो सकता है कि उसमें से 10%, 20% या 50% आर्टिकल्स ही मेज़र किया होगा, तो उन 50% आर्टिकल्स में ही आपको रिस्क ऑफ बायस उस पर्टिकुलर आउटकम के लिए निकालना होगा। तो थोड़ा-सा डिफिकल्ट काम हो गया। पहले था कि आपने आर्टिकल्स आपके पास अगर क्युमुलेटिवली अगर 20 है तो 20 जिसको बायस कैलकुलेट कर लिए, हो गया काम। फिर यहाँ पे आउटकम पे डिपेंडेंट है, और हो सकता है कि हर आर्टिकल को आपको 2 बार 3 बार देखना पड़े और सीइंग डिफरेंट आउटकम्स, डिफरेंट आउटकम्स में रिस्क ऑफ बायस क्या है। इन्फॉर्मेशन यही देखी जाएगी, लेकिन आउटकम वाइज़ देखी जाएगी। ठीक है? जो आर्टिकल्स में वो आउटकम नहीं डिफाइन होगा, उसको हम नहीं देखेंगे, उस आर्टिकल्स के इन्फॉर्मेशन इसमें नहीं डालेंगे। तो proceeding further, so this will be the window which will be visible. This is the format जिसमें की information आती है, and a crib sheet is also there which has some information regarding different questions. And this is the risk of bias. So we will be talking about a study which was published regarding steroid intervention in COVID patients. तो उसके बारे में हम लोग सिर्फ एक मोर्टेलिटी आउटकम लेंगे। मोर्टेलिटी आउटकम है 120 डेज मोर्टेलिटी में। Okay, so standard of care versus steroid, corticosteroid versus standard of care, and the one outcome what we have chosen is mortality at up to 120 days. 120 days up to 120 days लेने का क्या फायदा है? अगर 120 डेज लेंगे एट 120 डेज, तो फिर अगर किसी ने स्टडी में 120 डेज नहीं किया है, 90 डेज किया है, तो हम उसको उसमें इंक्लूड नहीं कर पाएंगे। अप टू डेट का मतलब क्या है? ऑल द स्टडीज में 120 डेज तक का डाटा है, उसको हम इंक्लूड कर पाएंगे। So coming to the, so you can open the Wagner paper PDF, Wagner PDF जो था ना आपके पास, वैगनर का PDF आप खोल लो। एलिटिफार्ड, मंच और जेरोनिमो, ये 3 PDF और वैगनर का PDF, ये 4 PDF आप ओपन कर लो। Yeah. कमिंग अबाउट बैकग्राउंड की, जो हमने वैगनर का स्टडी चूज किया है उसमें व्हाट वी आर डीलिंग अबाउट, तो द टाइटल ऑफ द दिस comprehensive meta analysis was systemic corticosteroid for the treatment of COVID-19, equity related analysis and up to date on update on evidence। ठीक है, ये रिव्यू, लेकिन इस टाइटल से बहुत इंफॉर्मेशन अभी हमें नहीं मिली कि क्या सर क्या है। तो what we can see is, can proceed to page 1 where abstract is there. So in abstract, there is a little bit more information that on in the objective section to assess whether and at which dose, whether and at which doses systemic corticosteroids are effective and safe in the treatment of people with COVID-19। पहले सेंटेंस में ही उन्होंने पॉपुलेशन क्या ली हुई है? पेशेंट विद COVID-19, सिस्टमिक कॉर्टिकोस्टेरॉइड्स विद, मतलब हो भी सकता है और विदाउट सिस्टमिक कॉर्टिकोस्टेरॉइड भी हो सकता है ट्रीटमेंट, वेदर एंड एट विच डोज, और अलग अलग डोजेस भी हो सकती हैं, ठीक है, एंड ऑल्सो इफेक्टिविटी एंड सेफ्टी। तो साइड इफेक्ट्स भी इसमें आ गए। टू एक्सप्लोर इक्विटी रिलेटेड एस्पेक्ट्स इन सब ग्रुप एनालिसिस, इन्होंने सब ग्रुप एनालिसिस भी करेंगे, एंड टू कीप अप टू डेट एंड द इवॉल्विंग एविडेंस बेस्ड यूजिंग अ लिविंग सिस्टमिक रिव्यू अप्रोच। मेथड जो डिवाइस किया है उन्होंने, कोविड-19 स्टडी रजिस्टर, सेंट्रल, एमबीएस, पबमेड, क्लिनिकल ट्रायल्स, ये सब देखा है, ठीक है। तो दिस इज एन ओवरव्यू ऑफ द स्टडी। So what we are going to talk about is, you can see in the result section, page number 2, that there are different types of results. So इन्होंने क्या लिखा है यहाँ पे? He included 16 RCTs in so many participants. उन्होंने RCT कितनी ली? 16 RCT. And there was hospitalized individuals with a confirmed or suspected diagnosis of COVID-19. And one outcome which we are seeing is systemic corticosteroid plus standard of care versus standard of care plus minus placebo। दो ग्रुप्स कौन से हो गए? एक तो कॉर्टिकोस्टेरॉइड है, सिस्टमिक कॉर्टिकोस्टेरॉइड, और एक है स्टैंडर्ड ऑफ केयर। और उसमें हम एक आउटकम सिर्फ अभी जिसको बैच मैसेज करेंगे, दैट इज द एविडेंस इज वेरी अनसर्टेन अबाउट द इफेक्ट ऑन ऑल कॉज मोर्टेलिटी अप टू 120 डेज, आरआर लिखा हुआ है वहां पे, विद कॉन्फिडेंस इंटरवल। इस आउटकम को हम कैसे भरेंगे वो दिखाएंगे, ठीक है। नेक्स्ट, कमिंग टू पेज नंबर 5। तो आउटकम्स, जो रिस्क ऑफ बायस हमें करना होता है, वो किन आउटकम्स को हम करते हैं, किनको चूज करते हैं, इसके लिए इंपॉर्टेंट होता है ये, देयर इज अ समरी ऑफ फाइंडिंग टेबल्स। तो जो जो समरी ऑफ फाइंडिंग टेबल्स में आप डिस्क्राइब कर रहे हो, जो आउटकम डिस्क्राइब कर रहे हो, उनके रिस्क ऑफ बायस मस्ट हैं, दैट शुड बी डन। तो इसमें समरी ऑफ फाइंडिंग्स टेबल नंबर 1 में यू कैन सी ऑल कॉज मोर्टेलिटी अप टू 120 डेज, ठीक है। इस समरी ऑफ फाइंडिंग टेबल में आप आओगे यहाँ पे, तो देयर इज अ सर्टेनिटी ऑफ एविडेंस ग्रेड, ग्रेड में ग्रेडिंग इज वेरी लो, ओके, एंड देयर इज अ सुपरस्क्रिप्ट बी, ओके। इसी टेबल के जब आप फुट नोट में जाओगे तो लिखा होगा एक सेंटेंस बी के आगे, we downgraded one level for serious risk of bias, partly deviation from the intended intervention, selection of the reported result, missing information about the allocation concealment, one level for serious inconsistencies, one level for serious imprecision. ठीक है, तीन वर्ड्स लिखे हैं, लेकिन हम आज क्या पढ़ रहे हैं, सिर्फ रिस्क ऑफ बायस, ठीक, और ये ग्रेडिंग है. डॉक्टर हरदीप विल बी टेकिंग दैट लेक्चर ऑन द फाइनल डे इफ यू आर कमिंग ऑन फाइनल डे. फोर्थ डे काम करना है ना, अभी तो हाफ वे है. तो कमिंग टू पेज नंबर 50 ऑफ वैगनर्स स्टडी, वहां पे क्या लिखा है, रिस्क ऑफ बायस के बारे में लिखा है, असेसमेंट ऑफ रिस्क ऑफ बायस इन इंक्लूडेड स्टडीज. तो उन्होंने एक जनरल सा लिखा है कि रिस्क ऑफ बायस में हम क्या क्या करेंगे, एंड ओवरऑल रिस्क ऑफ बायस आउटकम में ये 120 डेज वाला जो है मोर्टेलिटी का उन्होंने लिखा हुआ है कि रिस्क ऑफ बायस टेबल फॉर एनालिसिस इज इन 1.2 टेबल, सब 1.2 अपेंडिक्स में जो टेबल होगी उसमें होगा. एंड ऑन पेज नंबर 157, उस पे आप ना भी जाओ तो कोई बात नहीं, यहाँ पे आप देख सकते हो, यू कैन सी है. तो रिस्क ऑफ बायस वो 1.2 जो वहां लिखा था तो सेक्शन में, वो एक्चुअल में यहाँ पे 157 पेज पे है. 1.2 ऑल कॉज मॉर्टेलिटी अप टू 120 डेज. इस स्टडीज इसमें क्वालिफाई हुई थी इस पर्टिकुलर आउटकम के लिए, फिडेलिटी फॉर जेरोनिमा एंड मुच. और इन तीन स्टडीज पे बायस को रेंडमाइजेशन वही 5 डोमेन्स पे देखा गया, और ये ओवरऑल रिस्क ऑफ बायस जो है वो से निकाला गया है. तो ये हो गया हमारा बेसलाइन जो मेटा एनालिसिस जो हुआ है, जो पेपर हुआ है उसमें. तो वी विल स्टार्ट बाय फिलिंग. अब आप फूल ओपन हो गए, तो यू हैव डाउनलोडेड द रिस्क ऑफ बायस टूल हो गए. यहाँ पे एडिटिंग इनेबल कर लो, और जिनका कहीं यहाँ पे आ गए हो आप लोग. खराब है क्या? क्या लेकिन तो यहाँ पे आ गया आरओबी 2 असेसमेंट फॉर्म. तो इनटू दिस विंडो, एक्सेल टूल खुल गया. टूल ओपन हो गया आप लोगों का. टूल में देयर आर डिफरेंट इंफॉर्मेशन व्हिच हैज टू बी टेकन हियर. एक्सेल था उसने फर्स्ट वाला जो आरओबी असेसमेंट, हाँ फॉर्म फर्स्ट वाला आरओबी असेसमेंट फॉर्म वाला. ठीक है, ठीक है ना, पॉपअप विंडो. So there is a pop-up window and बैकग्राउंड में एक एक्सेल राइट क्लिक करके भी देखो। अरे ना प्रॉपर्टीज, हाँ बस moving forward. So there are some pop-up window, there are different options. So first is assessment ID. तो हम यहाँ पे कोई भी जो भी स्टडीज है, अगर हम उसे कोई आईडी देते हैं तो उस आईडी को यहाँ पे फिल कर सकते हैं। Then is fill the name of assessor. So you can fill the name of assessor. आप कुछ कुछ लिखते भी चले जाओ, ये जो लिखा है वही कॉपी कर लो। You can write one, you can write assessor's name, then you can write study ID. तो हमने जैसे study ID डाल दी यहाँ पे। Study ID you can write study ID। study ID के बाद से फिर experimental and comparator groups। तो हमने लिख दिया systemic corticosteroid versus standard of care plus standard of care versus standard of care। दो ग्रुप्स थे हमारे पास। इंटरवेंशन का विंडो होगा विच आउटकम, ये है ना एक्सपेरिमेंटल और कंपेरेटर ग्रुप। स्टडी आईडी में आप कोई भी एक स्टडी आप मंच लिख दो। मंच वाला इजियर है, मैं पहले मंच का दिखा देता हूँ। स्टडी आईडी में मंच 2021 बाकी बाकी मंच 2021 स्टडी आईडी यू कैन फिल मंच 2021। इज इट विजिबल? यहाँ तक आगे हमने स्टडी आईडी डाल दी, कंपेयर एक्सपेरिमेंटल एंड कंपेरेटिव ग्रुप्स डाल दिए यहाँ पे। एक्सपेरिमेंटल यू कैन राइट सिस्टमिक कॉर्टिकोस्टेरॉइड्स प्लस एसओसी स्टैंडर्ड ऑफ केयर वर्सेस जो कंपेरेटर ग्रुप है वहां पे आप डाल सकते हो एसओसी। प्लस कॉर्टिकोस्टेरॉइड प्लस एसओसी जो है एक्सपेरिमेंटल ग्रुप है एंड कंट्रोल इज एसओसी प्लस पीएलयूएस यू कैन राइट पीएलयूएस। कंट्रोल कंपेरेटर ग्रुप जो है एसओसी। हो गया यहाँ तक? नेक्स्ट वी विल प्रोसीड विद फिल इन स्पेसिफाई व्हिच आउटकम, आउटकम का है कि रिजल्ट टू एसेस कौन सा आउटकम हम देख रहे हैं। तो ये आउटकम क्या है? ऑल कॉज मोर्टेलिटी अप टू 120 डेज। कैपिटल इज को ले लो। इंटरवेंशन में इंटेंशन टू ट्रीट अभी हम ले लेते हैं। और प्रोटोकॉल भी ले सकते हैं। तो यहाँ तक आपने भर दिया, इसके बाद से क्या होता है, वी हैव एडिशनल कॉलम ऑन द राइट साइड कि कहाँ से आपने ये इन्फॉर्मेशन आपने कहाँ कहाँ से ली हुई है। तो यू हैव अ फुल टेक्स्ट पीडीएफ, apart from that a particular article may be published as a conference abstract also, may be available on a author personal research gate also। तो अलग अलग जगह से लेने पे इंफॉर्मेशंस भी ऐड ऑन हो जाती हैं अलग अलग। किसी कॉन्फ्रेंस एब्स्ट्रैक्ट में हो सकता है उसने कोई और आउटकम दिखाया हो और डिटेल में दिखाया हो, कोई सप्लीमेंट्री टेबल दी हो। तो ये यू कैन सेलेक्ट वट एवर ऑप्शन यू आर सीइंग, मतलब जो जो आपने उस पर्टिकुलर आर्टिकल्स के डिफरेंट वर्जन्स या डिफरेंट फॉर्म्स को यूज किया है इंफॉर्मेशन लिए, यू कैन सेलेक्ट दिस, देन क्लिक एंड फिल वन बाय वन डोमेन 1 to 5। अब हम डोमेन्स वाइज जो है देखेंगे। तो फर्स्ट इज टू क्लिक ऑन डोमेन 1, ठीक है। तो डोमेन 1 में क्या है, सिग्नलिंग क्वेश्चन, दे आर 3 सिग्नलिंग क्वेश्चन। Was the allocation sequence random? है ना? आप कुंज की स्टडी खोल लीजिए। हाँ? नहीं फुल टेक्स्ट। यहाँ पे आपने सारी स्टडीज जो है, सारी स्टडीज को आपने वो कर लिया है, फुल टेक्स्ट में कर लिया है यहाँ इस पेज पे। तो हाँ मैं समझ स्टडी में फर्स्ट क्या देखना था हमें, डोमेन 1 इज रैंडमाइजेशन, रिगार्डिंग रैंडमाइजेशन। उस स्टडी जो है उसमें देखिए पेज नंबर 1423, 1423 पे कुछ लिखा हुआ है। ये लिखा हुआ है ना, randomization was performed according to a computer generated allocation sequence stratification variables trial site use of invasive mechanical ventilation age below 60-70 years and varying block sizes। ब्लॉक रेंडमाइजेशन टाइप का इन्होंने किया है सेंट्रलाइज कंप्यूटर। तो क्या लग रहा है, सही है रेंडमाइजेशन प्रोसेस, अच्छा है। तो यू कैन सेलेक्ट यस। नेक्स्ट क्वेश्चन वाज all the allocation sequence concealed until participants were enrolled and assigned to intervention। आर्टिकल में देखो, the allocation sequence was only known by the data manager at the CTO। तो allocation sequence concealment was also robust, ठीक से हुआ है। तो इसमें भी हो गया yes। Third is, did the baseline differences between intervention groups suggest a problem with the randomization process? थर्ड क्वेश्चन सिग्नलिंग क्वेश्चन जो डोमेन 1 में आता है वो क्या है कि दोनों ग्रुप्स के बीच में कोई बेसलाइन कैरेक्टरिस्टिक्स में कुछ प्रॉब्लम तो नहीं है। तो कहाँ पे मिलेगा इसका इंफॉर्मेशन, वेरी गुड, टेबल 1 यूजुअली बेसलाइन कैरेक्टरिस्टिक। तो पेज नंबर के बाद 25 ना, 5 और 26 पे था। बेसलाइन कैरेक्टरिस्टिक्स में तो दो ग्रुप्स हैं, हाइड्रोकॉर्टिसोन एंड प्लेसिबो ग्रुप। एक तो इसमें नंबर्स आप देख सकते हो कि जो नंबर्स हैं डिफरेंट डिफरेंट चीज के, और खासकर वो नंबर्स जो इम्पोर्टेंट है, जो इम्पोर्टेंट रोल प्ले कर रहे हैं। तो देयर इज और समटाइम्स क्या होता है, हेल्प मिल जाती है किसी में मैक्सिमम टेबल्स में पी वैल्यू भी निकली होती है, वेदर देयर इज अ सिग्निफिकेंट डिफरेंस बिटवीन दीस टू ग्रुप्स और नॉट। पी वैल्यू अगर सिग्निफिकेंट आ रहा है इसका मतलब वो डिफरेंस ज्यादा है। तो यू कैन सी दैट median age is 61 and 59, male sex 24 and 14, okay, and its median weight is 86 or 85। इचमिक हार्ट डिजीज है, कोमॉर्बिडिटीज इंपॉर्टेंट है, तो उसमें कोई डिफरेंस तो नहीं है। 1 hypertension 8 and 5, chronic pulmonary disease 5 and 2, diabetes 4 and 2। तो these number एक्चुअली परसेंटेज में होता तो ज्यादा अच्छा समझ में आता है, क्योंकि थोड़ा सा ग्रुप्स जो है, ये सॉरी ऑल पेशेंट्स में हो गए ये 2 2 2 3 5 3, तो ये सिमिलर है, इसमें बहुत ज्यादा डिफरेंस नहीं है। अगर वो दो जगह पे डिस्क्रिप्शन है, एक तो डिस्क्रिप्शन जहाँ टेक्स्ट होगा वहां पे भी ये इन्फॉर्मेशन कई सारे आर्टिकल्स में लिखा हुआ होगा, अगर नहीं भी लिखा है तो 1424 में है। अगर नहीं भी लिखा होगा तो इस टेबल से आप देख सकते हो, और नहीं तो इसमें एक लाइन लिखी होगी। ऑल एनालिसिस वाज डन इन द baseline data was यहाँ पे जहाँ पे कर्सर है, baseline data was presented descriptively in each group and in total and median with interquartile range for continuous variables and numbers with percentage for categorical variables, because the final sample size was substantially smaller than planned। फिर इसमें उन्होंने वो ये नहीं लिखा हुआ है कि डिफरेंसेस हैं कि नहीं है, यूजुअली लिखा होता है, नहीं तो आप टेबल से देख सकते हो। ओके, तो यू व्हाट यू विल सेलेक्ट करने के बाद से आप यहाँ पे एल्गोरिदम है, इसमें डिस्क्रिप्शन में भी एबीसी कुछ भी लिख दो यहाँ पे। वैसे डिस्क्रिप्शन में आपको आर्टिकल में जहाँ से इंफॉर्मेशन आपने कॉपी किया, लाइन कॉपी की, वो कॉपी पेस्ट कर सकते हो इसमें, ताकि आपके लिए वो रहे कि कहाँ से उठाया। एंड यू क्लिक हियर ऑन द एल्गोरिदम। Did baseline differences between intention groups suggest a problem with the randomization process? No. No आएगा। 1.3 में थोड़ा बहुत डिफरेंस तो होगा ही होगा, बिल्कुल सिमिलर ग्रुप्स तो नहीं मिलेंगे, अगर सिमिलर ग्रुप मिल गए तब तक प्रॉब्लम, वो उतना ज्यादा डिफरेंस नहीं होगा उसमें। और यूजुअली कहते हैं कि अगर 20 वेरिएबल्स अगर आप देख रहे हो और 20 वेरिएबल्स में अगर एक में ऐसा कुछ मिसमैच है, देन इट इज ओके। 20 वेरिएबल मैं ये मान के चल रहा हूँ इस टेबल में 20 वेरिएबल्स और वो जो एक आपने लिख किया वो गड़बड़ है थोड़ा सा, तब ओके मान लेते हैं, ठीक है। कैसा है, या एल्गोरिथम क्लिक करने पे क्या है, कलर ग्रीन आना चाहिए। Was the allocation sequence random? Yes. Was the allocation sequence concealed? Yes. Read base ये नो होगा, थर्ड वाला नो होगा, ऊपर के दोनों यस होंगे। हाँ लोड, हाँ येलो मतलब वो लाइट येलो आ रहा, लोड ऑल। हर आर्टिकल के रन आउट कौन के लेनी चाहिए। इसी लिखते हैं टाइम डिस्क्रिप्शन ए बी सी से कौन से वाले हैं, जिसके नीचे वाले इन्फॉर्मेशन में दिया आपने। कोई इन्फॉर्मेशन छूटी होगी तो वो कलर नहीं आ रहा होगा। तो डोमेन 1 is filled. Moving to domain 2. Yes, sir. You can save or you can move. Save and you can save and then move forward to domain 2. एक सेव का बटन है। domain 2. In domain 2, what are the questions? Participants aware of their assigned intervention during the interval. इसमें कितने questions हैं? इसमें 2.1 to 2.7 है, ठीक है? तो नहीं टेंटेटिव आंसर करना आसान है, आपको आर्टिकल में ढूंढना कैसे वो बताना है। पर्पस ये है आर्टिकल में कहाँ पे क्या चीज है, आप एक बार समझ जाओ तो फिर आर्टिकल में ढूंढ पाओगे। ठीक है, तो देयर आर 6-7 ऑप्शन। वर्ब आर यू इन डोमेन 2? डोमेन 2 में आप जो है पहला ऑप्शन पढ़ो, वर पार्टिसिपेंट्स अवेयर ऑफ देयर असाइन्ड इंटरवेंशन ड्यूरिंग द ट्रायल। द पार्टिसिपेंट पेशेंट जो है, ठीक है, वो अवेयर है अपने इंटरवेंशन के लिए। तो यहाँ पे कंसेप्ट आ गया ब्लाइंडिंग वाला। तो ब्लाइंडिंग वाले कंसेप्ट के लिए पेपर में which page number is this 1423 ब्लाइंडिंग वहां पे लिखा था, ब्लाइंडेड थे सब लोग। ब्लाइंडिंग वाले में लिखा है ना, लिखा है ना, तो यू कैन सेलेक्ट। No, then work here, carers and people delivering the intervention aware of participants assigned intervention during the नो हो गया, ठीक है। जब ये दोनों आपने नो सेलेक्ट कर दिया तो 2.3, 2.4, 2.5 ऑटोमेटिकली मास्क हो गए। बात है। Then the next question was an appropriate analysis used to estimate the effect of assignment to intervention। तो हम लोग mortality ले रहे हैं तो उसमें assessment वाले इस पे कोई इशू नहीं आएगा, तो इसमें हम yes कर देते हैं। And then click। तो क्या आ रहा है फिर से सामने सामने वो डिस्क्रिप्शन वाले में कुछ ए बी अल्फाबेट कुछ आप डालते रहे ना, तो फिर वो अनफिट रहेगा तो प्रॉब्लम करेगा। डिस्क्रिप्शन में कोई भी एक अल्फाबेट आप डाल दो, नंबर डाल दो। लाइट होगा वो। हाँ सेव कर दीजिए। Then you can move to domain 3. So in domain 3, the question is 3.1 is what data for this outcome available for all or nearly all participants randomized। तो यहाँ से जो एट्रिशन वाला इशू था कि पेशेंट जो है हमने तो ये थे लेकिन कुछ फॉलोअप से चले गए, वो सारे इश्यूज जो है ये डोमेन 3 पे कवर होते हैं। तो डोमेन 3 की इंफॉर्मेशन हमें कहाँ मिलेगी? पेज नंबर 1426 एंड 1428, 1426 and 1428। So we move to 14 पेज नंबर 1426। तो ये जो हमारा फिगर 1 है, यू कैन गो इनटू दिस फिगर 1 एंड यू कैन सी दैट टोटल कितने रैंडमाइज हुए थे पेशेंट? 30। एलोकेशन कितने हुए? 16 इन द हाइड्रोकोर्टिसोन कॉर्टिकोस्टेरॉइड ग्रुप एंड 14 इन द प्लेसिबो ग्रुप। फॉलो अप किया, लॉस टू फॉलो अप 0, लॉस टू फॉलो अप 0। तो इनके कोई भी पेशेंट लॉस्ट नहीं हुए हैं। एनालिसिस में कितने भी किया है, n इक्वल टू 16, n इक्वल टू 14, सेम पेशेंट्स गए, ठीक है, तो एक भी पेशेंट किसी ग्रुप से नहीं गए, तो इसलिए हमारा उसमें आंसर क्या होगा? यस, वो डाटा डेटा फॉर द आउटकम अवेलेबल फॉर, हम आउटकम देख रहे हैं क्या, जब सारे पेशेंट को इन्होंने लास्ट में एनालाइज किया है, कोई लॉस टू फॉलो अप नहीं है तो ठीक है, तो लो, फिर इसका भी क्या है, लो। नाउ कमिंग टू डोमेन, हाँ वो है, वो हो सकता है जो आप सोच रहे हो कि बिल्कुल कोई भी स्टडी करते हैं, एक दो तो लॉस टू फॉलो अप होते हैं, तो वो प्रॉब्लम है। तो आपको ऐसा लगता है कि ये प्रॉब्लम बहुत सारी जगह है, अब इसी पेपर में आपने और भी चीज़ों में देखा, तो आप एक बार क्लैरिफिकेशन भी ऑथर से पूछ लेते हो, नहीं तो आप नोट डाल लेते हो सकता है कि आपको लगे नहीं ये कुछ ज़्यादा अनरियलिस्टिक लग रहा है एंड आई विल नॉट एक्सेप्ट इट, इसीलिए एक ये रिसर्च जजमेंट का एक बॉक्स दिया हुआ है यहाँ पे। आपको लगता है आप इसमें लो आ रहा है, लेकिन आपको लगता है ये लो नहीं है, तो आप यहाँ रिमार्क डाल के उसमें लिख सकते हो ये प्रॉब्लम। हाँ, ये तो 1, 2, 3, 4 कम है और रीज़नेबल लिखा हुआ है। जैसे सर ने भी बताया कि उसमें लॉस टू फ़ॉलो अप है या कोई पेशेंट वहाँ से उसमें जो डिटेल है कि कितने पेशेंट जो है हमारे एल्गोरिदम में से हट गए, उनके रीज़न्स क्या-क्या हैं। अगर रीज़न्स ऐसे हैं कि अनट्रेसेबल है, तो अनट्रेसेबल में क्या है कि कोई ऐसी ड्रग दे रहे हैं जो मॉर्टेलिटी का रिस्क उसका है, हो सकता है। पेशेंट तो मर गया तो वो अनट्रेसेबल ही हो जाएगा। तो जो ड्रग ज़्यादा डेंजरस होगी उसमें जो पेशेंट मर जा रहा है वो तो हटता चला जा रहा है, उसके बारे में पता ही नहीं है। बट एनालिसिस के समय क्या होगा? यू विल गेट कि हाँ, इसमें ज़्यादा पेशेंट बचे और इसमें अपोज़िट आर्म में जो पेशेंट मरा नहीं लेकिन सीरियसली हील हो गया, वो उसमें जो है ज़्यादा सीरियसली पेशेंट्स आ रहे हैं। लेकिन उसका जो ज़्यादा डेंजरस आउटकम था, साइड इफ़ेक्ट था मरने वाला, वो पेशेंट लॉस्ट टू फ़ॉलो अप होके वो एनालिसिस में ही नहीं आया है। तो इसी तरह पर प्रोटोकॉल और इंटेंशन टू ट्रीट वाले के हिसाब से एनालिसिस करना भी इसलिए ज़रूरी हो जाता है। तो कमिंग टू डोमेन 4, डोमेन 4 इज़ अबाउट मेज़रमेंट्स और द मेथड ऑफ मेज़रिंग द आउटकम इनएप्रोप्रिएट। हमारे लिए आउटकम क्या है? ऑथेंटिक, तो उसको मेज़र करने का तो कोई अलग से कोई होता नहीं, इट इज़ एन एब्सोल्यूट, अगर चाहे वो क्लिनिशियन को पता चले या रिलेटिव बताएँ, वो एब्सोल्यूट है। तो और द मेथड ऑफ मेज़रिंग द आउटकम इनएप्रोप्रिएट होगा, ठीक है? Good measurement or assessment of the outcome have differed between intervention group। मॉर्टेलिटी तो दोनों ग्रुप में एक ही जैसे हम पता करेंगे। If no PN or NI to 4.1, 4.2, were outcome assessor aware of the intervention received by the study participant? अब ये इन्फॉर्मेशन हमें आर्टिकल में मिलेगी, हो सकता है वो। तो आउटकम असेसर को अगर नहीं इन्फॉर्मेशन है, तो वो कोई चीज़ इसमें अगर होती भी, आउटकम असेसर को पता भी होता कि ये इस ट्रायल में, इस ट्रायल में है, तब भी उससे कोई फ़र्क नहीं होता। अगर हम किसी का पेन स्केल मेज़र कर रहे हैं और हमें ये पता है कि इसको ये ड्रग मिल गई, उसको वो ड्रग मिल गई, तो हो सकता है कि वो बायस इंट्रोड्यूस हो जाए कि हम कहें कि नहीं ये ड्रग अच्छी है, तो हम उसमें स्केल के हिसाब से इम्प्रूवमेंट दिखा रहे हैं। लेकिन जो मर गया सो मर गया, उसमें तो कोई आप कुछ चीज़ कंपेयर नहीं कर सकते हो ना, एब्सोल्यूट आउटकम है वो। तो जब आप इन तीनों को नो सेलेक्ट करोगे देन द रिस्क ऑफ बायस विल बी लो, ओके? एंड कमिंग टू डोमेन 5, domain 5 is were the data that produced this result analyzed in accordance with a pre-specified analysis plan। तो यहाँ पे हमने पेज नंबर 1424 एंड 1428 पे जाना है। पेज नंबर मैंने साथ में पढ़ के फिर निकाले हैं। हाँ, and you can be more, फिर क्या कर सकते हैं, you can stop at that। तो दो दो पहला डोमेन 4 में हमें क्या देखना था? फिर 4 में 5 में था statistical analysis, है ना? So all analysis were done in the intention to treat population defined as all randomized participants for whom there were consent to use data. We had no missing outcome data. Yes, मिसिंग आउटकम डेटा है ही नहीं तो हमारे लिए इंटेंशन टू ट्रीट हो या पर प्रोटोकॉल में ज़्यादा फ़र्क नहीं पड़ेगा, ठीक है? So, work the data that produce this result analyzed in accordance with a pre-specified plan that were finalized for unblinded outcome data were available for analysis. तो हम इसे yes लिखेंगे, ठीक है? मल्टीपल फिर क्या ऑप्शन है मल्टीपल एलिजिबल आउटकम मेजरमेंट्स स्केल्स डेफिनेशन टाइम पॉइंट्स ऐसा तो कुछ नहीं था इस आउटकम को हम जो हम देख रहे हैं तो ऐसा कुछ भी नहीं था नो मल्टीपल एलिजिबल एनालिसिस ऑफ द डेटा हम इसको किसी और तरीके से एनालाइज कर सकते थे तो वैसा भी नहीं था तो हमने सबको नो सेलेक्ट कर लिया एंड देन रिस्क ऑफ बायस इज लो ठीक है देन यू गो फॉर ओवरऑल बायस एंड फिर से एल्गोरिथम पे क्लिक करोगे तो आपका हाँ नहीं तो उसमें कुछ इन्फॉर्मेशन जो डोमेन फिर फाइनल सेव नहीं किया होगा ना सेव नहीं किया होगा वो नहीं यार हाँ ठीक हाँ क्या पर ध्यान से तो नहीं है दोनों ही है यहाँ तो इसमें अगर असेसर जजमेंट अगर असेसर जजमेंट भी आप डालते जाना हर डोमेन के साथ में हाँ अगर नहीं आ रहा होगा तो असेसर जजमेंट किसी में छूट गया होगा ठीक है तो यहाँ तक तो हमारा ये हो गया ठीक है तो सेव कर दिया ठीक उसी से फिर सेकंड स्टडी का भरना है तो हमें क्या करना होगा यहाँ ऊपर से ये असेसमेंट आईडी से हाँ हाँ मैं बता रहा हूँ अगर दूसरी दूसरी स्टडी करनी है तो असेसमेंट आईडी से आप सेलेक्ट करोगे नया ये पेज आ जाएगा दूसरी स्टडी आप कर सकते हो तो इस पर्टिकुलर आउटकम के लिए हमें 3 स्टडीज को करना था ठीक है अब इसको आप सेव कर दो सेव करने के बाद इसे क्लोज कर दो हाँ हर एक पेपर से जो एलिजिबल पेपर्स हैं फॉर अ पर्टिकुलर आउटकम सेव करने के बाद से ये पीछे ये एक्सेल में भी ये डेटा इसमें लाइन से आ जाता है ठीक है जब आप पॉपअप विंडो क्लोज करोगे तो ये एक्सेल का बैकग्राउंड इसमें ये फर्स्ट लाइन में वो डेटा फिल हुआ होगा जो आपने भरा होगा ठीक है नीचे जब आप आओ नीचे जब आओगे तो रिजल्ट्स वाले के बगल में इंट्रो वाला ऑप्शन था ना तो वहां से आप हट में जा सकते हो यहाँ फिगर का एक ऑप्शन है फिगर के ऑप्शन को क्लिक करोगे तो आईटीटी मींस इंटेंशन टू ट्रीट अगर फॉर्म में आप कर रहे हो एनालिसिस तो इंटेंशन टू ट्रीट टाइप का फिगर बन जाएगा पर प्रोटोकॉल पे कर रहे हो तो पर प्रोटोकॉल हमने क्या डाटा बना था आईटीटी में इसलिए आईटीटी वाले में शो हो रहा है तो आपको एक लाइन वो 2021 वाली ग्राफ दिख रहा होगा फिगर क्लिक करने पे आ रहे हैं हाँ ठीक है तो दो और आर्टिकल्स हैं तो वो आप अपने आप फिल्टर करके एक आर्टिकल और देखना ठीक है सेकंड इज देयर इज अ टूल कॉल्ड रोवेज टूल जिसको बैच डॉट इन्फो पे जो गूगल पे वेबसाइट खोली थी ना आप जाओगे तो एक रोबिस टूल भी है। उस टूल से भी जो है आप फिगर जनरेट कर सकते हो। उसमें सिर्फ एक्सेल का जो डेटा है वो उसमें फेच करना होता है। ROBVIS टूल विजुअलाइजेशन, रोबिस विजुअलाइजेशन टूल। बेसिकली हमने रिस्क ऑफ बायस टूल यहाँ से डाउनलोड किया था, रिस्क ऑफ बायस डॉट इन्फो से। वहीं पे एक इसी वाले में सबसे लास्ट में ROBVIS टूल है, विजुअलाइजेशन टूल, रोबिस टूल। इसको क्लिक करके भी जो है आप फिगर जनरेट कर सकते हो, ठीक है। इसमें जैसे ये एक्सेल होती है, एक्सेल उसमें डेटा एक्सेल ऐसे एग्जाम्पल के फॉर्म में भी पड़ा होगा। उसको लेके आप उसमें वैल्यूज डाल दो। स्टडी 1 में जैसे है स्टडी 1 D1 D2 D3 D4 D5 ओवरऑल, ये टाइटल डाल के और स्टडी का जो लो और ये है ये आप डाल दो और उसको अपलोड कर दोगे तो वो कोई बात नहीं, ये मैं दिखा दे रहा हूँ क्योंकि टाइम शॉर्ट है। तो व्हाट विल हैपन, ROB2 ड्रॉप डाउन आप करोगे, ब्राउज बटन फॉर पुटिंग डेटा। डेटा का जो एक्सेल वाली फाइल है, जैसे मैंने सेव कर रखी है वो फाइल एक्सेल की, वो अपलोड होगी और इस तरह का एक फिगर जो है जनरेट हो जाएगा, ठीक है। ये फाइनल फिगर जो है वो इस तरह का बन जाएगा। आपने 3 स्टडीज दी तो इस तरह का एक बन जाएगा। अगर तीनों स्टडी दी तो ये पूरा ऐसे टेबल बन जाएगा। ये पेज है, ठीक है। फिर हमें आना है ये रो बेस्ड विजुअलाइजेशन टूल, ओके। फिर जो है रो बेस्ड विजुअलाइजेशन टूल में गो टू रो बेस्ड टूल आ गया है। और मिनट्स रिज्यूम, यहाँ पे इस पेज पे अपलोड और डेटा का ऑप्शन आ रहा है ना। तो जो एक्सेल आपने बनाई है ना, एक्सेल से मतलब एक्सेल की फाइल मैं दिखा दे दूंगा कैसे बनानी है। यहाँ पे यू कैन चूज अपलोड योर डेटा, चूज ROB 2.0, ठीक है। यहाँ पे ब्राउज द फाइल, हमने फाइल ब्राउज की। एंड मैंने कल रात में भी एक एक्सेल शीट शेयर की थी है ना, उसको आप यहाँ पे यूज करना। वो बेसिकली फील्ड डेटा है फॉर 3 स्टडीज। तो ये मैंने ROB2 ऑल 3 स्टडीज का डेटा यहाँ पे फिल कर दिया। ये स्टडीज आ गई मेरी, ठीक है। यहाँ पे लिख के आ गए सबके डिटेल्स। मैंने जनरेट प्लॉट पे क्लिक किया, ये बन के आ गया, ठीक है। अगर इसको मुझे सेव करना है तो मैं किसी भी फॉर्मेट में यहाँ से डाउनलोड कर सकता हूँ। और अगर ट्रैफिक लाइट फॉर्मेट में करना है, जैसे ये हो गया और ये इस तरह से बार ग्राफ में भी हो सकता है। ठीक है, इडेलिटी फॉर्म वाला जो स्टडी है उसमें भी हर जगह पे डोमेन 1 2 3 4 करके वो है टेक्स्ट बॉक्स यूज किया गया है। यू कैन गो एंड प्रैक्टिस। थोड़ा सा इंटरफेस का इशू है लेकिन अभी हो गया। When you have generated this figure, the work is done. ठीक है, तो रिस्क ऑफ बायस के लिए आपकी स्टडीज में एक पर्टिकुलर हर आउटकम के लिए आपको ऐसे फिगर्स बनाने पड़ेंगे और ये फिगर्स कहाँ यूज होंगे। अभी जब फॉरेस्ट और पढ़ाएंगे सर उसके अंदर ग्रेड के अंदर फिर वो फिगर्स जो है, जो पुराना वाला मॉड्यूल है उसमें फॉरेस्ट प्लॉट में ही आपने देखा होगा, आरओबी 1 में तो दिखाया होगा ना, उसमें फाइनली जब फॉरेस्ट प्लॉट जनरेट हुआ तो उसके बगल में जस्ट ऑफ बायस का एक ऐसे ही डॉट डॉट करके आ जाता है। तो वो जो होता है पर्टिकुलर स्टडीज के लिए होता है, लेकिन अभी इसमें क्या है, हर आउटकम के लिए वो वहां पे आ जाएगा। थोड़ा सा डिटेल फिर से ग्रेड में भी ये रिस्क ऑफ बायस जो है वो यूज होगा, तो फिर से थोड़ा सा रिवीजन होगा ऑन डे 5। ओके।
So, a very good late evening to all of you. 5 o'clock. It's not the right time to start this talk. Anyways, uh, I'll be brief and we'll through certain areas and we'll focus on very few key areas. Basically, all of you have read number of articles in your life, and all of you have written maybe a few articles. And since this is for systematic reviews and uh, networking analysis, and so I think in this process you would have come across various articles in your area of interest. That's one. Second thing is when you have already come across various articles, you will figure out that very broadly all articles are the same, right? Isn't it? But you really find articles different from each other. They're different in terms of numbers, some outcome measures, but essentially all articles are the same. If you look at from a distance, right, all forests look similar. When you go closer, you'll find some differences. So uh, it's always good. So I'll just share a few things where I feel that when I start writing, that's how it makes the process faster and more efficient. That is one. Uh, the slide set is there. The slide set is old. Dr. Hardeep has probably seen it earlier, and maybe some of you have seen it earlier. So I'll just leave you with some pointers, with some thoughts, how to make it more efficient. That's it. Essentially, it is about efficiency. The jacket is the same. It is like tailor sewing a new cloth, and he knows how the cloth has to be sewn, and he follows the same process every time. So every paper has same headings.
There is some variation here and there depending on if it's a basic science paper or a clinical science paper. But essentially, all papers have the same headache, and all papers will go through a similar framework. I'll skip a few things and about PICO and just move to one particular slide. That whenever I start writing a paper or anybody comes to me that okay, I have done this work, I always ask that person to draw their work on a piece of. This is something which really helps. And essentially, whatever you have done, if you can draw it on a piece of paper, it is really helpful. In epidemiology, these are known as causal diagrams or directed acyclic graphs, and we're not going to complicated terminology. But essentially speaking, we want you to know what are the two things you are really worried about in your article. So, in any epidemiological study or any study where there is any kind of comparison, there is always one exposure and there's always one key outcome. And often people struggle to find their key exposure and their key outcome in their study. So, what was your study all about? What was the key outcome you were interested in? You should be able to write that key outcome. Here, for instance, a key outcome is anxiety, and this is an empiric exercise. And you should be able to identify at least one key exposure. I know there will be many exposures, but you should be able to identify one key exposure you were interested in. And we will put that one exposure here and connect them with an arrow with a question mark in between. This is the question we want to ask. This is nothing but keywords drawn from your PICO. If you were able to write a PICO, and I'm sure that exercise would have happened, you will be able to write exposure, outcome, and connect them with a dotted line and a question mark. Once you have done that, identify all that which can probably affect your exposure and identify everything which can probably affect your outcome. This is not an easy exercise. This will require you to have subject matter, but ideally it should be done at the protocol level, but should be done at least at the writing of a paper level. We just want, or I just want to list out all the variables that ought to be there and all the variables which are actually there, which really matter for that exposure and outcome relationship. So essentially, there are number of other extraneous variables around I and E. So once we know our I and once we know our once we know our E exposure and once we know our O, which is outcome, then next thing is confounder. I know there has been some talk about bias and confounding, but it's good to identify these so that we know where we are and what means what. It's always better to at least identify one key exposure. You may think that 10 exposures are important. Still identify a key. It is like a hero of your movie. All other characters will revolve around. So that's one exercise I encourage everyone to do and to draw it on a piece of paper to understand myself and to understand. Once you have all the variables from the same diagram, just write one word in front of each. How did you actually measure that variable? It is important because all this information should be there in the manual. Whether that variable was a key variable or whether that variable was extraneous variable, whether that was a confounder or not a confounder, all variables should be listed upfront before you start writing. Because a major folly when published papers come for review are that there are a number of variables which are listed in the result section. They don't find a mention in the method section. So all variables which are there in the results, which will eventually be there in your table, should be there in the methods. And to ensure that it is really there, once you have written your PICO, list out all the variables. This will help you draw your dummy tables that come to later, which will also help you understand what this study is all about. This will also help you understand that all variables need to be mentioned somewhere. Once you have these variables, you will figure out that some of them come from questionnaires, some of them come from land records, some of them will come from a particular biological measure, some of them will come from a different subset. So, understanding your variables in question is important, and I usually know this. This is one part. I'll straight away move to sections. Paper is different from a thesis. Thesis we can go on at any length. If you figure out, you will find that papers are more or less structured. Structured papers help you focus your energies in a more structured manner. So we always start with an introduction. In fact, first paragraph of introduction I write is usually the third paragraph of introduction rather than first paragraph, and I'll tell you why. So there are different paragraphs, and there is a last paragraph of introduction. And if you start reading journal articles, and if you read third paragraph of introduction, that is actually the most informative part of introduction. And once you have third paragraph nailed out, you can go to previous two paragraphs. Third paragraph basically is how would the current study add to the existing knowledge, and what did you actually do? So the last sentence of the third paragraph is actually your research question. So if you have anatomy of paper, right, and you're looking at paper and you want to write it, we start our research with RQ. Last sentence of third paragraph, mostly all journals has your research question. And first two paragraphs are just for justification of that research. So once you have question right, and this question comes upfront at end of introduction, your subsequent sections become easy. So I usually start with third paragraph, that what is my study going to add and what is new, what I am asking, and what is the question I'm really asking. That goes in third paragraph. So whenever you go read more papers, just also read about the anatomy and just try to read last few sentences or last paragraph. It will give you clarity. Once your last paragraph is clear, you can move to justification of that. And in fact, papers are written in a reverse order. Your question comes in a third paragraph. A paragraph before that, second paragraph, is what we know and what we don't know. And first paragraph is introducing your broad area to lay audience. Because your paper may be anesthesiology paper, or your paper may be, say, a biochemistry paper, but it can go to any kind of a reviewer. The first paragraph of introduction is very broad introduction about what you wanted to do. Second is a very brief gist of your review of literature, what is known and what is not known in one paragraph. And it is a third paragraph of introduction, half paragraph of introduction, most important, which is essentially research question and why you want to study what you want to study. So if we start reading papers, we usually read a title and read abstract, and that's end of it. But my suggestion is don't read the abstract. Start with the paper. Start with last paragraph of introduction. That is most informative. And then when you don't understand something, move two paragraphs ahead. That will complete your introduction. Don't use more than 3 paragraphs in introduction. At most, you can go 4. That is a brief issue. As far as method section is concerned, a lot of discussion around method section happens. Again, it is a very structured section. The structured section is there in protocols. The structured section is there in paper. Again, there is only one dictum to writing a method section, that whatever is there in the results must have a mention in methods. So whatever you have analyzed, whatever you have measured, whatever you have collected, which you want to show off in your paper, should have a corresponding method to it. There's only one dictum. And many times this dictum fails because, we might have written methods long before and analyzed results much later, and few things come up in the results which are not there in the method. So that is the only issue which is of importance. As far as method section is concerned, which is more of a recipe, second idea of a method section is that anybody else can do your study by replicating it. All of us who are doing systematic reviews would be very closely reading the method section, because method section decides quality of a paper. It also decides whether your paper will go into a systematic review or not go into a systematic review, if pertinent details which are expected are there at all or not. Now, as far as method section are there, we have various checklists which help us determine, checklists like scope for observational studies, or checklists for trials, and checklists for cluster randomized trials, and so on and so forth. But whole idea is that it should be sufficiently detailed but sparkly, but sparing the nitty gritty. All variables and results must have a mention in the methods. And poor method section, if it is there, usually people will not move on to your result section, will not even. So I'll say this is the most important section to know what you. There are a number of manuscript flaw articles which say that essentially it is ambiguous method which lead to most rejections. So subsections of a method section: setting, where was it done? Sounds simple, but essentially it tells you if it is a community, if it is a outpatient or it's an inpatient, it's a tertiary care or a primary care or a secondary care. What is expected in this setting is a paragraph which usually gets missed from a method section. You would say that we perform this study in an outpatient clinic of a tertiary care hospital, but then what is expected there in that outpatient? If it is say ENT study that okay X number of patients visit this outpatient hospital every year, of which X Y proportion are of the subject of interest of that particular part. So what is expected in this setting is important. Keep in mind that you are writing any paper for an international audience. Everything is on internet. Anybody in the world can read it. So they will have no idea what is AIIMS and what is Bhopal. They will have no idea sometimes even what ENT is. But you will have to give them an idea that if it was done in a particular setting, in a particular level, what is usually expected at that level, and some idea of flavor which is there. Second is design, study design, and we have enough uh, thoughts around study design. Study design should come up front as a separate subsection in the method section. So we designed a longitudinal study, a case control study, cross-sectional study, experiment, or any other type of study to answer our research question. Uh, Usually, design is mentioned in a single sentence. Many journals look for an ethics statement after a design. That is, this design was approved by the executive committee with a reference number of that particular design. Ingredients. We have already listed our ingredients beforehand. Ingredients are participants. Participants are P of a people. What is important is that whenever you are writing inclusion and exclusion, you don't forget the consent process. Uh, Always think of that when you included or excluded, what was the screening process which you used and how efficient that screening process was. So this will go into participant. Uh, this slide I like to show every time because many a time I find same flaw even in review articles which come up for review. Remember that exclusion and inclusion are subsets of P. So if we say that we included all individuals above 18 years of age, then less than 18 is not an exclusion. Understood that that's an exclusion. So amongst those who included what was excluded, that is important. So as far as writing style is concerned, population based, we sometimes don't bother as far as hospital based studies are concerned. But at least which population we screen? We screened all individuals in an OPD if that was the case. Whatever was your inclusion, exclusion cannot be simply a reverse of inclusion. Reverse of inclusion was everything else in. So whatever you wanted to include, if you have to excluding something for some particular purpose, that is an exclusion criteria. So every person who satisfies the inclusion criteria but has something else to necessitate exclusion will be. So keep that tight because this is an error which happens many times in articles which come for review. If there are cases and controls, there should be separate inclusion as well as exclusion criteria for both cases and this is also part of the stroke guideline. Uh, Procedures, how was it done? So, logical order in which a study proceeded, variables, how were they collected, references of any standard techniques, and may use a figure or a diagram to represent sequence. Variables, how they were collected, we have already listed variables before you started writing. So, you should have a listing of variables. Ensure that all variables which you are going to use in results are mentioned here in study procedures and how they were collected. Anytime the study procedures is helpful and it moves in a logical order if you had more than one research question. If you had one research question, one set of procedures. But sometimes you will find that you have more than one research question. Sometimes you may have procedures for RQ1 and procedures for RQ2. This is also there in various grant submitting guidelines where you have objectives and you have to write methods specific to a particular objective, something that rarely happens or sometimes happens in a paper as well. General dictum is that one paper should focus on one RQ, and if you have multiple RQs, it should go to two different papers, but often we need to combine. It's always good to give a chart if your procedures are too complicated, that multiple things are happening at same point of time and there are multiple points of time where you're following up. It's always good to give some kind of a table or a chart like this. It's always good that this chart, which will usually come at the beginning of the result section, would have a reference in the method section itself, will give you a clarity what kind of things would happen as when you describe the same methods in the result section. Analysis part or the statistical analysis part includes certain things. And even if you may not know much about statistics, very broadly speaking, every statistical analysis section will tell you how you analyze it, what you analyze, what software you use, and what kind of distribution comparison you take. So these are certain sections or certain sentences which you will repeatedly find in statistical analysis. It's easy to determine from a published manuscript whether this manuscript has gone to a statistical author or not, because there will be two additional paragraphs if one of the authors is a statistician who will describe some special techniques and terminology is there. If a good articles or a high impact journal articles you're writing, one of the reviewers is often a statistical review. So even if you think that you have written it all, at least for this section, go to a person who has statistical knowledge and insight, because that person will add two good paragraphs about analysis section, which will really help the statistical reviewer understand your paper. Result section is actually also very structured, and there are certain folies we can avoid in a result section. One is first sentence of the result section ideally should start with the time period of the study. The study was done between 2022 and 2024, something like that. Many times you will find that when you get articles for systematic review for a review, you will find that you have read the entire article, you don't know in what year the study was actually performed. You would know that in which year it was published. So that is one information which is many times required whenever we go for reviews. Also a good information because it will help you understand the time frame and help others understand the time frame. There are typically not more than 3 tables and not more than 2 figures to any good article. More tables and figures are now relegated to supplementary appendix or additional information which is available only. So think of your tables as not more than 3, your figures as not more than 2. If you can squeeze everything in there and give still your message, that is better than having too many tables and too many. There are essentially result tables and result figures. So often result figures are a flowchart and any other key data you really want to show. And again, result tables are often baseline outcome and analysis data tables. So first sentence would be when it was performed. First paragraph is a demographic. Second is everything which is inside the table should not be there in the paragraph. If you have tables, table 1, table 2, and so on, it's always good that even before you analyze, you make a dummy table. Dummy table just has columns and just has rows and only variables written. Dummy table is important because you know which variables are baseline variables. You will put them in a baseline table. And suppose there was another comparison table, you would know what will go into dummy table 2. So make a dummy table. Don't make one table for one variable. You club with various characteristics to make one table about a statement you want to make. Suppose this particular table will have all these variables and all information would be there. One table should be self-contained. If you are using a particular measure such as mean or standard deviation or median or percentage, please indicate in the footnote of the table. So out of this table, once you have constructed a dummy table, what is the key information about the table you want to give? That key information will go into one first paragraph of the table, that there were total X number of variables A and B, and this is the key mean we want to give. Don't give every information of the table in the paragraph, only the pertinent. Typically, if you look at journal articles, you will find that every table has a corresponding paragraph. So if there is a table 1, there is one paragraph about summary of table 1, and the last sentence of that paragraph typically is that details of demographics are provided in table 1, something like that. Second advantage of having a dummy table is it's easy for you to understand statistics. When statisticians will give you output, they will give you a lot of output, and often you will not know what output actually goes in. If you have a dummy table in mind, and if you give it to a person to analyze, or even if you are analyzing it yourself, you really know which information comes in. What I usually do is I get an output, I print out the output separately, I print out the dummy table separately, fill out the numbers myself. Every time I'm filling out a number, it helps me understand what this variable is all about, to know which variable is really important and really making. So that much of paper, I find it better as compared to purely online system. Although now there are softwares where the result output is automatically converted into a table and your table will be ready. At least if you do that exercise, it will help you write the next section, which is a discussion section. Result section, other than 2 to 3 tables and 1 or 2 figures, is actually a section without any judgment. It's a section only about facts. So if 100 people have participated, you will say 100 people have participated. You're not making any judgment whether 100 is more or less. If mean age of participant was 75, you would simply state mean age of participant was 75. You are not making any judgment there whether they were old, too old, young, or less young. So result is facts. Result has no judgment. It is purely the numbers which you are getting, which we want to put in tables and figures, and we simply want to present these numbers without ascribing any quality to it. Discussion section is your section, where again, when I'm writing discussion section, I usually divide it into 6 and 7 paragraphs. These paragraphs help me decide what I'm going to write. Once I have written 7 paragraphs, I figure out, okay, do I really need an 8th one, and I'll add another one. Essentially, first paragraph of discussion is answer of last paragraph of introduction, who are interconnected. So you have already read last paragraph of introduction, which will have your research question. First paragraph of discussion should be answer to that. Second is, what do our results suggest in terms of what is the judgment of our results? Only one paragraph. That whether our population was different, our results were different, we found what others found, we found something else or different from what others found. You can spend paragraph 3 and 5 in comparing your results with serial studies and significance of that. Essentially, these paragraph 3 and 5, 3, 4, and 5 are just an extension of second paragraph of your introduction section. Remember, second paragraph of introduction section was a very brief summary of review literature. Third, fourth, and fifth paragraphs of your discussion are essentially an elaboration and comparing yours with theirs. Which pertinent study we really want to compare. Para 6, which often gets left out when full manuscript is there, strengths and limitation. We believe our strengths are many. Give 1 sentence to strength and give 4 sentences to limitation. If you have done that, the viewer who is reading your paper would have already identified your limitations. By the time reviewer comes to this paragraph, if he doesn't find these limitations, he'll be annoyed. So he or she, whoever the reviewer is, when they come to this paragraph, and if they are satisfied that all the limitations which they identified reading your paper are already identified by you, that person is happy. And your paper is more likely to go through. So never forget strengths and limitations. Remember, strength, 1 sentence, not more than 1. And limitation, you can add, but at least 3. So try to find at least 3 limitation and 1 strength. And that's a good ratio to move forward to. And last is conclusion. Conclusion is again nothing but answer of the third paragraph of introduction, which was there already in paragraph 1 of discussion, and conclusion is a broader statement out of this answer. So a very broader statement of where do you want to go now? That our findings are so important that they should be included in the guidelines, or these are preliminary findings of a small study we need to confirm, blah blah blah. So overall presentation slide, there are few take-ups and spend slightly more time in each of these sentences. These essentially come from presentation of Richard Smith. Richard Smith was editor of PMJ for a long period of time. He was an editor and we were writing when no Grammarly softwares were available. So there were particular things which are mentioned. It's important that when you write, and if you are using now grammar software or a language software, they will flag many of these things. But it is important that we try to inculcate these things in our writing. Firstly is, if there is a choice between a longer word and a shorter word, use a shorter word. If there is a choice between a short sentence and a long sentence, use short sentence. A sentence which has more than 20 words is a long sentence. Sentence which has less than 20 words is typically a short sentence. Short paragraphs. Paragraphs which are going more than 300 words are long paragraphs. Paragraphs which are between 250 and 300 words are short paragraphs. No jargon, fewer abbreviations. Ensure that use an abbreviation in your paper only when it has to be used at least more than thrice. If you have used an abbreviation in first paragraph and you figure out that abbreviation never figures out later, you delete that abbreviation and keep yours. Prefer nouns and verbs to adjectives and adverbs. Basically, avoid as many adjectives and adverbs. So you may say that, okay, our study was magnificent study. Avoid the word magnificent. If you did a study, be modest. Avoid similarly avoid adverbs. So R was a very large population. Avoid the word very. So your study was conducted in a large population. That is sufficient. Uh, Avoid figures of speeches and idioms. Don't start your article with a saying of a famous person. Doesn't help. Uh, Prefer active to passive. That is very important, and that's major flaw where many of us who are coming from South Asia suffer. Actually, all native languages are actually passive languages, but English, we prefer it to be an active language. So try to shift everything from passive to active. For example, this study was performed. This is a passive sentence. He performed this study is an active sentence. So try to move an active sentence means the person who actually does a particular thing comes up front and this person did this. Say, for example, laws were made in India. No, the lawmakers in India made laws. That's an active sentence. So similarly, please think every sentence. Now most software give you a highlight that this is an active or a passive sentence. Refer the concrete to the abstract. So again, give hard facts and give judgments in your discussion and give focus on hard facts. Avoid the double negative. So if your sentences are long, often they will become double negative. If your sentences are short, they will not be double negative. Last one, say, don't be too chatty about a particular aspect. You may believe that one property of a drug X is most important and you may be able to write 3 paragraphs out of it. But again, limit yourself, give pertinent facts in a limited number of sentences. By reading a paper, it should appear that the author is not too pleased with himself or herself. Author should be moderate or author should be neutral. Uh, don't use slang or be careful with the slang. Whenever you have written a particular sentence or paragraph, think and read through that paragraph again. And one good way to read and review your own paper is read it backwards. Start with conclusion section, the last sentence, and then move forward. As you are reading the last sentence in a different kind of a flow, just figure out whether certain words in that sentence are really required or not required. If they are not required, you can use a scalpel to remove it. Many notes should not be there. That's why the thought is that one paper, one research question, one answer is actually a good paper. If there are too many questions, too many answers, and too many comparisons, that's actually not a very good paper. If you want to add a color, just add a dash of color. So again, this is more British, but this is how most papers in English language are written. That you even if you have done, you feel that you have done a Nobel Prize winning discovery, you don't jump out of the tub like Archimedes did. So basically, that is that you remain where you are, remain modest, and give things in a true perspective. So this is very quick and very short, but going back to the last thing that when I look at papers, I often find that all papers are done in the same way, with the same anatomy, with same sections, and even what is there in paragraph 1 to 3 is also become similar. Probably because across the world, every editors they have got used to a particular style of writing, and they expect that style to be there in every paper. So this is brief, but I think most you can get when you start analyzing papers critically and trying to figure out which sentence is coming in which section of the paper. That will be it. So quick and brief. Thank you very much. Any quick questions or thoughts that could be good? Otherwise, this presentation has a right? Yes, sir. Thank-
Thank you, sir.
I hope it was a learning experience for all of us. So now I would request Professor Rajneesh Joshi, Dean Academics, to felicitate our esteemed keynote speakers, Professor Dr. Renat Datta.